ultrasound will take you later in the day.
But pain drive is less, and he doesn't have another topic to say.
So,
So maybe he must be skipping this.
ask him, sir, do you want to skip or do you want me to schedule your
He's
time?
coming, he's always listening.
विचारून घे.
Yeah.
We can keep you later. तुम्ही 2 तास 4 तासात टॉक तयार करा नाही इथे ना.
तुम्ही within 4 days मध्ये जाऊन येणार आहे का?
हो ना 4 days आहे. मला ऑगस्टला जायचं रिटर्न. डेट नवीन डेट दिली तिकडे काहीतरी. व्हॉट्सअपमध्ये चेक कर. व्हॉट्सअपमध्ये जा. वाय
14 to 17. नाही त्यांनी माझ्या ते इलेक्ट्रोलाइट दिलं होतं की
तो पण आला नाही. तो पण त्याच हॉटेलमध्ये.
हां
समजून जा.
before it or after this? Before? After, no?
ते आता हेच चालू करतील.
फर्स्ट त्यांचं करायचं
नाही पहिले
ते
डॉक्टर नमित निथरवालला सुरू करू. नमित
येऊन
नमित कोण
अगोदर येऊन चेक करून गेले.
कोण
त्यांचं नाव
नीरज जंटकला
हां
बडबड आहे.
Dr. Namit has to go early. So अपने
ये तो उनको
interchange
ले रहे हैं, उनको पहले ले रहे हैं. यू रेडी ना? तेरा लैपटॉप कनेक्ट कर ले. कनेक्ट योर लैपटॉप डॉक्टर नमित.
हॅलो सर एक मिनटं.
हाँ सर. हो सर. हाँ सर. ओके सर. नो इश्यू सर. थैंक यू सर. हो सर. हो सर. हो सर. रूम चेकआउट केलं तेवढं करा. सर्वांना आत पाठवू रे प्लीज. मला स्टार्ट करायचं आहे यार. हॉल खाली आहे. चलो गाइस प्लीज. डेलीगेट्स फैकल्टीज प्लीज कम इन. Our speaker is Dr. Namit Nitharwal. He is going to be speaking on ligamentum flavum. Is it a friend or a foe in UB? May I request for the chairpersons, Dr. Pangwang Hu and Dr. Riski, have they come? Or even I think they are also a little loose. Warfarat, can you please go on the stage and chair this session for me? Can you go on the stage and chair it for me, please? Dr. Pang, you're a chairperson. We're waiting to start. Dr. Pangwang Hu, आप stage पर बैठो. Shall we start? Please. उनका टॉक चालू कर दो प्लीज.
येस.
Good morning, all international and national faculty and delegates. Myself, Dr. Namit Nitaral from Jaipur. Thank you, Malcolm sir, and organizing committee to giving me this opportunity. Today's our topic is to ligamentum flammum is a friend or foe in UB. So, as you all know, I am not giving so much of detail because in all previous 2 days detail has been given. Unilateral biparietal UV technique is a minimal invasive procedure for spine surgery applied to conventional arthroscopic system for the treatment of spinal disease. As you all know, surgical setup like a patient maybe in general anesthesia or epidural in prone position, we require CR, radiolucent table and laptop. And in UV instrument, we can use our conventional arthroscopic 4 mm rigid arthroscope, 30 degree or 0 degree, 4.5 mm or 5.5 mm spherical bulb, radio frequency ablator, and some specialized UV instruments like tissue strapper, serial dilator, etc. And as you know, in UB, we initial steps to making portal. If you are standing on left side of the patient, then we should make cranial endoscopic portal and caudal instrument portal. And our target point should be at spinolaminar junction. If we don't make a proper portal in initial, then we struggle through whole procedure. So we should first confirm in AP and lateral to our position of dilators. And these are UB steps like making endoscopic portal first, then working portal, then do triangulation, and then creating working space, bleeding control by RF, and decompression discectomy, and further what do you want in this procedure. And I am describing ligamentum flammum. Ligamentum flammum is a short and broad elastic structure. This is made up of 80% of elastin tissue and 20% of collagen. Because of high content of elastin, this gives a tensile strength to our spine and giving yellow color. It's made up of in two layers. Superficial layer, this light fibrous structure, which 2.5 to 3.5 mm thickness, and it's attached to the ventral surface of cranial lamina to the dorsal surface of the caudal lamina and fused with interspinous ligament in midline. Deep ligamentum flammum relatively thin, connecting to the ventral lamina both proximally and distally, and ligamentum flavor covers approximately 50% of cephalic lamina at L1, L2 and up to 7% at level of L4, L5. In caudal lamina, ligamentum flavum covered 1 to 2 mm at L1, L2 to 5 to 6 mm at L5, S1. Laterally, the deep ligamentum flavum extends in the foramina, forming the posterior wall of the foramina. As you see, this is making the roof of the foramina. And at our initial days of learning in UB, we start decompression, but we leave the this part of ligamentum flavum. We decompress this central and this lateral recess, but we leave this hypertrophied part of ligamentum flavum at this foramina, and that may end up with patient having some pain after decompression surgery. And in UB, we can take three approaches like interlaminar, contralateral, and paraspinal. In interlaminar, that most commonly used mainly for central and lateral recess stenosis. In this, we can do ipsilateral or bilateral decompression. First, ipsilateral laminectomy performed. We started at the spinolaminar junction. Then we do sublaminar decompression to decompress the contralateral lateral recess, and then do ipsilateral medial fascectomy to decompress the ipsilateral lateral recess. And after removing the flame, remaining work like central canal, bilateral lateral recess, and bilateral traction route can be made very effectively. In this picture, we are seeing in both side compression, in left edge well edge, right, and this MR showing central edge wedge bilateral lateral recess stenosis. And after UB, we can see that is right side, contralateral side, left side, ipsilateral side made completely free, and this MRI, the central edge well edge bilateral lateral recess made free. In this interlaminar approach, we standing on the left side of the patient, making a scopic portal on cranial side and working portal on caudal side. And in this image, we in the L5S1 left-sided extruded disc in this procedure. We did only ipsilateral side, making portal uh, on the left side and doing ipsilateral work and remove this fragment. We don't touch on the contralateral side. So, in advantage of UB, we should preserve as much as possible ligamentum flavum to prevent epidural fibrosis. And in contralateral approach, uh, first do sublaminar decompression through the interlaminar window. In this approach, we first should make the interlaminar window at the spinal laminar junction and then do all bone work from contralateral side, and then we should remove the ligamentum flavum. At advantage of this, we are staying on the opposite side and we can see as much as possible of the facet, so we can effectively preserve the facet. And in this approach, we don't touch on the ipsilateral side of facet joint, that should be preserved. In this picture, we are standing on the left side of the patient and compression is on the right side at this one. So in this, we don't touch on the left side, we just decompress the opposite side, that is right side, and made nerve root free. In this post-op-MRI picture, we taking entry from the left side and doing work on the only right side. And another is paraspinal approach, in which we take our incision lateral to the pedicle, and this is indicated for foraminal or extraforaminal stenosis. This is similar to Wills approach, which is used in conventional open surgery. Advantage of this, in this we use endoscopic endoscope, and we can avoid excessive tissue dissection, so which we can prevent the muscle damage, and this is ideal size for foraminal area at L5S1 level. You know, having high like rest, which can be issue in a transforaminal approach. And in this approach, the compression is at the foraminal level. So we made the incision on the same side, pathology on the left side, and we taking incision on the left side, lateral to the pedicle, and in this MRI picture showing foraminal stenosis. And we should, in this approach, we should first do work at the pars, then first do bony work, and then at last they remove the part of the ligament flavum, and we can make nerve root free. So in conclusion, take home message, first do all bony work first in this approach, and then separate separate the ligamentum flavum in midline, and then remove superficial layer and then a deep layer, and proceed from cranial to caudal in piecemeal manner, and then do remaining decompression with Caresian punch. If we first do flavectomy and then want to do bony work with birth, then may end up with either dural tear or neurological tapered. So my advice to learners, first to do all bony work with bar, then remove ligamentum flavum, and ligamentum flavum you should preserve as much as possible to prevent epidural fibrosis. So ligamentum flavum is friend in UB, not a foe, so we should preserve, and
Your
it
time
prevent
is up,
dural
Dr.
tears,
Namit.
prevent neural injury, reducing epidural bleeding. Okay, thank you.
Hurry up. Thank you. We thank you very much. Wonderful talk, wonderful explanation, and wonderful pictures. I'll request now the next speaker, Dr. Neeraj Jain, to come on the stage, please. I will introduce you Dr. Neeraj Jain. He is one of India's foremost pain specialists. He's an excellent person, excellent in transforaminal spine surgeries also. Dr. Neeraj, you have a 12 minutes window, so please maximize it, sir. है वहाँ बंदा बंदा ऊपर स्टेज पे ही है सर. सर 12 मिनट है, प्लीज उतनी में रहना प्लीज.
Trying to squeeze. Just connect this. Yeah, I'm there. Full size. Quick.
ओटी में क्या हो रहा है? कैन यू शो द ओटी प्लीज? पेशेंट पोजीशन क्या है? Can you ask for a feed from the OT? No, they're I think, inducing the patient. Yeah, show there for a second.
Okay. Done.
Audio
Switch, switch.
एक 10 सेकंडसाठी. Just 1 second, Dr. Neeraj Jain.
Sure.
वर दाखवणं यार, काय करता? This is our operation theater of our hospital. Patient is being induced right now. As we progress, we'll be switching over there. Dr. Neeraj Jain, you may please start. Show Dr. Neeraj Jain, please.
Good morning, friends. First of all, my compliments for a great congress, Dr. Malcolm and Professor Hassan. Well, thanks for calling me to share my work on pain management. It's so important to talk about pain management because that is what patient has come to you for. He doesn't know what is the actual problem inside, what is the pathology inside, is we diagnose and we treat it. But if we treat the pathology and we don't treat the symptom on the part of the patient, it is half-done job. So let's do a full job for the patient who has come to us for a relief. And that's the primary symptom of the patient many times. So there's no conflict of interest per se. Oh, you sorter, by the way. Now, pain, back pain has got many causes. Look at the MRI report. Multiple etiologies, multiple lesions. So each one of them or many of them could be reason for pain generator. You have to find the pain generator and treat it. It's not always the disc which is causing pain. We have to look at the other causes also, like posteriorly, facet, NSI. Anteriorly, it could be a disc disease. And now lately, vertebrogenic pain. It is more and more recognized, more and more authenticated, and more treated now. And we'll do something about it. We'll talk something about it. Well, there are times you have a multi-level disc disease. You know which one is the one which is really causing the problem. Here it is so obvious. But sometimes when you treat just this one, the other ones are still painful. This may be causing back pain, and this may be causing leg pain. And you have to treat the patient in total. It's a total pain relief you're looking at, and we have to treat them separately in their own right. We do discography at times for reason of knowing which one is which, and which really needs a right treatment, and what treatment, and how it is to be done. And that is to be looked at. This has become more and more imperative when we're doing a biologics lately. Believe me, 5 years down the line, there'll be less and less of surgeries and more biologics which will come in because we're going to prevent the disease. It's like cancer prevention versus cancer treatment. So we're going to prevent these diseases earlier than better, and especially in younger age group with the very bad lifestyle we are looking at these days. Yes, well, intermittent pain management can be pre-surgery or can be post-surgery also, because as I mentioned earlier, there'll be a patient sitting in the clinic who either doesn't want a surgery at all, or who has got a surgery done and still cribbing. So it's our duty to kind of give a relief to this patient. Now, the point is, this gentleman has got an open surgery. You can see a big scar in there, and there is a microdiscectomy done, this endoscopic discectomy done in there. Still look at the list and pain apart of patient barely walking. Is when hard luck changes. Professor Kulkarni showed a very good, Ramchandra showed a very good list of cases yesterday. A single case, by the way, lined up with so many surgeries. But these are known things, facts. And let's believe it, let's do it, and let's kind of try to justify from we don't have some heavy soul with us, you know, that way. So spine injections, definitely it is a precursor or to the surgeries, but sometimes it falls after surgery, I mentioned, and is going more and more. Done effectively, they are a very good relief to the patient. A very good surgery has supplemented with a very good pain relief or procedure is the 100% cure for so many patients. Another such patient, look at the multiple disc disease like this patient has got. You're not going to open all 4 of them, by the way. I know everybody, even Professor Malcolm and all will believe, not all it to be open. And another one, a patient who has got a black disc in there, which obviously surgery is not the primary treatment for such patients, and a degenerated disc. Definitely, then we have other things coming in. This is the era of lesion invasiveness. getting more and more acceptance amongst the patient population. And what I do, I'll give you one very nice trick there. I do 5-in-1 technique. I take my needle in, my radiofrequency needle in there, put in the anterior disc first. I bend my needle by purpose and go in there, do my discography, be it with dye, be it with the LA with steroid, or be with the PRP later on for a therapeutic. But it becomes therapeutic thereafter, or methylene blue, or ozone. I've done thousands of ozone in my times, but lately less and less of them. PRP is more rampant now. And then I come back, turn my needle back in there in the posterior annulus there, and do my RF annular denervation, which is an important ingredient of all disc procedures to be done if you're not handle the annular pain. Disc is not painful structure. The pain is coming either from the annulus or from the vertebral body. So that is to be realized. And then when I come out, I'm in the lateral recess. In my lateral recess, I do my lateral recess procedure, be a neuroplasty, be a just block in there. Come out, if the patient has got a facet pathology in there, I take my needle, redirect my needle, bend needle into the facet joint, or do a facet denervation, facet RF. So this is 5-in-1, a combo total relief for patient. And this is if patient has got a multi-disc disease, and they don't merit surgery per se. At least what you can do is you can always do a PRP or biologics. People are coming with the stem cells now. This is a very good technique now. They have a machine lately, where they take the blood from there and take some stem cells out, small stem cells out. Rest of the blood is pulled back into this, like a dialysis, pulled back into the body, and only the cells are taken out, and those cells are used. Initially, they increase the number of cells by some methods, and those cells are used. So be ready with all this, because I've been to Cuba, Havana, and I saw all this right there, and they're using it. Yes, well, if not taken care, we had ozone, we have annuloplasty or bicoplasty, and we have obviously the manual or mechanical decompression of the disc fragments, or fragmentectomy for that matter, and obviously epiduroscopy is there. Well, hold the culprit from the neck. Large base disc, there's no way this can be better treated than a discectomy or endoscopic discectomy, and you have a big fragment, nothing else would work in such patient. So this is what is required in such patient, and 100% pain relief, obviously. And then you address see what happens when you remove a big fragment, there's going to be a disc collapse syndrome. So patient will have a secondary facet arthropathy, must address that. Annuloplasty is a must, platelet plug is there. We are making it all patients lately. We might use with the endoscope, or we do a PRP through a needle. When I do a needle procedure, I use PRP. When I do a scope procedure, I do with the plug. Now, well, this is, a flapping route is good. Always you want to see a dura flapping, but sometimes there are bigger holes, which is a reason of concern for pain or recurrence. And that is, I've devised a method there. I do a disc mesh plasty. I put my mesh in there. I fix it with the tucker, and my patients are doing very, very well. No recurrence I've seen. And obviously the pain is reduced. And I'm more confident, and I tell patient to walk around the very next week, because that always keeps the mesh in place. Well, we talked about the annular pain right there, and we talked about the RF and RF denervation, but there is a bigger component with the modic changes which is coming in chronic disc disease, and that is the sinovertebral nerve which is coming, basivertebral nerve which is coming in there and supplying the end plates, and that's the reason for the discogenic pain. There are very, very good articles which have shown the chronic disc disease has got a more neoinnervations and more of the end plate changes coming in there, and the inflammation, other things, and they're really bothering, and there are pro-inflammatory mediators already there, and they're bothering these patients. And obviously, patient is in pain. So it is realized in such patients, the anterior disc problem or anterior column pain is more common than the posterior column, which is the facet we're talking otherwise, and this is less often seen. So I think probably that needs more care, and that's what American Society of Pain and Neurosciences are doing it. They're doing a sinovertebral denervation or basivertebral denervation with the RF technique. And this is intracept procedure. Very good procedure, very relieving, and shown a very, very good results. We just have to do like a transpedicular, like vertebroplasty, put in those probes there, hard probes there, make space, and do denervation. And that is at the end of the procedure. This is how the lesions look like. These are the lesions which you look in the multiple. You can do it at multiple level, especially when the modic 1 and 2 changes. This is very, very helpful for those modic changes, which is painful, by the way. And this is the amount of relief they are getting. So almost, you see almost 90% patient get a relief between 50 to 100%. 72.6% they mentioned, which is more than that now. And 26% has got 100% relief in such patients, which we can't address otherwise. Do any disc procedures, these pains are not going to be addressed. And this is their protocol. Best practices now already is put in, formulated, and they are using it. When there is disc pain, especially the annular pain, We do annular denervation, I told you. But anterior disc pain is more of a sympathetic mediated. Now, that's why it's a vague, it's not localized. So we do a RF denervation of the rami complicantis, or sometimes we go anteriorly and do a simple lumbosectomy for the anterior discal pain. Now, new things which is there, new kid in the block which has been rampant now, and the one which was there already, there was a spinal cord stimulator for the radicular pain, which is more to do with the lead inside the spinal canal and for sensory fibers. Lately, what has come in is the reactivate, which is the mechanical pain of the muscle mechanical pain, which is restorative for the motor fibers, and leads are outside the canal, and they're placed next to the medial branches of the multifaceted muscle supplies, and this kinds of give a stimulus to multifaceted muscle. 30 minutes twice a day is good. This kind of takes care of all this pain, and this is a core strengthening, you can say. And now it's a counter of what we have been doing. We are doing a denervation. Now we are doing a reinnervation or muscle reinforcement, and this is how the leads are placed. You can see the leads are placed, this spinal cord stimulation lead again, and they're well anchored in there with these tanks, and the leads are there, and they're doing stimulation, and they found a very good result. So the RF of the facility is going away because we're doing reinforcement. Like knee, we do a quads exercises. Same thing is happening with the multifaceted reinforcement. Well, there are patients who have been beautifully surgeried, 6 open surgeries, 6 procedures, pain procedures, still in pain, and a misplaced screw. One can see a misplaced screw in there. So we're doing a spinal cord stimulators there, and this is what the patient is on the table. You do it under this, and we want to see a happy patient at the end of the procedure. That's what you and me, everybody's look for. DRGs come in there already, which is more for focal pain or monoradicular pain, especially for post-surgical scenarios. If there is a disc collapse syndrome which is coming, vertiflex, they're doing it. We are not doing it that often, and we're doing a reinforcement or a posterior column augmentation with the opening of the neural foramina, and that takes care of the pain problem. These are hybrid procedures, CM versus CM vis-a-vis or CM with addition to the ultrasound. We have a hybrid OT lately. We're not doing only CM guided, radiation is killing to us also. And that is what you can do all facet joint blocks, you can do just with the ultrasound. It's very, very effective, very nicely done. But if it comes to RF, I have to write needle placement at right places. Very, very helpful in post-surgical scenario because there's a transition syndrome. We have fixed all this. There's a more load shifting onto the adjacent level vertebra, adjacent disc disease we talked. We don't not talking about adjacent facet syndrome. So these are adjacent facet disease which comes in, and we have to address that. And that is why our lead has to be placed next to the median branch. You can see the lateral and the intermediate branch. The medial branch, which is supplying the facet joint, 2 levels for a single level. We do 2 denervations. And there are bigger lesions now with the cool RF, as well as the very good technological makeup is there. Somebody was asking me about the RF. This is the cool RF. Machine is costly, probe is costly. But we have tanks coming in with the same cost, and it can be used with a conventional machine, and it's a bigger lesion. So we are saving on cost with a better lesion. Same can be used for SI. We know we do lumbar work, but not to forget 15-20% of patients who have SI pathology. We do intra-articular injection, diagnostic come therapeutic with steroids, and then we go on with the radiofrequency ablation of these lesions. There may be a patient, 5% of them, a Bartoloti syndrome, more so symptomatic after the L5S1 procedure. So we go and address the Bartoloti or transition vertebra. When there's pseudoarthrosis, if you don't treat the pseudoarthrosis, patient can be for years to whether can be in pain. Obviously, neuroplasty is a golden procedure, post-surgery or pre-surgery for that matter, and we're doing with the spring-loaded catheters, but they really don't do very great in the bad adhesions. There we are using balloon neuroplasty. This is my own procedure. I presented in the World Congress also in South Korea. And that is how I put all through, transforaminal, caudal, via endoscope, through S1 foramina, and open up my places. This can take a pressure up to 30 atmosphere. We have to be more careful on not to cause injury. That's what you have to be smart at. Yes, epiduroscopy is there, and it becomes therapeutic, diagnostic and therapeutic if you have a laser in place, and you can really break away those adhesions need be. I always say teaching is the best way of learning. More you teach, more you train yourself first. So it's such a nice thing, and it's always good to share because after all, you want to leave a happier world and for the more trained world. And that's what we do, live workshops on patients, by the way. This time is on the patients. I do live workshops. And well, you do your healing touch and keep gifting smiles all over as far as possible. These are few patients. She was the foot drop, by the way. I've got a video of hers, foot drop, and she came totally recovered. Interlaminar procedure on
Sir,
this
thank
patient.
you. Your
Other
time is up,
procedures.
sir.
Bas
Please.
last, sir. Finish, sir. Thank you, my friend, and thank you, Professor Malcolm, for giving me time to share my work. Thank you, friends.
Thank you, sir. Yours was a very informative talk. A lot of new technologies brought on the screen. And definitely chronic pain is something which many spine surgeons need to learn and address. And you spoke of many things that come under the realm of spine, and that is where I feel that the streams of spine, neuro, ortho, and even pain management merge. Their job, especially on the frontiers of pain, is excellent. Thank you so much for this. We'll move to the next talk.
Pleasure, my friend. Pleasure. Thank you.
I now invite Dr. Kiran Jaiswal to start his talk.
Thank you. Good morning. Thank you, ESFI and Dr. Malcolm Pastanji and World Congress to give me an opportunity to present among you. It's just a small narration. Percutaneous endoscopic lumbar transfemoral, everybody knows since 3 days it's going on. With unilateral pedicle screw fixation, facet sparing, transcambine interbody fusion, little bit of kind of a debatable subject, but why, when, and who? Now, this is again one forward message before 20 years, or not 20, but it's 2012. That spine surgery is the third most common operative area, you know, because all of you are here dealing with 23 disc and 33 vertebrae. So the future of spinal surgery is minimal invasive, everybody knows. Spine endoscopic procedure will also be a value of those who recommend surgical, an alternative to standard operations. That was the dictation in that time. Now it's the first line of treatment for the spinal procedures or spinal surgeries. And who can do it? Everybody can do, those who are like learned and experienced. My introduction for this is the most common basic surgery of the spine degenerative diseases, everybody knows MIS, and in dynamic instability, misty leaf. The few patients are deprived of this. These are like geriatric issues and multiple comorbidities, osteoporosis, attendant issues for the activity of daily life in today's urban lifestyle. Social stigmas and threat for the spine surgeries, as few of the relative still bedridden after open or other surgeries. Might be pain pathology would be different, but these are the stigmas. So they can select under local endoscopic spine surgery very rapidly or easily rather than going for under GA. So the percutaneous endoscopic spine surgery not only offers the decompression but facilitates interbody fusion by cage placements via transcambine portal, the same portal from where we decompress. For that, to facilitate little bit of facetal work to be done. And pedicle screw fixation and bone cement augmentation if required, if osteoporotic. Cannulated fenestrated screws that can help us. See, this is an initial era of since 20 years. This is the field of vision, what we can get. And for that, we need to remove the bones, create a space. This is microendoscopic, again, endoscopy assisted, the same field, but your eyes are at the pathology, where here, your eyes are not at the pathology, upper one, almost we can say 1.5 feet above. So it's a direct eye on the pathology where you can address the pathology nicely, and then rest of the other work is mechanical work. This is full endoscopic where you can have at least 360 rotation and no bony work required at all, or else minimal, at least SAP work to facilitate into the disc or central and even contralateral pathology. You can choose the trajectory. This is just to orient. These are the workstations, what require. These are the instruments, endoscope, and this is fluid management where it's underwater medium. Hand instruments, these are the basic hand instruments required for. Now, you have to choose wisely the trajectory as per MSU classification, right? Grading 1, 2, 3 and zoning ABC. So these are the simplest form. If at all there is minimal degenerative listhesis in the older age, what is minimal? Not more than grade 1. If it is grade 1, we can accept it. Initially, we can offer them just to decompress. But it's significant like this 3AB and even C involvement. So this causes cauda equina. For that, many of the time you have to proceed with this decompression, as well as if listhesis is more than 1 or 1, we can fix unilaterally. There is no harm in single sitting. And why sparing opposite side? We all know ASD, adjacent segment disease, at the age of after 1 year, after 3 years, after 7 years, after 10 years down the line, for rigid fixation, all of your patients, averagely we can say 40 to 50%, they do represent with the adjacent segment disease. Here they can have advantage. What advantage? Again, you can fix opposite side when they come with after 3 or 5 or years, and under local anesthesia you can give opposite reconstruct. These are the classification where you have to address pathology. These are the trajectories all you are aware of. And these are the pathology and iceberg phenomenon. So there are inside out technique, outside in technique that you have to select. Here just you have to rim the pedicle for aminoplasty, and then you can facilitate the cage even approximately 12 to 14 mm size also with the serial dilatation, not directly docking, and with the proper sleeve inside. Same, we all are aware of Cambin's triangle. Today, I think since 3 days, Cambin's going on. And sometimes you can encounter anomalous nerve roots. So under local anesthesia, if you are performing, check it whether sensory, motor, or mix. If it is sensory, you can cut it out. Otherwise, no issue. You just retract it and proceed. This is endoscopic strategy. You can select what migrated fragment, up migrated, down migrated, right? High up and high down. So that wise, you can select the endoscopic strategy just pre and post of MRI migrations, and then full endoscopic transcambine. It's a just pedicle screw fixation, transcambine approach. Enter inside, put the cage with sleeve dilator. Some clinical trials reported that both bipedicular and unipedicular, and results are same. The one who says conclusion in meta-analysis, we found that the unilateral pedicle screw fixation in lumbar spine was effective as bilateral pedicle screw fixation. There are some stress fractures also, or that stress elements I can show you, and that stress studies also. This is second one. This also says with the balanced vertebral support using cage, unilateral pedicle screw fixation, satisfactory effect on the lumbar segment stability. So sometimes while you are doing both, what are the advantages? Lesser time, old age. Again, lesser time, less blood loss. Lesser time, immediate mobility. So this is third one. From the perspective biomechanical and unilateral pedicle screw is considered safe as and reliable implantation technique. So here, this is intact model where the stress sharing. This is unilateral and bilateral. This is in implant in situ, we can say. And this is the study that shows almost you can see equal, not that much. This is balanced, that intact model, and rest of the others are not more than that in range of motion, degree, pressure, stress. Right? Here again, stress of the intervertebral disc. Already we fixed it with facetal sparing. So that stress again reduces. This is stress distribution in unilateral and bilateral. Almost we can say there is no red line.
Kiran, you have 30 seconds. Please hurry up.
Sure, sure. It's about to finish. So again, this is stress on the screws and rod. Almost we can say, just on the flexion, it increases. So careful. This is what introduction. And my case study is again, right, of 20 initially, almost there are 2 having nerve root irritation and foot drop because of that case slider were not available properly. So we used to dock. And then due to Dr. Malcolm Pastanji, I'm thankful to him, that case slider, Cadilla, with the thinner 0.5 mm thickness, I can put up to 12, 14. So different sizes of Cadilla are available with the dilator. This is conclusion. Conclusion is what? Ultimately, less hospital stay. Everybody knows all are the benefits. Even blood supply, not more than 100 ml. 2 mops, not more than that, for pedicle screw. And that is half. No dural reported because it's a ventral to dura. We are proceeding.
Thank you. Thank
Thank
you
you,
very
sir.
much for a very informative talk. Anybody for a question? I think we'll take a question here.
Thank you.
Anybody would like a question? Or then we'll go ahead with the next talk. I think people are still tired from yesterday's party. Next speaker is Dr. Vaibhav Jain. Dr. Vaibhav Jain is a young, dynamic, upcoming endoscopic spine surgeon. He's learned UB technique. And he's progressing very fast in it. He is going to talk on short-term outcomes in UV lumbar decompression, in lumbar disc herniation, and lumbar canal stenosis. Baba, big topic. It's okay. It's okay. I just had a look at the theater. They have induced the patient, positioned the patient. So after a talk or two, when they're starting, we will go to the theater, okay? Unfortunately, our patient has a dual problem. I'll be sharing his PPT to you. He has a lumbar disc at L5S1, but he also has cervical myelopathy at C4-5 and C5-6. So because of that, he's hypertensive, and because of that, his induction has taken some time. So that is why the theater is running a little late. But we'll be doing both a lumbar UB and a cervical laminectomy and unilateral foraminotomy at 2 levels to free both the nerve roots that are jammed. I'll be sharing the images with you shortly. Dr. Vaibhav Jain, please start.
Thank you, sir. Good morning, everyone. I am Dr. Vaibhav Jain from GMC Bhopal. I am working as an assistant professor. First of all, I would like to thank for the organizing committee for inviting me to this very prestigious platform. So this is more of my study and my learning curve. We have been seeing from last 2 days. So why UB, I just run through the slide. It's where anatomy is very similar to microsurgery with advantage of more magnification and clearer view. It's safer than microsurgery, again with due to magnification. Surgical instruments which we routinely use for our open surgery can be used without limitations. Advantages of UB include a small incision, which causes less damage to the soft tissue, which leads to faster recovery, decreased blood loss, decreased infection rates, and if you get stuck, there is always a way out to be converted to open. And less hospital stay, which when patient goes back home, is very happy. This study was conducted at tertiary level teaching hospital, and 30 patients were included, in which 16 were male and 14 were female. In this, common age group was 31 to 40. However, second common was 46 to 50 years of age. Duration of surgery, this is more of my learning curve. Initially, I used to take more time for triangulation, for marking. With practice, the time decreases to around 1 to 2 hours for a single level. In this, we can see for back pain, the pre-op score, VAS score was around average 5, which decreased at the end of 3 months for 1 and 2. For leg pain, which was more severe than back pain, and most of the patient had around a VAS score of 8, which decreased to 1 and 2 after 3 months. Most of our patients were very satisfied, in which we have excellent MACNIP criteria with excellent for 63% and fair for 20% and good for 17%. When we come discuss about the spectrum of UB is very wide. You can do almost everything which you can do with the open surgery. For example, discectomy at all levels, cervical, thoracic, or lumbar level. Ipsilateral or contralateral decompression can be done. Fusion surgery in instability and spondylolisthesis and revision surgery, para-UB approach can be used. This is very important case selection. As my mentor has told me, I am quoting just like that. First, do simple level, single L4, L5 discectomy or L5S1. If you are comfortable with these, go for fusion surgery when you have done almost 50 cases, and cervical spine when you have done almost 100 cases of lumbar. Operative steps we have been discussed and seen in the morning. Making skin portal is very important. Triangulation is basically to, you need to see your instruments with a scope. Creating workspace, again, an important thing because we are not working in a joint, we are working in a span where we have to create a space. Bleeding control with RF or other methods. And once you have achieved this, rest of the steps are very similar to micro decompression. Skin portals, in the red solid line, vertical line is a marking a disc space, 1 to 1.5 centimeter away from is dotted yellow line is for medial pedicular line, and horizontal line is disc space. Upper one is scopic portal for scope and saline inflow. Lower one is working portal for working instruments and saline outflow. Triangulation is very important. It's similar to knee arthroscopy surgery. Scopic portal is for scope and saline inflow. Working portal, again, as I already said, surgical instrument and outflow. In open triangle, when your instruments and scope are very far away, you cannot see you cannot visualize your instruments. In early triangle, your scopes and instrument cross each other or bang with each other, and again the vision is a problem. In this another image, we can see the docking of instrument at the spinolaminar junction. UB is an art of water flow. We can see if a proper working space is created, we can see a good inflow and outflow. And I'm usually use a semicircular sleeve for making a chain to keep the port open. These are some of my cases. This is a left-sided UB for L4, L5 discectomy. These are one of my initial cases where I should have been using a retractor, which my mentor told. This is left side UB for right-sided disc. I did the UB over the top decompression and discectomy from the left side. L4, L5 biportal endoscopic decompression for, we can see the left side nerve root is properly decompressed. Right side is also properly visualized. Again, a simple L5 S1 discectomy from left side. A huge disc was removed, and patient has been explained that he might need a fusion surgery later on. All the surgeries have its own complication. UB also has its own sets of complication: headache, retinal bleeding, posterior neck pain, seizure. It's due to high hydrostatic pressure. I have in my study, till now, I have seen 2 cases of spondylodiscitis and 1 dural tear. This patient was with spondylodiscitis, managed conservatively, and he is doing good. Limitation of study is this very small sample size, only 30 patients, short duration of follow-up. We need to assess more to look for the future degeneration and instability. Conclusion, UB is safer than open surgery with better and magnified view. Endoscopic anatomic view is very similar to conventional open surgery with advantage of magnification, which leads to better adaptability to surgeons. So in future, UB along with other endoscopic techniques will be a standard treatment for all degenerative spinal disease. Take-home message for the young generation, for young colleagues is that every procedure has its own learning curve. We have our own complication. You'll have your own complication. Manage it and do it. Start doing it. That's the only way of learning. Thank you.
Thank you for a very wonderful talk. Dr. Vaibhav. Dr. Sharon Lopez, please.
Good morning. It's a pleasure to speak on this topic. There have been many advances in physiotherapy in past few years. We try to include this all in our rehab protocols to set goals and achieve them as soon as possible. We see patients pre-operatively. We assess them. We take a little history and set patients' baseline. We record their pain. We take the history, we take their pain, we record their body chart. We ask the symptoms and mark the symptoms on the body chart. We check the MMT uses Kendall's muscle grading scale. We check if patient has any neurological deficit pre-surgery. We check the ADLs using Barthel's index. We also counsel the patient pre-operatively. We give a brief history of the surgery, do's and don'ts post-surgery. We tell them importance of the exercise and following the instructions post-surgery. Once patient is gone for surgery and is come back, we'll see them post-operatively and we'll again assess them and compare their pre-surgery and post-surgery, VAS, pain, everything. If the patient has pain post-surgery, we'll start using cryotherapy and TENS. Cryotherapy and TENS may act as counter-irritant stimuli to close the gate of the noxious impulses at the spinal cord level. We help them to give possible comfortable positions and relieving pain. Example, sleeping on the sideline, putting a pillow in between. And we tell the nursing staff to use this position regular intervals. If patient has any neurological deficit, we start giving them stimulation and we also think of the orthosis. We follow the ERAS protocol, which states that we have to mobilize the patient as soon as possible. Once the patient's heavy-headedness is reduced, we'll mobilize the patient to sitting, standing, and progress accordingly. We do not tell them to do vigorous activity because rest is also important. But we do this so patient gets more confident and patient feels more comfortable. Routinely, a belt is not used because it's a sister surgery and not many muscles are involved in this. We give them walker. If the patient, we assess the patient pre-op and decide whether the patient will need a walker post-operatively. Regarding exercises, we have two phases, productive phases and advanced phases. In productive phases, it's 2 weeks for discectomy, and in fusion cases, it is 6 weeks. In productive phases, we will do only isometric exercises. We'll work on activation of transverse abdominis, gluteus muscle, etc. After 3 weeks, we'll work on the dynamic exercises. Initially, neural mobilization was neural stretching, placing patient at risk because stretching might irritate the nerve and cause more pain. So NDS came in picture. According to Michael Shacklock, nervous system is continuous structure. It has a natural ability to move and withstand mechanical forces that are generated by daily movement. It has primarily 3 functions: withstand tension, slide in the container, and compression. Tension, perineurium is the primary guardian against excessive tension and is effectively cabling in the peripheral nerves. It allows the peripheral nerve to withstand approx 18 to 22% of strain before failure. Sliding occurs in longitudinal and transverse direction and helps in distributing tension. Blood flow to the peripheral nerves is blocked at 18 to 15% of elongation. And last is compression. So when we have to rehab a patient and start neural gliding, we'll start with single-ended sliders, which then progress to double-ended sliders, and last tensioners. I have a small video on that. So we'll take this patient as having pain in the back and right proximal thigh. So the sliders will be distal. Sorry, this is a wrong video. Just a minute. Hey, band karo na.
Can you check the slides, please? जरा कोणाला हेल्प करायला पाठवा प्लीज वर. कोण आहे का वर?
Okay, so this is the starting thing. We'll slide the distal extremity. Okay. Once patient is comfortable in this range, then we do the double-ended sliders. And then the tensioner. So this is tensioner. Once patient is completely comfortable, then we will do tensioners. So we start with single-ended sliders, double-ended sliders, and then progress to tensioners depending upon the patient's symptoms. If it is a proximal symptom, we move distally. And if it is a distal symptom, we move proximal. Then regarding climbing stairs, we allow patient to do climbing stairs, but we do not ask them to do as an exercise. So if patient is staying on a duplex house where he has to climb stairs and go, we will teach the patient to climb stairs, but it was just once they can do. They can't keep on doing it as an exercise. In fixation cases, bending activities are started after 3 months, twisting after 6 months, and compound movements after 9 months. Rehab ends after achieving complete function. This concludes rehab from my side. Thank you for your kind attention, and I would like to thank the organizing committee, especially Dr. Malcolm Pistonji, to give me this opportunity. I would like to thank my work team for their support, especially Dr. Simon Michel. Thank you.
I'm going to request Dr. Dinesh to come and conclude his talk because he's missed his morning talk and come a little late. And then we'll move to the next section.
Good morning, ladies and gentlemen. I am Dr. Dinesh Patel. I am basically a neurosurgeon and belongs to Reba. Reba is a land of white tigers and famous for its waterfalls. I started my endoscopic journey last 7-8 years. Started with transforaminal. I started my endoscopic journey last 7-8 years, started with transforaminal surgeries, followed by PSLD, and now switch over to UB. For a neurosurgeon, UV is very simple and easy to learn. That is why I switched over to UB. Why UB? Because it's most innovative method of endoscopic spinal surgery and recently developed at a rapid pace. very vast indications similar to open surgery. Now let us talk about cervical UV. Indications of cervical UV are unilateral radiculopathy, foraminal disc, paracentral disc, and contraindications are central disc, segmental instability, severe kyphotic deformity, infections, tumor are relative contraindication. After some time, people may able to do tumor surgeries also. Patient operated under general anesthesia with hypotensive anesthesia. Position is prone, and positioning of the patient is very important in cervical UB. Neck should be flexed, upper back slanted down. It helps in maintains venous return and decrease bleeding during surgery. Shoulder should be tucked back. Skin marking, with the help of fluoroscopy, skin incisions are marked 2 centimeters apart, 0.5 centimeter in length. It may be horizontal or vertical, depending on your choice. One important thing for the imaging in cervical UV, which is very difficult because of overlapping of the upper and lower jaws during fluoroscopy. You should aware of the anatomy very precisely. Up to C5-6 level, AP fluoroscopy is very difficult. Only you have to rely on the lateral fluoroscopy. And below C5-6, you have to rely on AP imaging, and lateral imaging is very difficult. Even we are not able, sometimes we are not able to find spinous process in AP imaging in above C5-6 level. So we have to follow C7 spinous process and center point of the nuchal line, and then mark accordingly. After marking, we have to make skin incision, horizontal or vertical as you wish. Then gently put the dilator after cutting the fascia and feel the bone and confirm with lateral fluoroscopy. Similarly, put trocar and sheath in endoscopic portal very gently and feel the bone. Then make triangulation of both the portal instruments and to and fro movements cranially and caudally. After this, we land up over the laminas. Find the V point. V point is the junction between upper and lower lamina with facet joint. For a beginner, it is very important to find V point or V junction, because from here we have to start our work of drilling. Use 3 to 3.5 diamond drill and partial laminectomy, fascectomy as required for your case. You have to start with that. More than 50% of the facet joint, if you have removed, leads to instability, so avoid this. Drilling started. You can see the ligamentum flavum, yellow color. And in this video, drilling of the lamina. When you are doing cervical UV, laminectomy and fascectomy is very easy as compared to lumbar region, because it is very thin as compared to lumbar region. And finally, we have to do flavectomy with the help of Carrison punch number 2, number 3, number 1 as your comfort level. Finally, this picture, you see the dura, vessels running over it. Sometimes it's very challenging to find dura and nerve root for the beginner especially. These vessels help in identifying the dura and nerve root. Nerve root going laterally, vessels going laterally from the dura, you can confirm it, that is a nerve root. After this, we can go for dissectomy. Just gently pull the nerve root cranially and do dissectomy. Major complications of cervical UV are neurological deficit, monoparesis, quadriparesis, and catastrophic is death. Next is bleeding, but sometimes it is problematic, not very much. Take home message for the beginners. Cervical UV should not started by beginner until unless you are very confident in lumbar spine. Your hand should be stable, otherwise leads to major complications like monoparesis, quadriparesis, even death. Start with simple cases of foraminal stenosis, for which partial laminectomy, foraminectomy, and flavectomy suffice. And after few cases, when you are confident, switch over to discectomy. Choose patients which are thin and long neck, avoid short neck patients, otherwise complications are inevitable. Cervical UV is difficult but easy and simple. Why it is difficult? Because of your experience, because complications which are very massive, like quadriparesis and death. Why easy? After, if you did well, patients after 1 to 2 hours able to walk and talk, able to eat, he feels happy and going in 1 to 2 days back to home. Thank you.
Excellent talk, thank you, and great progress. Very proud of you.
Thank you.
Dinesh.
Any questions?
I think we'll move on to the next session. May I please invite the new chairpersons, Dr. Amit Thapa and Dr. Kiran Jaiswal, to take the stage. And may I please ask the next speaker, Dr. Yuddha Shakti, to get ready for his lecture. I think after that, we'll go to the theater because the patient is now he's been finally induced. And they've turned the patient, so because myelopathy and disc, high risk, so that was taking some time. जरा theater ला आपला आवाज जातोय का? Dr. Saisha, when you're ready, please let us know before you start. Before you start, please let us know, Dr. Saisha. Theater, can you hear me? Theater, can you hear me? Please let us know when you wash up and you're about to start. We'd like to see you doing the skin markings and the entry. In the meanwhile, Dr. Yuddha, can you please start with your talk?
Thank you very much, Dr. Malcolm. It's an honor. It's a big honor for us to be able to present here. It's a little bit hopefully interesting because we are trying to correlate between, I think all of us agree that alignment creates better function and also related with function. So my talk will be about the evaluation of our short experience regarding the spinopelvic parameters following lumbar endoscopy. But for these cases, we evaluate our uniportal experiences. So I'm from Indonesia. So the main thing about our treatment is lumbar disc herniation create problems. In a way, we know that in a way we are creating mechanical problem that relate with patient position. In that, the spinopelvic parameters also will change, in which also a lot of paper also showed that these parameters directly related with health, quality of life, dissatisfied patient, bad outcome. Therefore, although we are doing endoscopic surgery, this should be our parameter in evaluating whether our patient is good, whether our surgery is good or not. I think I've already shown you this case that we started with a patient with more or less non-aligned, non-balanced patient. And then after the surgery, subjectively, we can see that the patient is getting better in alignment. So why don't we measure this and make the spinopelvic parameter as one of the evaluated parameters after doing the surgery. So this is the basic, I think. Hopefully, us from orthopedics knows aptly told us that deformity is something fixed, but also something that is compensatory. So whenever you the patient, if the patients come in a deformity, usually the deformity is a compensatory mechanism in which the structural problem is less to be being stressed on that particular area. So the patient is deformed. And then the other basic fundament is the Dubuche system, in which if the patient is malaligned more in a compensatory condition, it will relate to higher energy expenditure, thus creating dissatisfied patient, bad outcome, and HRQOL that it's bad. So I think if we would like to say that our patient is getting better after our endoscopic surgery, I think we should show that it's also being goodly better evaluated by the spinopelvic parameters. So this is the basic. I think everybody knows the main thing is to put the head on top of the sacrum, more or less 5 centimeters from the sacrum. So that creates a stable, balanced spine and creating better function. So in this study, we'd like to show that lumbar lordosis, pelvic parameters is increase or decrease depends on our surgery, and then related with the patient's functional outcome also. First is the lumbar lordosis. We have limitation in which the evaluation should be a panoramic X-ray. However, what we can tell you that doing evaluation of spinopalmatic alone with lumbosacral standing X-ray is more or less enough to evaluate the spinopelvic parameters. And then what's interesting is most of our problem is between L4, S1. So if we treat those problem in which 70% of lumbar lordosis is based on this location, you are more or less helping the patient to be more balanced if you are treating L4 to S1 better or good in this way. So L4, S1 is crucial, and then your sagittal performance will be nice if you correct this problem nicely. The other thing is pelvic incidence. I think this is a stable, constant in which it relates with pelvic tilt and sacral slope, in which directly correlate with lumbar lordosis. All of us, I think, know when the patients have problem in the spine, lumbar disc herniation, they will have a loss of lordosis, in which in loss of lordosis, pelvic incidence will remain constant, but the pelvic tilt and sacral slope will more or less change. And then we also need to understand that we as Asians, in Asia, we have a lower pelvic tilt. Lower pelvic incidence by means of we have limited ability for the pelvis to retrovert, therefore creating, if we restore the lumbar lordosis, more or less the pelvic tilt and the sacral slope will realign there for related also with the good functional outcome. How about the pelvic tilt? Already being mentioned, pelvic tilt is the thing that's directly correlate with the SVA, spinal sagittal axis, in which if the pelvic tilt is more to the back, you are creating much problem. Usually it is between 5 to 20 degrees. That is our target. And then this is a good thing, the paradox of anterior compression of the lumbar disc herniation. Usually the resident always asks, if the problem is the anterior part, why is the patient have a loss of lordosis? Why don't they tend to bring the weight posteriorly? Actually, it resulted to the retroverted mechanism of the pelvis. Because of the retroverted contraction of the pelvic extensor, then it creates the loss of lordosis, thus brings the weight posteriorly to relieve the anterior or the disc pressure during the lumbar disc herniation. And the last thing is about the sacral slope, already being mentioned. The good thing is the pelvic incidence is PT plus SS. Therefore, if you are correcting the lumbar lordosis, the PT and SS will also correctly being in a good comparison, in which ideally the PT should be less than 50% of the PI, and SS should be do not exceed the 50% of the PI. It's quite confusing, but the main idea, I think, the last thing is the spinopelvic mismatch. As a deformity surgeon, this is the target, to create PILL less than 10 degrees. And if we evaluate nicely to our endoscopic patient, we will also have this. So the clinical application, I think we all know that. This is this is the what I'm trying to show you in this paper, the small box of the yellow one. Pre-surgery, usually patients have decreased lumbar lordosis, increased PT, and decreased SS because the patient is going backward of the retroverted pelvis. And in the post, you should have return LL, decreased PT, and increased SS. How about the result? So this is the method we evaluate in the standing X-ray of lumbosacral X-ray due to the limitation. And then we can see that after surgery, directly you can see that there are increase of lumbar lordosis and also related with increased PT and decreased SS. This is the first patient. The second patient, third, in which all of this shows if you relieve the symptomatic problem, in a way, we are also creating the realignment and returning the balance of the patients. So overall of this, only very, very short early study of evaluation of our patient, 18 patient per se, but we can see that the LL is corrected significantly by the red box. However, the PT, the pelvic tilt is not that much because we can see again that the Asian have smaller pelvic tilt. This discussion, I think, the same. A lot of studies shows the same. And as a conclusion, I think the most important thing is the lowest part of the point. Actually, as an endoscopic surgeon, we are doing deformity correction without having an implant. Thank you very much.
Thank you so much. May Dr. Punit Gulati to come on stage, please. I think as a teacher, I'm proud to say he is my first student. He honors me by being my student. Puneet, can you just hold on for a minute? Puneet?
Yes, sir.
Can you hold on for a minute? Huh?
Yes, sir. Sure.
We'll just go to the theater for 5 minutes. Hello, theater, can you hear us?
Hello. Yes, sir. Loud and clear.
Hello, theater,
Hello.
please put the theater on now. Hello.
Yeah.
Saisha, we are watching you. Can you please explain your skin markings?
So this is the midline which we marked. Shoot.
Okay.
This is the L5S1 right sided case.
Okay.
Shoot. I'm marking the medial pedicular line now. Shoot.
Suhail, can you do me a favor?
Shoot. Yeah. The lateral pedicular line. Shoot. And the disc level. Shoot. Shoot.
So midline, medial pedicular line, lateral pedicular line.
Shoot. Yeah. So for the disc herniation, the upper working portal
Okay.
is generally,
Can you show the C-arm view, please?
yes.
Make it a picture in picture and show us the C-arm, please.
Show the
C-arm dikhao.
Needle, spinal needle.
Can you show the C-arm images? Yeah, that's the AP. Okay, next C-arm image, please. Can you just run through the C-arm images? No, that's a scopic view. We want to see the C-arm image also.
I'll show you on here as well.
And then if Dr. Namit is there, please ask him to show us the MRI also for a minute, brief minute.
Yes, sir. Show the MRI.
Shoot.
This is a patient having 53 year
Namit
old.
रुको, पहले हम लोग C-arm देख रहे हैं.
Yes.
Okay, so this was your first shoot. Next.
Shoot.
Okay, this is the current shoot. Fine. Okay, so these are going to be approach entry points. Okay. Proximoscopic, lower is the, I believe, your working portal.
Working
Now,
portal.
next, can you show us where was your medial line and lateral line?
Yeah. This is the medial pedicular line. Shoot.
Okay. And now the lateral pedicular line.
Lateral pedicular. Shoot.
Okay, you're going to come over the top and do it? Or
No,
you're doing it from the right?
From the right. I'm putting it from the right.
Okay, doing it from the right. Okay, right-sided disc, right-sided patient. Can we have a look at the MRIs, please?
This one. That one.
Thank you. Shoot.
Can you zoom at the L5S1? I believe that's the pathology, correct?
Yes, sir. Yeah.
Shoot.
Okay. Okay, so it's a large disc.
Shoot.
Okay, this is the portal entry that you're taking. You're taking needle shoots or you're directly putting in the portal?
Yeah. I'm putting in the needle first.
Okay, it's a down migrated large L5S1 right-sided disc.
Yes, yes.
Okay, thank you so much.
So, shoot.
Okay.
Sir, patient having history of low back pain with right side radicular pain for last 5-6 months.
Okay.
Claudication time is 2 minutes and neurology power wise okay and having only hyperreflexia. So in this case, Dr. Seso planning to do right-sided UB and standing on the left side of the patient.
Okay, so he's doing a right-sided UB. Stand means he's doing it contralateral side.
Yeah,
say.
yeah, yes.
Okay, he's doing an over the top. Excellent.
Yes.
He's using a 2-needle marking technique
Shoot.
to define exactly his
Shoot.
points.
Shoot. Lateral.
Yeah, can you show the CM image of the needles, please?
CR image. That one. Yeah.
He's doing it.
CR image.
Give him time. CM image, please. जरा PIP मध्ये CM दाखवा ना यार. तर सांगा त्यांना करायला. आता पूर्ण हे आलं. मला PIP पाहिजे यार.
Okay.
Okay, he's triangulated the 2 needles. Excellent. Yeah, one more question. Yeah.
टेबल वर पाहिजे का?
Huh.
टेबल वर वर वर.
Squaring of end plates is definitely an advantage because then you are, what I do is I square the end plates, then I make the CM vertical again, and then I adjust the table so that my lamina becomes flat.
Yeah, we've adjusted
So
the
then
table.
when I'm working, it becomes easier.
We've adjusted the
We
table.
adjusted the tables.
Yeah, he's already adjusted. You can see that.
Yeah.
Shoot.
आता CM बंद करा मेन पिक्चर दाखवा चालेल नाही होत PIP तर
Exposure बड़ा.
कम्युनिकेट करा ना प्लीज
So,
Can you show the main picture please?
yeah.
Thank you. So obliged.
Yeah.
Done.
Now you can see in lateral that he is triangulated on the highest point of the facet. So his triangulation is pretty good. He should have a proper axis angle gliding in to do his work. Now he is going to be on the left side of the patient. He's doing a right-sided UB, so he's going contralaterally and doing it with a direct approach and a direct triangulation across the spinous process.
मेरे को ये फुट स्विच इधर ऊपर चाहिए. क्वार्टरी का.
Sarsha, we'll come back to you in about 10 minutes. We'll just finish Puneet's talk. He's on the mic.
Sure, we'll start then.
Puneet, you start your talk and we'll come back to the theater again after 10 minutes.
Okay, good morning everyone. First of all, a big thank you to Malcolm sir and the organizers for giving me this opportunity. Now, I'm talking on comparison of transforaminal and interlaminar spine endoscopy, my personal journey. Now, right away I would like to state this is a subjective comparison colored by my personal biases and experience. I started my endoscopic journey with Destendu. I have been trained in microdiscectomy during my residency, and though I did my fair share of Destendu, it was never a wow, this advances things kind of surgery for me. I could never see any significant advantage over microdiscectomy in Destendu. So I decided to learn full endoscopic spine surgery. Now, full endoscopic spine surgery is essentially transforaminal and interlaminar endoscopy. In transforaminal endoscopy, the discectomy is carried out with the scope entering through the intervertebral foramen, as you all know, or more accurately, the Camben's triangle. This is a posterolateral approach to the disc. In interlaminar endoscopy, the endoscopic access is through the interlaminar window, which may need to be enlarged by drilling of the lamina. This is a posterior midline approach to the disc. Now, I first learned transforaminal endoscopy. I think I did about 25, 30 odd cases. I was improving, but I hadn't reached the stage where I could confidently say, now this is the endpoint and there are no more fragments. Then Malcolm sir introduced me to interlaminar endoscopy, and something clicked here. This was something I was immediately comfortable with. It had most of the advantages of transforaminal, like minimal incision, excellent view, bloodless surgery under fluid medium, with the familiarity of the posterior midline approach. So now let's say you're a beginner. So what would be the learning curve like? What could you start with? Now, in my opinion, assuming you are a conventionally trained open spine surgeon, or even a surgeon doing performing MIS or tubular retractor surgeries, in this scenario, interlaminar approach is a low-hanging fruit. In interlaminar approach, essentially the tools change in comparison to open or MIS surgery. The basic approach and the anatomy remains the same. In transforaminal approach, the tools, approach, and anatomy all are new. So interlaminar significantly has a less steep learning curve for someone already doing open or MIS surgery. Now, endpoint of surgery, how do you identify that? The endpoint of surgery is clearly visible in interlaminar endoscopy in the form of direct visualization of the decompressed nerve roots, as we do in open surgery or MIS surgery. The endpoint of surgery is indirectly ascertained in transforaminal endoscopy by visualizing the flapping of the thecal sac and the movement with water column. Someone may argue that this drawback of transforaminal is for the inside-out approach and can be overcome somewhat, at least by using the outside-in approach. But then the outside-in approach is always anyways riskier for beginners. So there's a higher probability of a retained fragment with transforaminal endoscopy, particularly in your learning curve stage. Coming to L5-S1 discectomy. Now, L5-S1 transforaminal discectomy is a technically demanding procedure. Why? There are several obstructions in your way. Iliac crest, particularly in case of high iliac crest. The L5 transverse process could be an obstruction, the hypertrophic L5-S1 facet, the sacral ala. All these are obstructions in a pathway. You need to adjust the angle, and modifications are needed in technique. You either do a foraminoplasty or sometimes even a transiliac approach is needed. Particularly when you have high iliac crest, sometimes you have no option except to go transiliac. Now, transiliac approach is something I could never get my head around. I only tried it once, I think maybe twice, but it seemed too brutal to me. Though I believe transforaminal endoscopy to be slightly less invasive compared to interlaminar, but transiliac approach changes this equation in my opinion. Interlaminar approach to L5-S1 is a much gentler approach compared to going transiliac. So interlaminar endoscopic discectomy at L5-S1 is a much simpler procedure. The L5-S1 interlaminar window is largest. Very often, absolutely no drilling is required. You just dock and you begin your work. Many surgeons who have primarily do transforaminal, even they prefer L5-S1 interlaminar compared to transforaminal. Next, coming to lumbar stenosis. Now, stenosis is essentially of three types: foraminal stenosis, lateral recess stenosis, and central stenosis. We all know this. Now, foraminal stenosis, there is only one way to go about it. Transforaminal is the only way. You cannot access this by interlaminar. Lateral recess and central canal stenosis, this needs interlaminar stenoscopy, not accessible by transforaminal. Now, interlaminar endoscopy for stenosis is a very taxing surgery, at least for me, particularly when 2 or more levels are involved. Your shoulders are literally crying out by the end. In fact, my only motivation to learn UBE is stenosis surgery. I believe it will be significantly faster, though probably more invasive too. Now, anesthesia. Interlaminar endoscopy we generally do under GA. There is a small amount of muscle dissection still involved, shearing of ligamentum flavum, retracting the thecal sac, rotating the cannula. All of these cause pain. There are some case reports of people doing under this epidural or even under local, but at least I haven't tried it. I always do my cases under GA. Now, transfemoral endoscopic surgery, GA is never used, always done under local anesthesia or epidural analgesia. This enables nerve monitoring. I think some people, maybe Germans or somebody, I've read a few papers, they use GA for this with nerve monitoring. But then at least here in our country, I think it's always done at epidural. And this is a big advantage in elderly or those with significant comorbidities. I think most people are doing this under local, though I prefer epidural analgesia, not anesthesia. Somehow the patient is more comfortable. Coming to radiation exposure, now Intellamina wins this round hands down. Radiation exposure is significantly less in significantly more in transforaminal, particularly in the initial part of the learning curve, and more so when doing L5S1. I think this is something which is objective. Everybody would agree with this. Intellaminar often requires only a couple of C-arm shots. So now, which is less invasive? See, both are full endoscopic techniques, which are significantly less invasive compared to UBE or MIS tubular systems. However, intellaminar still requires some amount of muscle dissection, whereas transforaminal just requires some muscle splitting and dilatation. Some splitting or shearing of ligamentum flavum is there in intellaminar. Some drilling of lamina, particularly for levels above L5S1, is generally required in intellaminar approach. Like L3, L4, L2, L3 would require significantly more drilling. Transforaminal approach also requires some drilling of SAP and sometimes even pedicle when you're dealing with down migrated fragments. All said and done, both are less invasive, but transforaminal endoscopic surgery is the least invasive spine surgery out there. Coming to higher levels, as we go higher from L5S1 level, the amount of drilling in intellaminar approach increases and sometimes significantly increases, particularly when you have a small intellaminar window. Thoracic intellaminar approach requires significant drilling of lamina as well as SAP and is riskier compared to transforaminal approach. I don't think this is often done. For thoracic spine in L1, L2, transforaminal seems to be a better option. Now finally, which is better? Well, here the old cliched answer, whatever works in your hand, whatever is better in your hands, this is better. For me, at least now, presently it's intellaminar. Ideally, learn and master both. For most cases, you'll realize either of these techniques would work fine. But then you'll still come across cases where a particular approach offers advantages. So knowing both is definitely beneficial. Thank you.
Thank you, Dr. Puneet. Hello. Thank you, Dr. Puneet. Now we shift to the OT. Can you just connect to the OT? Hello, Saishav? Hello? Hello? Dr. Saishav? Hello? Hello?
Hello.
Dr. Saishav.
Dr. Bhupesh.
So we get
Yes.
back to you. Just explain us what we are doing and what you have done already.
This is our RF cautery from bones.
थोड़ा आवाज बढ़ाओ ना.
Plasma cautery.
Just so.
Yeah, so this is
कैमरामैन को बोलना जरा जूम आउट करने को थोड़ा. बैक पे से जूम आउट करो प्लीज. थोड़ा थिएटर दूर से दिखाओ.
Yes.
लोगों को पेशेंट देखना है. या कैन यू गो अहेड विद प्लीज नमित.
Yes.
So this is the bone.
Saishav, थोड़ा जोर से बोलो.
This is the bone.
Yeah, thank you.
L5 lower edge.
Yes.
Yes. I'm trying to find the edge.
Yeah.
Mostly this is the spinal laminar junction. I would like to confirm it on CM once I see it.
Okay.
This is the lamina of L5 lower edge.
Okay.
I'm using my cautery.
Okay. So one question. This is a larger internominal window. Still you like to drill it?
Yes, you know me.
Yeah.
What all do you like to drill so much?
I have a good drill here. I would like to drill more.
How do you find the plasma?
It's good, it's great. And the anesthetist is also very kind. I am not seeing a bleeder here, it's a single bleeder.
This patient is alive.
Yes, 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 yes.
We just talked that. Yeah, Siam.
Siam should. Yeah.
Yeah, now we can see the spinal minor junction, ligamentum flavum.
Height up.
Yeah, right.
I generally use those cannulas.
Can you just orient us endoscopic view, medial, lateral,
Yeah, so
superior and
this is
inferior?
the cranial end is towards the 9 o'clock.
Okay,
Caudal is 3 o'clock.
okay,
Medial is 6 o'clock.
okay. So here medial is 6 o'clock. because
Yeah,
he's
medial is
doing
6 o'clock.
from
I'm standing on my left side.
Left side and doing right side surgery.
Yes. Siam.
Up, please.
अरे अब करो अब करो अब करो टेबल को लग रहा है तो रुक जाओ हाँ दिखा दो अंदर आ जाओ आओ अंदर आओ अंदर आओ अब ये सर की तरफ जाओ हेड एंड बाजू जाओ जाओ हेड एंड बाजू यस शूट
Yes, shoot. This way.
अंदर आ जाओ थोड़ा
This way, please.
अंदर 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 सर की तरफ जाओ सर की तरफ थोड़ा
This.
हेड एंड
Here. Okay, please show the CR view.
head end. Mostly I should be at the spinal laminar junction. Head end पे जाओ ना भैया. बस बस बस. Shoot. Yes.
This view.
So I am at the spinal laminar junction. Just निकल जाओ तुम.
Just show us the Siam view.
Yeah. Please see the CR view.
निकल जाओ.
This one. Yes, sir. Visible.
Okay, yeah, this is perfectly at the spinal minor junction.
Bar.
So Dr. Sesov has approached the right way.
मामले ने ACL के लिए I generally use my right side and
So-
right.
So now you start drilling.
Yeah, I'm eating the soft tissue with the burr as well, creating my space.
Yeah.
ये मेरे को नहीं पता.
This is new technique, Sesov. Yeah.
हाँ लेफ्ट में दो ना मेरे को. Thank you.
Yeah, he is using a diamond tip burr. You
Yeah.
just see. So because with diamond tip burr, you can also.
I don't want a bleeder over there, so
Sesov
only
using
thing
the
there
full,
is lot
full
of
luxury
trust.
of this OT, plasma,
You need
diamond
a good,
bar,
water flow.
good anesthetist.
yeah, cautery.
A good surgeon needs everything good but himself.
Yes, yes, yes.
Good anesthetist, good OT, good instrument. But I should be good last in the priority.
Yes, yes.
The spinous process is quite big, as you can see in the CM.
So there is a difference between this plasma and normal radiofrequency ablation. The chairing is less in this plasma. The tissues chairing is very less or
Of late, we've all started using plasma rather than using normal bipolar.
yeah.
It's basically a bipolar current, but it has got a ceramic cap over it. So it creates a plasma shield as the cap heats up, and it dissolves the tissue only by 0.3 millimeters.
Yeah.
So you can work on a nerve root at low power setting of 1 and 2. You can actually walk on the root or the dura. You will not even get shrinkage of the dura.
Yeah.
So it is so safe to use it. It's so safe to handle with it. I use it as a dissector also at times.
So bring head started at the spinolaminar junction.
Sheshav, you just finished with the drill, and we finish one talk more.
Yeah, I'm going to do that.
Okay, sir. Okay.
And make this screen half, just on the corner. I would like to invite Dr. Karthik Kailash for his talk.
Yeah.
Lateral lumbar interbody fusion in degenerative spine disorder.
Hello. Hello, hello.
Hello.
I am introducing to you Dr. Karthik Kailash. He is one of the pioneers of spine surgery in India. He is one of the senior most spine surgeons of India. He is with Ramchandra University. He is a professor, and a great many students have benefited from him. It is genuinely our pleasure and privilege to have him on the dais today. Please give him a welcome. Thank you, sir.
Thank you, Professor Malcolm, for the warm welcome and having us over here. At the outset, I have to make a disclaimer that I have no idea about UBE. I've come here as a student and as a delegate to learn from Dr. Malcolm and the team. So that's my disclaimer here. Now, we talk about interbody fusions, which can be endolif or by olif. And one of the things which I fancy about is the lateral interbody fusions in degenerative listhesis as well as in other degenerative disorders of the spine. My affiliations, I had the university in Chennai, which is a 2,500 bed hospital. Madras, I'm also a professor at the IIT Madras for engineering designs. I happen to be the vice president of the Society for Minimally Invasive and the Chennai Ortho Spine Society. Now, a couple of x-rays here to go through. One is a 57-year-old laborer, low backache, bilateral leg pain with difficulty in walking, a typical scenario where you have a degenerative listhesis. I'm sure a lot of us will talk in terms of either an open TLIF or a MIS TLIF or any of these procedures. Now, when you look at the approaches, you could have an anterior approach, which could be an ALIF or an OLIF, which is anterior to psoas, or an ALIF, XLIF, TLIF, or PLIF. Any of these are there, and all of these are well known to us. Now, when you talk about minimally invasive surgery, a lot of debate has been going on in this. The correct term is probably minimal access surgery, and surgical technique is very similar. Only the surgical approach, the working channel differs, whether you use a tube, whether you use endoscope. The surgical approach is very, very similar. It's heavily instrument dependent when you're going on to narrower and narrow spheres. Now, the goal of the surgery is to do efficient target surgery with minimum iatrogenic trauma. Access surgery or target surgery can be minimally invasive, but surgery itself is never ever compromised. So what are the major principles used? Skin incision should be adequate size and cosmetic. Route to target, least traumatic, fast, collateral damage, negligible, repairable. And of course, the target exposure should be adequate, like what we're seeing here in the endoscopy. Treatment should be efficient without restricting us, and of course, there should be no trace that we have gone in and come out. So posterior or anterior, whichever one you choose, the techniques are the same. Now this is again another similar case, a leukodecation with the degenerative disc and the listhesis there. what we do. So we're going into looking at specifically the anterior, the anterolateral approaches for spine, which could be either of the A lifts, X lifts, or D lifts. Now, why would you want to choose an anterior approach as compared to the traditional approaches? Biomechanically, it's very clear that 80% of the work load is anterior, 20% of the load is posterior, and therefore, I think it's almost no brainer that you work anteriorly to restore what has been destroyed. Now, in degenerative disorders, you find that the whole shift happens and 40% of the mechanism goes backwards due to degeneration, leading into foraminal stenosis and, of course, the cascade. So, what are the advantages of the anterior? We have restoration of lordosis to place a larger implant, more graft, many open surgeries, less blood loss, no manipulation of muscles or nerves, decreased hospital stay, and, of course, an improved recovery. It could be a trans-psoas. When you say LLIF or lateral lumbar interbody, it could be a trans-psoas approach or extreme lateral approach, which is XLIF, or it could be a retroperitoneal, and it could be an oblique anterior psoas approach. Now, direct lateral or DLIF, as we call it, is a very simple approach, but it's got its own disadvantages in the lumbar plexus coming in the way, which means that we need to be using neuromonitoring, and it makes it more expensive and more difficult to do it. Now, when you go on to the anterior to the psoas approach, the OLIF approach is approach from the lateral aspect, is anterior to psoas, and can give access to L5S1 also. Now, the advantages mainly it avoids injury, away from the peritoneum and vasculature, preserves sympathetic plexus, and there's less of retrograde ejaculation when you do it in the males. The advantages could be that it could be performed from many levels, up to 3-level fusion can be done by a single 4-centimeter incision by wide sliding mirror technique. And of course, this increased surface area of the cage is 3 times more than the T-lift cage, makes it a more stable, better, and as compared to a T-lift cage. Now, in technique and positioning, you position on the right lateral side. You do not tilt the C-arm, tilt the table as what we learned just now again from today's OT. So tilt it till you get a orthogonal or a appropriate position. A small 5-centimeter oblique incision is made, finger dissection to identify the retroperitoneal space. Guide-wise, a place dilators are used. I have modified it by using just the Hohmann retractors to save cost as well as non-availability of retractors in some occasions. A discectomy is done, end plates are prepared, a trial is done, and implantation is done. So procedure basically works out to be a very simple, straightforward one once the anatomy is very clear. This is an example of the same patient where we've done OLIF. What I have done here is a modification. Instead of going posterior subsequent to this, through the same approach, I put an anterolateral screws like what we traditionally do for our old TB spines and trauma spines, saving the cost for us and also not using expensive cannulated screws. Has it got problems? Yes, all these problems are there. Thigh pain, hip flexion weakness, vascular injuries, and continental injuries are also documented. Thigh pain and hip weakness are there. How do you avoid them? You avoid the brake. Don't put a large brake on your kidney bridge on the operating table so that there's no strain. You flex the hips a bit, reduce retractor time every 20 minutes to half an hour, take the retractors out. I use preoperatively dexamethasone as well as pregabalin, especially on obese patients, so that my retraction time gets reduced, operating time gets reduced. Vascular injuries have been noted. Preoperative MRI assessment. Sit down with your radiologist if you have doubts to see where your vascular structures are, and make sure your operative window, the psoas to vascular window, is very high, and therefore you don't have a problem with this. So going on to some outcomes on these, we find that the OLIF has got very good outcomes. And this is one prime author, Kim et al. They looked at ODI, disc heights, bilateral foramen heights, segmental lordosis, fusion rates, and complications. And we found that the review showed that the LIF studies had fewer hospital stays, lesser blood loss, early return to activity, and improved sagittal profile. So comparative analysis, again with this, showed the fusion time to fusion was about 80% better as compared to the MIF TLIF, is about 52%. It achieved equivalent outcomes, although not, duration of time was not there. So many of the authors again looked at all these various studies and said that the OLIF has got a better outcome overall as compared to the MIS TLIF. So I'm not going about into the results, they're all available there. Now come to the last part of my lecture where some recommendations had to be given based on our literature as well as on our own experience. ALIF is the preferred method when you look at L5S1. And PLIF and TLIF are good for central canal stenosis and recurrent discs, while PLIF is a good thing for ischemic listhesis. OLIF is promising in this area, but not really very documented on this. I must say DLIF and XLIF are not suitable for L5S1. At the L45 level, PLIF and TLIF are good. ALIF, OLIF, all of them are good, but with a little bit of increased risk, especially if you're looking at ALIF. Other levels and multi-levels, ALIF is definitely not recommended, but OLIF and LIF are very good options. And deformity correction is better obtained at OLIF and in LIF as compared to a posterior. A combined procedure produces better outcomes. So key points why you want to go anterior and use the LLIF technique is complete discectomy, larger surface area fusion, larger graft placement, better end plate preparation, and the complications are minimal. Some suggestions again to my younger colleagues: do quite a few open anterior before going into the minimally invasive anterior. Never hesitate to get the help of vascular or CTVS or surgical colleague. Few cadaveric cases before doing one in the OR. Conversion to open is not a failure, remember that. And don't be brave about doing some heroic surgeries. Minimally invasive surgery is definitely doable. Produces excellent outcomes with blood loss, decreased hospital stay, and definitely decreased morbidity. Both techniques are useful. You must learn endoscopy as well as LIF, and I'm here to learn some of them too. Must learn well, choose the cases well for that procedure. Lastly, climb mountains not so the world can see you, but you can see more of the world. Thank you very much.
Thank you very much. Wonderful talk, sir. Really proud to have you with us. Any questions from the audience, please?
Hello, Dr. Seshav.
Yes.
Hello.
Yes.
Hello.
Hello.
Yes. Seshav,
we are
we are
audible?
again with you. Just explaining where have you reached now?
Hello.
Hello.
This
Yes,
is the
yes,
main
yes.
line. We are audible?
Yeah, you are audible.
Yeah. Now Sess is doing bony work using burring lamina.
Yeah.
हाँ, ये दूसरा yeah.
Moderator.
I'm using spherical bar.
Hello.
Yes.
I would like to call chairperson, Dr. Almar Mashida. You just and Dr. Pau. Leon Pau.
Before we start Dr. Kangtek Lim's talk, I'm going to request two stalwarts of spine endoscopy, Dr. Kangtek Lim and Dr. Pau, to come on the stage. Sir, please come here, please. 2 minutes later. To come here, please. I'm going to announce the names of a few faculty for whom I wish to give the memento. So, gentlemen, please come this side. Sir, please stand here, please, sir. May I ask Dr. Puneet Gulati to come on stage to take his memento? Dr. Dinesh. Dr. Sharon, if she's there, I think she's left. Dr. Kiran Jaiswal. Dr. Vaibhav Jain. Dr. Namit is in the OT, so keep it. And Dr. Neeraj Jain.
Dr. Neeraj Jain.
Dr. Puneet Gulati, please. Dr. Dinesh Patel, please. Dr. Kiran Jaiswal. Dr. Vaibhav Jain. And Dr. Neeraj Jain, please. I call upon Dr. Gazwan, Dr. Varun Agarwal, Dr. Janil Gurnani, Jaldi aao Janil. Dr. Janil Gurnani, Dr. Kailash Karthik, please. Dr. Yodha, Dr. Pangwang Hu, and Dr. Pompavit also, please, if he's there with us right now. एक minute, Dr. Kailash Karthik ka do na, please. Please, sir. Come, sir. Dr. Amit, come. Dr. Yodha. No injury, no? Okay. Dr. Pangwang Hu, please. Dr. Pampavit.
Are you okay?
I'm going to request Dr. Lim to give this to Dr. Pampavit. And master to the student. And to two brothers who are here on the stage today. Two brothers. Thank you. Please. Dr. Asrafi Rizki Gautam. Dr. Rizki Gautam, please. Asrafi, please. Namit nahi hai, Sharon nahi hai, rakh de baaju mein. Varun rakh de. Dr. Warfarot. Dr. Sutipas and Dr. Siok Bong Jung, please. Dr. Jung. It's okay, don't worry. We'll give you two. You can take two. And we take one from Dr. Pau on behalf of Sutipas. And if Sutipas comes again, we'll give him one more. No problem. Dr. Alonso Garcia, please. Dr. Jipin Gopi. Yeah. Smile, please. He is a UB man. He's receiving it one from a UB master. Alonso Garcia. Dr. Lim, one more student of yours. You are today giving all your students. Dr. Hayati is not with us right now. And I'm going to ask Dr. Lim to give it to another great person on this stage, Dr. Pau. Dr. Maxim, is he there? I think he's gone to the embassy. Okay. Dr. Harmantya, may I request you please? And Dr. Diego, Dr. Baipak, and Dr. Nantawat, please. My dear friend, Dr. Rodolfo, where are you? Dr. Baipak Paudel, he is the president of the Orthopedic Association of Nepal, and we are glad and honored to have him with us. Dr. Harmantya, it's our privilege to have you with us. A wonderful talk yesterday, sir. Where is my dear Nantawat? He's not here. Okay. Dr. Hadar and Dr. Dr. Hadar, are you there? Yeah. Sir, please. Dr. Rodolfo. Viva Mexica. Hadar, sir. Hadar. And the last, Dr. Hadar, please. I think we will now start with Dr. Lim's talk. I'm really sorry for this interruption, but thank you, sir. Sir, please be on the stage, sir. You're the chairperson here. Yeah, yeah, of this session. Huh? Dr. Elmer, please come on stage, sir.
Good morning, everyone. I will talk about very interesting theory. As you know, the spinal stenosis patient has the multiple level, multiple pathology. So we need to finish the 20 minute, less than 20 minute, one level bilateral decompression. So it's very important. It's a one level bilateral decompression 20 minutes, and for endoscopic HDF 1 hour, and one level the lumbar fusion TLIP is less than 2 hours. And some the patient have multiple level, right? If the patient have a lumbar 2, 3, 3, 4, 4, 5, 3 level spinal stenosis, we should reduce operation time. And then you can do the 3 level, the less than 1 hour. You can finish, right? But it's very important specification to be considered in ideal endoscopic system based on the physics. It's my talk today. It's the Homo endoscopicus. Oh, it's not working. It's not working. Excuse me. Okay, I'll try to. Okay. Okay, it's okay. Okay. So in Korean Neurosurgical Society introduced the minimally invasive endoscope surgery early 2000. So we use the first PLD transforaminal approach, but most of the patients have a spinal canal stenosis.
Dr. Lim,
right?
we have to fix the visual.
I'll try.
No.
Okay. Okay. It's a Homo endoscopicus. Oh, it's not working. Okay. Why? It's not working. Okay.
इसको क्या किया इसको एक्स्ट्रा कंट्रोल किया क्या किया
Duplicate. Okay. It's working. Yeah, it's working. Yes. Okay. So the Neurosurgical Society introduced endoscope system early 2000, the PLD. So, but most of the patients have the aging, the patient, so they have spinal canal stenosis, lateral stenosis. So just only the transforaminal approach for the discectomy was the incomplete operation, I thought. So, and after the discectomy, the 3 months later, with the too much the inside-out technique discectomy, have a patient have the decrease of disc height. So I thought it's the transforaminal endoscopy is incomplete operation already. That's why I made myself this the new endoscopy system and maximal system. Yes, so the principle of endoscopy system is you can make out the spinal canal, big spinal canal, or small the spinal tunnel, right? Where pass the bus in the narrow space in case of the patient have a radical path. It was my old before introduction of the endoscope system. I prepared this operation, but I have some junctional problem, and I have to more the extension of the fusion surgery, right? So it's we have to a lot of you can do about the spine surgery using endoscope system. It can be the cervical posterior decompression for the stenosis, and we can do anterior HDF endoscopically, and we can do high cervical region, C1 region, and thorax also posterior decompression, interbody fusion we can do, and lumbar posterior or foraminal decompression or transforaminal interbody fusion we can do. A lot of things, operation you can do endoscope surgery, and the more important thing is the endoscope system and instrument is very important, and the harmony the instrument, endoscope system and the camera system, irrigation, the monitor CRM, the operation table is very important to reduce the operation time. And about the endoscope system, the physical point to be considered for either endoscopy is very important. Size, the diameter, and the steel, the material, the water pressure, design channel durability also, right? And some instrument. And so it's a new endoscope system from the Maxmore. As use the shaft length is 130 millimeter. We can do the operation even the fat patient. And small, short endoscope system will guarantee durability. And inside the diameter is 8 millimeter outer, and inside the 5.4 millimeter working channel, we can use the 1 to 35 millimeter kerosene punch, and the gap between the range and the body, the sealed with the gold, has a high thermal conductivity and will guarantee durability and prevent the fogging during the operations. And the tips of the endoscope system should be made the right angle. It's very important, and we put the 10-degree lens angle because as the right angle, the tip of the endoscope, the tissue debris are easily discharging outward because the pressure input-output is the same. But the 45 degrees, the tip of endoscope, here, the tissue debris is very hard to get outside, right? It's very important, the design, right? So that's why the maximal system has right angle tip of the endoscope. And the 10-degree lens angle is very important. It's a spinal canal is a very narrow space, and you can watch the abdominal space very closely because endoscope system can observe the area directly below it well. So it's very the, good at the, compared to the wide angle, the range angle. This 10-degree range angle can see the all structure inside the narrow the abdominal canal space. And about, sorry. So 10-degree range angle has a good view of ipsilateral the area. So ipsilateral decompression with a minimum bone work of the facet joint is the 10-degree range angle is more advantageous than the more than 15-degree range angles. And you can watch it right below ligament flavum with a 10-degree range angle inspection the space on the ligament flavum to prevent dural injury. Very useful. And one of the advantages of uniportal endoscopes can be the working channel. We can turn the endoscope system, so working channel will close to the target point, like this. So in narrow space, we can see the ipsilateral and contralateral at the same time, very closely. So it's, for example, it's ipsilateral side, but when you turn the endoscope, we can the contralateral side more closely. It's the advantage of uniportal endoscope, right? And the size is very important, the working slip size, right? Working slip or endoscope system, the out diameter is the smaller is the very useful because most of the patients who suffered from the stenosis has a hypertrophic facet joint, so laminar space is very narrow. So if you want to use the bigger size the working channel or the working slip or the bigger size the endoscope system, the distance is in the narrow space of the lamina. The distance from the range to the dura is longer, and it's very difficult to close contact with the lamina. So, and we had to move the endosystem to see the opposite side with the contralateral approach. As a bigger size is very difficult to move on the lamina in narrow space. So the 8 millimeter diameter, the endosystem is better than the bigger size. And about the working slip angle is very important. So we use the bevel type the tip, but the maximal system is 23 the degree of the angle, the working slip. But most of the working company has a 45 degree the angle. So what different? It's a 45 degree the working slip will have a chance to break a facet joint with a sharp the tip. Right? And the muscle on the lamina comes inside through the gaps, so disturb the surgical view. So 23, the angle, the working slip is useful, better than the 45 degree, the working slip. And we use HD or 4K image resolution. It's just a strike. The camera system is very small and not heavy. So I think the two handle is very better than another company. And yes, the endoscope system looks like the video game. So first we should find the enemy without damage of abdominal anatomical structures. So and we can destroy the enemy. And with the endoscope system, as visible as many angle, we can get more information. So the 10-degree lens angle is very important. And one of the advantages of uniportal endoscope system can be regardless of right-hand or left-hand surgeon, depend on pathology and tropism, we can do all approach, ipsilateral approach, contralateral side approach, right? So regardless of a right-hand surgeon or left-hand surgeon, right? It's compared to the biportal, it's I think one of the advantages of a uniportal endo system. And we use a high-speed drill, only diamond drill. So for the lumbar, we use a 4 millimeter, and cervical 2 millimeter, yes, right? But you should use a two-end surgery also, right? Two-end surgery for the speed, the high-speed drill. And about the Kereson punch, I told about the shaft length is short, and the shorter length, we can use a shorter length of a punch will to guarantee the shorter the tooth force, right? Strong by the force Kereson punch can to quickly eliminate the target, like the alligate. And the system of the tip of the Kereson punch has 140 degree the angle and 10 millimeter the length. So we'll maintain not the 90 degree, right? It's 140 degree is good to maintain the appropriate the angle to SAP and rheumatic flavor. That's how we can finish the operation bilateral decompression less than 20 minutes, one level, right? And with 140 degree Kereson punch, you know very well this George Foreman, yeah, meticulous jab, right? Straight meticulous jab. It's we can do fine grained work with 140 degree, like this, right? We can remove the bony structure, any of the structure in the short time. So I think the 140 degree angle punch is very useful than right angle. It will reduce operation time. And yesterday, as I mentioned, two-hand surgery is very important to guarantee safety, right? So left the elbow will hold left hand on the patient's back, and we can use the instrument of Kereson punch, two-hand surgery, right? You can hold the left thumb, you can hold the Kereson punch. So cervical or thoracic is dangerous, very dangerous of the operation. So you can use a two-hand surgery if you will guarantee the safety, right? It's one of the advantages of the uniportal endoscopic system. And I have the right arm pain because I performed so many cases. So I will change the electronic punch in the near future, right? And so also I will change the endo system with the CMOS electronic endoscopy in the near future. About RF, the range for using the RF in abdominal space can be from the 40 to 90 degree. But I recommend just the maximum the temperature we can use in the short time is better. 1 second, right? 9 Celsius, and we can use the 1 second in short time is very useful. And I told about this yesterday. In case of the bone bleeding, we can compress with the Kereson punch to cancel this bone forming. You can stop the bleeding, bone bleeding, right? And I think you will worry about the water pressure, but you use the water pressure using the irrigation pump from the 40 millimeter mercury to the 80. But according to Bernoulli principle, so the first, the 40 millimeter mercury, the water pressure in the irrigation pump will pass the 10 millimeter the diameter the tube, but the endoscope, the diameter, final diameter can be the 2 millimeter diameter. So according to the Bernoulli principle, pressure is an inverse proportion to area. So it's not high, but the speed is high, but the pressure is not the high. So don't worry about the pressure. So we can use it from 40 millimeter mercury to 80 millimeter mercury, right? With the irrigation pump. It's a 40 millimeter mercury, right? You can see this pressure. And then, how is the 30 millimeter mercury? No effect, right? And 40 again. And 50 millimeter mercury. There was no any the problem that we related to the water pressure, because we use the water, the amount of water used for the 1 hour can be the 300 cc, but the uniportal system input output is almost same. So there is no any the tissue infiltration to muscle and fat tissue. I think it's one of the advantages of the uniportal system. There is no any the brain increase the cranial the pressure related to the water. Right? So in conclusion, the spinal endoscopic system must take into account the physical structure and the scientific theory, so as well as its convenience and the safety, because we are the Homo endoscopicus. Thank you.
Thank you very much, Dr. Im Kang-tek. If you have any questions, you can approach Dr. Im at the back, then you can ask your questions directly. Our next speaker is Dr. Hayati Aigun. He will talk about modified UBE approach in the degenerative cervical. All right. Dr. Masato Tanaka, are you ready? All right. So he will be talking about posterolateral MIS cervical pedicle screw fixation.
Hello.
Good morning. Masa from Japan. My topic is always a little bit different from yours. This topic is posterolateral MIS cervical pedicle screw fixation. Let me begin with this case. 82 years female, cervical OPLL. You can see cervical kyphosis as well. If you draw a K-line minus, this is an indication of anterior approach, I mean corpectomy. If you look at CAT scan, you can see double layer sign. This means the dura is also ossified. I'm an endoscope navigation guy, so I always use navigation. So if you use navigation, so inadequate decompression is not likely. You always figure out your location. And for this kind of double layer sign, you shouldn't remove the OPLL completely. So floating method is the best. Now I'm using the ultrasonic bone cutter, and then this OPLL is floating. And then for posterior PPS, cervical. So this my topic is this. This is the context of my talk. As you know, for posterior, we can put various kind of screw. However, C1 lateral mass screw sometimes hit the VA and carotid artery as well. So according to this paper, 2.8% is unacceptable position. This is the 4 major methods of C1 lateral mass screw replacement. Indian technique or Gower technique, he always said it is okay to cut C2 nerve root, but I think it's not okay. The patient always complains occipitality. So Tan's technique is a Chinese technique. It's a direct lamina insertion. This is very easy technique. However, as you know, the lamina is very thin. C1 lamina is very thin. So about 50% of cases, it is impossible to perform this. And if you do, sometimes lamina will break. And if you slip cranial side, it's a high risk of VA injury. That's why the golden standard is American system. It's a notching technique. You make a notch beneath the C1 lamina and make a form. However, Japanese technique is a new technique. So let me explain my technique, midpoint technique. Insertion point is a midpoint of lamina, and then use navigation. But navigation is necessary because you cannot touch the lateral mass directly. So you always use navigation. Another one is lateral mass screw is very popular for subaxial fixation. However, in Japan and some countries, so pedicule screw is very popular. It's mainly because the pull-out strength is about twice stronger than lateral mass screw. So in Japan, maybe almost all spine surgeons can perform pedicule screw fixation. So next topic is how to avoid intraoperative complication during posterior screw fixation. There are several complications. The severe one is a VA injury. Sometimes it's a fatal complication. Instrument failure and dural tear is the most common. Wound infection is a nuisance, and dysphagia or airway obstruction is very, very rare. Intraoperative VA injury is occurred in about 2.5% in subaxial spine. However, alternate axial part up to 20%. It's mainly because highlighting VA. For dorsal approach, the first and third part of VA is the highest risk. According to this paper, the highlighting VA is more than 30%. It's very high. That's why it used to be very major, this kind of transarticular screw fixation. We say Marger fixation. Entry point is lateral medial midpoint, 3 mm from the lower end. And in the axial plane, you should aim 10-degree medial. And then you shouldn't aim the posterior 1/3. It's located. You should aim posterior 1/3 because the VA is located in anterior parts. So according to this paper, so if you perform transarticular screw, it's 4.1% in unacceptable screw. It will hit the VA. Okay, the same, the C1 lateral mass is also. So mechanisms of VA injury is, number one is a muscle prevent correct screw angulation. even if you use navigation. Cervical vertebra will rotate, especially C12 area. It's very mobile. And sometimes if there is a fracture, it's very mobile. So let me explain our new technique. This is minimally invasive cervical pedicle screw fixation. We say MICEPS. So it's very similar to Welch approach in lumbar spine. Posterolateral approach, direct approach. If you perform this technique over time and blood loss, you can reduce dramatically. So our new technique is without CR, just navigation. We perform a comparative study, conventional one and MICEPS one. This is the video. Just 3 or 4 centimeter skin incision, bilateral approach. 2 surgeons do the simultaneous technique and then use navigated high-speed bar, navigated probe. Screw is also navigated, like this. If you look at the result, surgical time is very less. Blood loss is also very less. Most importantly, the screw angle. If you look at the screw angle, the MICEPS group is more horizontal because the muscle never disturb your angle. And screw breach rate is 0%. Another case, it's a metastatic tumor. We perform CM-free MICEPS technique for 4 level. If MIS technique is cooperated with navigation, there are several advantages. Less radiation, almost no radiation for the doctors, no guide wire. You can get a 3D image, especially the axial image is very important to put this pedicle screw. However, there are several disadvantages. Of course, cost effectiveness. It's an instrument and equipment are very expensive. Sometimes it will have a navigation error and also have a navigation learning curve. Take-home message of my talk is pedicle breach rate of this new technique is less than the conventional technique. Pedicle angle or pedicle screw angle of MICEPS group is more horizontal. CM-free technique is beneficial for both spine doctors because of less radiation risk. Thank you for your attention.
Thank you very much, Professor Masato Tanaka. 2 minutes. All right.
Hello. Dr. Saishav.
Can you see the things?
Yeah.
So
Can you explain what have you done?
Yeah, so the disc seemed to be hard. I had to hammer my pen field inside.
Okay.
So this is the space there.
So you finished with discectomy or yet to done?
Yeah, there we couldn't find a big large fragment there yet. We are searching one.
Okay.
So this is the, just a second, I'll clear the vision. Yes. So this is the root. Okay. This is the disc. We feel that we are into the axilla of the root, so we want to clear some more bone here. This seems to be the traversing root. This
okay.
So the disc per se didn't come out that large. It might be more chronic. It was more hard. यहाँ पे सब hard है medially.
Are you in the disc right now?
Yeah, this is
this.
Disc.
Is what
Yeah.
disc space?
Yeah, this is disc space.
Okay.
Oh, so I had to hammer this.
Yeah. Can you
place.
put the disc punch and just remove a few bites?
Yeah, I'll do that. I've done it many times right now. I'll show you just once.
Yeah, we have
So
removed lot of base.
you have searched for the down migrated fragment?
Yeah, hook.
Or you already removed?
No, we searched. We couldn't find one.
You are searching for that?
Yes, we are still searching that one.
Okay.
See, this is the hook. I've going down.
Yeah.
There are a few small fragments which are already
we have removed. Yeah,
but we couldn't find one big fragment.
Just retract with the now root.
Seshav, I think you're there on the fragment, but it's an old thing, so maybe it's pretty stuck. You'll have to explore that space there. You'll have to go a little lower and explore that.
The annulus there was hard.
I appreciate that, but you'll have to direct yourself a little downwards. Yes. I feel that is the fragment. Be careful, yeah.
Clear this root.
Or, no, it's okay. Enough.
Hook. Disc forceps. Straight. Straight छोटा वाला straight नहीं है क्या आपके पास? Disc forceps छोटा वाला सब एकदम छोटा वाला माइक्रो टाइप का एक आता है. बस 1 mm का दो ना.
Hello.
Yes.
I think you are on the disc migrated fragment only. Just remove it. It's coming in the bit. It's not in a single piece.
Yeah.
So there is a fragment. Yeah. Take one angular disc punch if you want.
Angular disc punch though.
Excellent, Seshav. Little more manipulation and I think the whole thing will come. Or you can use a hook to free it further in case you feel it's too tight. Yeah, it's going to be a skill rotating an angled thing there, but that's nice. Very nicely gone into position. Yeah, so let it slide into your mouth and then pick it up. Yeah, keep mobilizing it. It needs mobilization because obviously it's got a 6 months history of being there. So it's nicely plastered. But you are in that subligamentous space and I think that is where it is. You're mobilizing it well. A little patience on your part and I think you'll get it out. Yes, that's it, buddy. That's it.
Yes.
Wonderful mobilization. Excellent. Excellent, Seshav. Excellent. I think you should go for the disc punch now. Careful with that band.
Straight up. दूसरा वाला ना इसका मुंह थोड़ा टेढ़ा है.
Discourse. Yeah, this one. So in this case, Dr. Sesau have
Through our mobilization curve, we'll come back to you after our talk. Please go ahead and remove that fragment, okay?
Yes.
Gently mobilize with the hook. We'll start with Dr. Pangwang Hu. Can we have the auditorium mic, please? Seshav, your mic is on, so in case you feel like speaking something, let us know.
Okay.
Okay, back to the conference. The next speaker will be Pang Hoon Woo from Singapore. He's going to talk about the UB in the body fusion using the 3D printed cage. Should be very interesting.
Good morning, everyone. I'm from Pang Hong from Singapore. I've mentioned about my disclosure, where I work, so I will skip that. I think endoscopic fusion is also one of the quaternary steps of the benefit zone, where we have built up to perform for more complicated cases. In the background, I think we have been doing more and more MIS fusion to address spinal pain. People with lower back pain has been increasing, and spinal fusion using MIS can address a number of these issues. As we evolve in endoscopic technique from the discectomy that we have been observing just now, we slowly migrated to multi-level decompression and in the end multi-level fusion. So the road ahead also involved going to the scoliosis correction. And how we can achieve endoscopic fusion is through a few routes, interlaminar routes, the transcambin triangle routes, as well as that of the posterolateral route. These have been discussed in various talks in this forum, so I will not elaborate further. But in the Uniportal, we published a paper on this, and this is the figure. So there are problems with transcambin fusion, mainly in that of the exiting nerve root dysesthesia. And we have a various design, and you can see from the outside as well, some of the special cage glider that can try to avert that. And of course, in the Uniportal, we can also perform posterolateral facet remove completely, kind of interbody fusion, facet sacrificing fusion, which we have described in a various paper. So overall, the various paper from biportal and uniportal shows good clinical results, and the systematic review shows promising results as well. We have evolved in describing the technique in endoscopic surgery. The landmarks is very important. I think the landmarks mainly when you get a magnified view is to look for this particular paper we described, the Wu and Kim's point. Basically, we look for the superlateral edge and the more of the medial spinal laminar edge, and then we can completely resect the facet joint. And the UBE can reproduce this technique with great efficiency using the chisel rather than using the drill. And for the right side, I tend to make the incision, as you can see, a bit more caudal compared to the left side. I think in the lateral view, it's very important to see that working portal is directly in line with the end plate. Be it on the left side and the right side, the lateral view is very important to evaluate that. I've tried transverse incision and the vertical incision. I think if you do multi-level and scoliosis correction, I encourage using the vertical incision. But for cosmesis, if one level surgery, I think a transverse incision heals very nicely. So first we do a inferior articular facetectomy. In our series, when we do uniportal, we find that lateral to medial drilling is faster. In biportal, however, what I do is I will actually identify the medial and the lateral point, and then I just chisel across. There's also a new development of using ultrasound knife to do that, so you can make the facetectomy even more efficient. And then subsequently, the superior articular process facetectomy is dependent on what type of cage you want to insert. If you want to insert a huge cage, like an olive cage, then you have to do a complete SAP facetectomy. If that we are just planning for a T-leaf cage or P-leaf cages, then we can preserve the lateral third of the SAP. Why do we do that? Because there will be more bleeding if we resect all the SAP. And then that may impede the surgical time. In terms of decompression, we have done a paper in the Uniportal series and find that not all cases need to be bilaterally decompressed. But in UBE, nevertheless, I most of the time do a bilateral decompression over the top decompression. And we prepare the end plate till that we see a punctate bleeding. There are various instruments to do that, and Dr. Pao yesterday showed a very nice design of instruments as well. We can use pen. Generally, I use a pen feel, which is blunt, and then dissect the window between the end plate and the cartilage. So we try to denude and see punctate bleeding in this manner. And subsequently, then we insert the cage. There are some debate on banana cage versus a straight cage versus lordotic cage. Currently, I use small lordotic cage. I've tried expandable cages. I think expandable cages has this question on subsidence. So basically, I show just a case of right foraminal stenosis, grade 1 spondylolisthesis, quite a straightforward case. Let me see the video working or not. Play concurrently, so basically we can do a IAP facetectomy after we mark the lines. And then for the interest of time, I play concurrently. We mark the levels, and then I typically identify both visually as well as using radiologically the spinolaminar junction, so-called the Wu's point, and then the superlateral edge, which is the Kim's point, and then a chisel across for the inferior articular process facetectomy. You can also use a drill just to mark the decorticate area to your satisfaction before you do that. With the ultrasound knife, I think in the future, but of course that added cost, you can use the ultrasound knife, is even faster. So you can see a cutting burr marking it, and then basically using the chisel across. And then the SAP is pretty straightforward. You can either use a Kerrison, or you can use to start the marking and then use a chisel across. It's really entirely up to your preference. I think for the interest of time, I just move on. Then we can expose to this. I use a plastic cannula. I really like that, and that can protect the nerve roots. I watched Dr. Pao's technique yesterday using a protector and a needle that can actually medialize the nerve root. I think it's a very good technique as well. Just various preferences are different. And then let's see what, and then we can do the end plate preparation using typically just beginning with the Indian knife to mark the correct level. I think using the Indian knife, you can actually see the trajectory if you are just using a bullet cage or those bullet lordotic cages. So if you want to do a more XT lift, like larger cages, then you have to do more SAP resection, start your incision more laterally, and then again the Indian knife can direct the position of your eventual disc. Eventual cage. But if we are doing XT lift, then the Indian knife should point towards the contralateral pedicle rather than midline spinous process. But essentially, it's a choice of cages, and that's in consideration of the patient's bony osteoporotic status and what you want to achieve. I find those patients with large cages, then the lordosis in the L5S1, you can't put an 18-degree lordotic cage. So sometimes I would like to use actually just simple T-lift cages that can design up to 18-degree lordosis. So it depends on end plate, amount of end plate support you need, or that of the lordosis that you require. So these are the technical consideration, and then we tend to, I think the question about fusion, we need longer term data, but so far the early results are promising. We are involved in some of this research, and we show in our series 2 that is encouraging. And we have started doing some scoliosis correction, both in the uniportal and that of biportal. Personally, I like to do my biportal scoliosis with some lateral first for the rigid coronal deformity, and then the top and bottom I add with the endoscopic fusion with large lordotic cages. So these are some of the examples of the CT scan image. I see whether they play or not. Oh, sorry, it's rotate. Okay, in this computer, but essentially it shows that it's a nice looking cage that's across. We can point this medially, and then, or we can point it directly in just like a T-lift. And we find that in our cohort study, endoscopic fusion have a good preservation of muscle bulk, partly because we don't really dissect too much. Overall, I think we have shown that 3D printed cages with the essentially new design can allow better bone ingrowth and fusion rates. We have published that in Global Spine Journal, and the end plate preparation is very good in the endoscopic view. So the superior endoplate preparation is essentially what drives endoscopic fusion, not only so much so that it's MIS surgery. And then we have 3D printed cages. I use conduit, and then it shows in the retrieval study that it has good trabeculation that fuses through the cage. I think we use PIC cages, they tend to fuse around the cage, and when we use 3D printed cages, they fuse through the cage as well as around the cage. So I prefer 3D printed cages in most of the cases unless there is a cost concern. So in conclusion, I think there's many benefits in endoscopic surgery. We can actually control where the cage go through the planning of the incision. There's a flexibility of scope. We can do bilateral decompression, and there is a lot of potential in this, but longer term follow-up and larger clinical studies are required. Thank you very much.
Thank you very much, Dr. Pang-Hoon Woo. Our next speaker is...
we have a debate, I believe.
Hello.
Oh, Dr. Amit Thapa is there.
All right.
Hello.
Yeah, Saisha, we hear you.
Yeah, I think we are done.
Excellent. Can you just clean up that little mess over there? Those tags over there, if you can clean those up. And I think you've done a wonderful job. You've shown us the discal surface. We can see the back of the vertebral body.
Yeah, this is
and you have removed the fragment very nicely. So
this is inside the disc. This is
yeah. You got nice and lateral also. So it's wonderful. Absolutely wonderful. Just clean up and out. And I'll be joining you all in about 10, 15 minutes.
The flavor as well.
Yeah, excellent.
Thank you.
Any questions from audience?
Okay, now we go back to the lectures. Our next speaker, let's all welcome Dr. Amit Thapa from Nepal. He will be discussing hemostasis in UBE.
Respected chairpersons and dear friends, a very warm greetings from Nepali Society of Neurosurgeon. I am the current vice president of the society, and I would like to thank the organizing team, particularly Dr. Malcolm, for having me here. And I should actually bow to his efforts, relentless efforts from him and his team to bring all these stalwarts together. I feel this is the best place to learn about minimal invasive surgeries, tubular as well as endoscopy. Well, I bring here with a topic which I think is very relevant, not only for the beginners, but also for the experts, because I feel that surgery is nothing but training your reflexes. And if we have a checklist just like a WHO checklist for surgical safety as to what to be done for preventing a bleed as well as what to do at the time of bleeding, that's going to not only save your time of surgery, but also leads to a lot of complications avoidance, which I will be discussing in a few minutes. Well, I have nothing significant to disclose related to this presentation. So UBE is a bloodless surgery, and that's why the reason I actually took this surgery over the tubular surgeries, which I've been doing for the last 2 decades. The benefit is definitely of the hydrostatic pressure, which prevents the epidural venous bleed. The water as a medium washes off the blood, and that's why it provides a clean feel. But then what you need to remember that because of the vortex movement of the water inside the cavity which we have created, the platelets do not have enough time to clot the blood, as well as the blood is pushed inside the tissues, which causes the hindrance of the epidural bleed. So these are the caveats one must remember as to use of the irrigation when we are trying to control the bleeding. Now, why I choose this topic? I actually did a little research on the Google as well as in the PubMed as to what are the recent publications on the bleeding. And to my surprise, I didn't find any single publications of the bleeding. There were much more talk of the hidden blood loss, but then there was no talk on how much, what all procedures are actually recommended, and has there been any scientific publications on this particular thing. And this is every beginner's nightmare. We all know about it because blood absorbs light. It actually obliterates the vision because of this. And in the zest of trying to control the bleeding, we actually cause much more injury by inadvertent use of diathermy. Irrigations leads to hypervolemia and tissue edema. And also it prolongs the surgery, and at the end it frustrates the surgery, and that's why most of the surgeons, even after learning a very good technique, actually fails to use it in their practice regularly. So we should also know what bleeds. Now, when we talk of bleeding, there can be two categorizations, either a visible bleed or an invisible bleed. So the visible bleed actually is the excess-related bleed when we are trying to reach the space of sun. So there are bones, there are soft tissues. And it has been published in a literature by Go et al. That the amount of the bleed is actually depending upon the thickness of the muscle you need to access through to reach that space of zone. And of course, we all know about the vascular supply over the bone, and which are basically supplied by intra-articular artery, superior articular artery, and inferior articular artery. And if we see the scope which we are placing in the UB technique intralamina approaches, it's at 9 o'clock, 7 o'clock, and the 6 o'clock position, which actually bleeds from the bone, and that's why we have to be cautious about these particular sites of bleeding whenever we are using any RFA devices over it. And similarly, when we reach inside, then there is an epidural bleed which can occur. What is also important to us to understand is the hidden cause of the bleed, like increase in the venous pressure, which can be because of the result of the increase in the abdominal pressure, as well as coagulopathy, which we may have missed the whole thing. So as adage goes, prevention is better than the cure. We should always start with checking of the coagulation profile of the patient. We should stop all anticoagulants and antiplatelets. We should be giving two different point of checks when we are trying to position the patient. Not only the surgeon, but also the anesthesiologist should check whether the abdominal pressure is relieved. And then to maintain adequate pressure inside the cavity, we should be trying not to create a lot of facial punctures. This usually occurs when the beginners is starting, when we are trying to push in the instruments inside the instrument port, we actually create a lot of facial punctures, and that's what actually seeps a lot of water outside the cavity and does not allow a sort of a pressure built up inside the cavity. And also we should try to keep the exit port as small as possible, and that's why nowadays the semicircular or semi-open sheets are available to use to push your instruments inside the cavity. Now, when the bleeding occurs, we should always start communicating with an anesthesiologist. We should try to keep the blood pressure, particularly it has been recommended that the optimal systolic blood pressure during the local and general anesthesia is 90 to 100. For the local anesthetic procedure, it should be 120 to 130. We should also try to decrease the inspiratory pressure or PEEP, and if in case patient may have bronchospasm, so if in case the patient does not have a very normal inspiratory pressure, we should also try to rule out bronchospasm. And sometime when the anesthesiologists are trying to put the CVP line, patient may have developed a pneumothorax or may have developed some compression over the abdomen during the positioning, so this needs to be ruled out. And of course, we should also ask our floor nurse to start recording the bleeding time as well as the durational time. This is very, very important when we are raising the height of the irrigation fluid to control the bleeding. We forget that the pressure is very much high inside the cavity. And that's why, as a general rule, we should always keep that pressure high, but not more than 1 to 2 minutes. Because if in case we are trying to do that, this means we are flushing the blood off very fast, and that's why the patient is losing blood, even though we may not realize it. Then there are medications like tranexamic acids, which can be used throughout the surgery to control the bleeding, and also hemostatic matrices like flow seal. Nowadays, flow seals are coming in the liquid form where you can put it through the nozzle inside the epidural spaces, particularly to control the bleeding. And then there then be many instruments like diathermy. Nowadays, the diathermy has been taken up by the radiofrequency plasma coagulation, which does not allow the temperature to go up, and it actually creates a very good feel after some time. Only point to be noted is we should try to use this RFA towards the periosteum so that we do not pull off the epidural vessels, which can get stuck to these RFA devices. And of course, on the bone, we can actually apply bone wax. Diamond drill has been shown to be very effective in controlling a little bit of bleed oozing from the bone. If you can apply the bone wax over these sites and then use the drill over it, it actually controls the bleeding. So Dr. Om Prakash, I think he must be in the audience, he actually showed a very good technique how you can apply a bone wax using a small shunt tunneler passer. But this is applicable when you are putting it over the surface which is exposed to you. If the bleeding is coming from the down, you can actually use a pen field, a curved pen field with a small bone wax plug onto its tip, or you can even use the small bone wax plug attached to the foot plate of the bone ronger, and then use it to plug the small bleeding from under surface of the bone cut surfaces. Then, of course, the irrigation pressure, we should be aware that the pressure which we are talking about, 30 to 50 millimeter mercury, may not be actually be pressure built up inside the cavity because the water is flowing out. And that's why the pressure built up is not so high. So if you have to create a little bit of more pressure, the first and foremost thinking is you can actually close the egress. So you can actually use a finger to close the exit of the water so that the pressure builds up inside the cavity. And then, of course, you can control the vortex movement by this, and then you can also increase the irrigation process pressure. Then we can use the scope. So the scope has to move out a little bit outside so that it does not get soaked up in the blood. And we can use a 30-degree scope in these particular phases, because 30-degree scope by an eccentric view, you can, by its movement, by rotating movement, you can have an extended field of view vision on the operator side. And if nothing works, then of course, you can actually call your seniors, and your non-endoscopic colleagues can also be a help of them. You can convert to open surgery and use microscope and keep your blood products ready and transfuse if necessary. We have to repeat hemoglobin, coagulation profile, and ABGs. And remember, these are the patients where hypothermia, acidosis, and coagulopathy needs to be prevented at all the times. Of course, once the bleeding is stopped, you should always bring down the pressure and always see whether the bleeding stops while the irrigation has been stopped. Sometimes these bleedings are hidden by the continuous irrigation, so one should be aware of this. Other term which I like to put forward is the hidden blood loss. This was actually being talked about nowadays. So hidden blood loss is nothing but the subtraction of the total blood loss minus visible blood loss. And it has been shown that the blood loss which we estimate after the surgery is severely underestimated because of the use of continuous irrigation, blood infiltrating into the soft tissues, and even the blood which is going inside the dead spaces in the surgical channel. So in one of these papers where they have done the blood loss, hidden blood loss calculation for the patients who had undergone UB technique surgeries for simple cases like canal stenosis and discectomies, it has been found that the hidden blood loss has been around 361 plus minus 217 mils. That is almost half a liter in the maximum amount of the cases. And it has been 3 times more than what surgeons calculate in the visible blood loss. And it has been shown to be directly proportional to the operation time and the paraspinal muscle thickness. So to conclude, whenever we have these types of situations, we should keep our calm. We should not intervene in panic. Think what causes bleed, so we can come from up to down, and then we can start taking preventive steps before we use a stepwise management. And also, whenever we are trying to going to close the wound, we should always reassess so that the patient is not bleeding from any other sides. Thank you for your patience listening. My email is here. We can always communicate on this topic. And I would like to use this flora to invite all of you to the Neurosurgery in South Asia Advances Achievement and Future Collaboration. So basically a SARC meeting to be held in Kathmandu from September 7 to 9. And we will have a session on spine endoscopic techniques in this meeting. Thank you very much.
Thank you, Dr. Amitabh. A wonderful, wonderful lecture. And thank you for keeping in time.
We are going to start with a debate, so I'm going to ask you all to please continue sitting here because I need you to fight. Huh? So you're taking his place. You're Dr. Aigun right now. Dr. Monu Singh, Dr. Ashok Lawange, please. My dear Dr. Masato, without you, no debate can be complete. So please honor me, sir. May I invite on stage Dr. Pompavit, please. Dr. Siok Bong Jung, Dr. Rodolfo, Dr. Alfonso, Dr. Girish Datar, the one and only star of India. Dr. Jung, please. We have a debate and I need you. Dr. Pompavit. I think he's outside having a coffee, I guess. If somebody can please send a message to him. No, any side. Everybody takes their own side. Yesterday we had 11 people disagreeing on what surgery I did. Everyone had a different opinion. But that's what spine is. So we are going to have Dr. Bhupesh Patel presenting his case today. Yeah, Dr. Neeraj Jain, where are you? Yeah, please, sir. Still.
Hello.
Dr. Pompavit, please. Dr. Lim, I think, is missing. Dr. Lim, can somebody please call Dr. Lim? Sir. We await you, sir. We await our star. It's okay. So we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, and all of you. It's remember one thing, debate is open house. Guys, you have an opinion, put your hand up. Say all of you all are wrong and I'm right. That's done. Dr. Lim, sir, please. So we are going to start with maybe 1.5 minutes. First, we'll have the presentation. The rules of the debate are simple. You go through these images. Please give your opinion. What will you do? And then let's curse him. Okay? We'll say, you did something wrong.
Yeah.
So, can you start with the presentation,
just,
please?
Go through the history. He is a 71-year-old male with left leg pain since 2 years, progressively increased and become very severe since last 6 months. Not able to sleep due to pain, daily medication needed for the pain relief. Pain was mainly located in the back of thigh, goes till leg. Tingling numbness in both legs, left is more severe than right only mild pain. No neurology involvement, no bowel bladder symptoms, deep tendon reflex at the age of 71 is preserved. He underwent surgery 3 months back. So when he came to me, in just 3 months back, he underwent surgery from L1 to L5 decompression, fusion, along with thoracic decompression. But after surgery, he came to me 3 months after surgery. He said, no relief of symptom post-surgery. It's same what it was before surgery. Little numbness reduced, but no pain relief. So this is a MRI after first surgery.
You are free to walk up the MRI. You can go to the MRI and look at it like this. You can look at the MRI like this.
Yeah.
You can look at it like this. All yours. The screen is all yours, gentlemen. Please have a good close look.
I don't have pre-operative.
No, there is no pre-operative because he's received the patient after 2 surgeries and that too after a span of maybe 10 years.
Sir, frankly tell me, this patient is under insurance, so insurance company took all the images pre-operatively. No weakness, yeah. No
Only
weakness.
pain and severe
very
pain.
severe, it's stretching kind of pain. He just said this back of thigh is just paining like anything. Yeah, left side, only left side. But right side, it's not, numbness is there a little bit, but no pain. This is our whole spine screening. And he had also thoracic mild component, so he did decompression at the thoracic level also, the first surgeon. And obviously there is a cervical component that is there, so there might be some numbness. Yeah? 3 months back, when I intervened in this case.
No, you're going too fast. Go back to the MRI. Okay, let us have a look at the MRI again, guys. Should we start from looking at it from down up or up down?
Same pain, no increase, decrease. This same pain since last 6 months. Yeah.
The pain is posterior on the leg or lateral?
So
posterior on the leg or lateral?
Below leg is paining, no perfect dermatomal involved, but back of thigh is more painful.
All right, thank you.
Turning is also painful. Infection? No. All the parameters, blood investigations are normal, and even contrast MRI doesn't show. Even contrast MRI doesn't show any pain. Okay. Yeah. Can I go to CT scan?
You're most welcome. Okay, let's go to the CT. Unfortunately, this is a pixelated.
So, do you find anything wrong with the screw, or?
Left S1, little low, yes. I give that to you. Bhupesh, but I want an honest declaration from you. Were you the first surgeon? Were you the second surgeon? And are you also the third surgeon?
I am second surgeon. Yeah.
But no, before me, he saw 2 to 3 surgeons.
So can we go to the next image, gentlemen? Can we go to the next image? Thank you.
So now we can go to one by one. What will you do?
Wait, give people time here. Don't rush.
Okay, sorry. If you want, I can go back again to previous image.
Ask for back and forth pictures. I'm so glad somebody left the S1 and somebody left the S2. Didn't use that also.
There is a transition at L5 S1 actually.
Yeah.
Do you have claudication?
He's not able to walk. He's in bed. Not able to walk. Moment he just stand, he start having pain left leg.
Only standing causes pain. Forget walking.
Even sleeping, not able to sleep. Without daily, he's taking almost 75 Lyrica, almost 3 times a day, but not pain relief. Even Madrol he took, methylprednisolone, but no relief.
See the drug addict. To add it to it.
Okay. So again.
Okay, go back again once. One more back time to the MRIs.
This is just.
अरे घाई मत कर यार, वो वाला MRI पे जा.
This screening.
हाँ, इस पे देखें जरा जरा.
What is the last image delivered?
That is L5S1.
This is not L5S1. Yeah, D12L1. This one. Thoracic one. Yeah. He did decompression.
Now, what level is that? What is the level marked on your laptop?
Let me see here. D12L1.
That is the thoracic. Okay, he's showing you the thoracic
Post-operative.
CT.
This is a post-operative.
Okay.
All post-operative. I don't have preoperative image.
Where have they done dorsal decompression at upper level?
Yeah.
Okay, now we go back. Back to the CT images. Back to the MRI images. It's still showing a lot of rat tailing and cutting of the cord at many places. But why the severe pain? The question is, why the severe pain?
Yeah, that is something wrong with the foramen.
But now we shall not debate. Now we shall answer. Each one has a chance. Yeah, we'll start with Diego. Let's start turn-wise. Diego, come on. What would you do? Now I only want to know what you would do. Now don't discuss the MRI. And I think it could be this. No.
Your diagnosis for this pain?
Simple. 1, 2, 3, 4.
Persist even after surgery, no relief.
What will you do? I'd send him to my best friend across the street.
L5S1, left side, decompress foramen.
Loudly.
Extraforaminal, decompress, L5S1.
Extraforaminal, I won't call it extraforaminal. Why do you call it extraforaminal? That's a little cut of the ala bone, yeah?
This is a lower cut.
This is a lower ala bone cut. This is the ala bone cut. So don't go for that, but I would, yeah. I mean, if you tell me foraminal disc, maybe I'll agree.
More of facet joint.
Next. So you are a little confused. You don't know what to do. You'll send it to your next best friend.
Maybe.
Sorry? Yeah, I'll tell you. We just discuss what you will do. Then what I did, we'll just discuss where the images is. I didn't do.
No, the question is specific. Did you rule out complex pain syndrome, CRPS?
No.
No, you didn't rule it out. Fair enough. That's it. End of it. Okay, so what would you do?
I feel if it is possible for me to go in for a nerve root block at that particular level.
Which particular level?
That L5S1.
Okay, you'll do a L5S1 nerve root block and you will check for
and
pain
I'll see
relief.
whether the patient responds to that or not.
Okay, and then you will decide on what?
If the patient is responding to it, then my choice would be a decompression. At
Your
that
choice
level,
will be a
unilateral.
decompression. Thank you, sir. Dr. Girish Datar, your call.
So it looks to be the left L5S1, which is of high suspicion.
Okay.
Go back, please. Yeah. So lateral recess block would be a more optimum.
Okay,
because
lateral
my-
recess block,
the
but
images-
only block, or you'd follow it up with something else?
No, first I would do a block to confirm my diagnosis, because most
Okay.
important thing, the cuts in the upper part of the foramen are missing.
Normal, yeah.
Are missing.
Yep.
So I don't know whether there is a foraminal stenosis there.
This is upper part of foramen.
Yeah, but obscured, right? Yeah. So if confirmed, I would definitely go with the decompression.
So, block, decompression, block, decompression. He says, I send it to my best friend. Fair enough. You, doctor, sir.
L5S1, there's definitely a foraminal area, there's hypertrophy, and there is a block there, and there could be root impingement there, which can be
Sir, what
diagnosed
would
with
you
the
do?
Root block, and over and above, I think L4-5 doesn't look good on the lateral recess side, so probably L4-5 could be involved, which is traversing L5 could be involved there at L4-5.
So you would want to explore the traversing L5?
Yeah.
You would want to explore the foramen with a root block?
Yeah, and once you find the relief, and then you go for a definitive procedure.
So then a definitive procedure. Okay, so we are still stuck on block, block, block procedure. He to my best friend. Boss, your call.
I didn't. I have no responsibility.
He is going to send it to Mumbai. Go to Dr. Malcolm. Out. Okay.
I have no idea. Yeah, I will send it to Dr. Girish.
Okay, he's going to send it to Dr. Girish.
So that,
Oh, I love you.
Main problem is we have no any the pre-operative MRI.
Yeah, I understand that, sir.
Yeah.
Unfortunately, it's missing.
It will be the clue, but the patient have a left leg, the back means the low level.
Yes, sir. Yeah,
problem.
it is a lower level.
So I think it was L5 lateral recess all. Yes, S1, right?
Yeah.
S1 lateral recess all L5.
Yes, sir. So
S1.
traversing L5,
Yeah.
exiting L5 or lateral
Yes,
recess
our-
S1. Thank
yeah.
you, sir. Thank you so much. So if you suspect that, you would want to decompress it, sir? Yeah. Thank you. So you are on decompression.
I very agree with the doctor. I return with the other surgery.
This is what you call taking a safe side. Boss said it, I said it. Okay,
No,
thank you.
That's definitely is necessary to do that decompression in the L5S1. The first is do the block, and if it's good for the patients, I do the decompression by biportal.
But now we are halfway through.
Now he find. I think
Hello.
first
Hello,
you
hello,
see
hello,
the
hello,
MRI,
hello,
then
hello.
see the CT scan at the same level.
Hello.
I don't want to see.
You don't give hints, huh? I'll throw you out of the main debate. You don't give hints. No giving hints. That's not fair now. That's cheating. These people are already committed. And now he's giving y'all hints. So he's taking your side. See? I'm taking their side. Balance. Dr. Pompavit, your call. Boss, what would you do?
Okay. Normally in the failback case, the common side of the failback come from the thoracic levels, particularly in the 9, 10, or 10, 11. OYL is the
Yes.
most common cause of the failbacks. But in this case, they perform a lot, many level. But the main is the left facet joint L5S1. You can see the calcification in the allow the joints, and they have the joints hypertrophy. So I think if this is my case, I perform the uniportal, and then I attach to the L5S1 first, and decompression, and
Root
go
release, yeah.
to
Down.
cut the tip of the
SAP.
SAP, and then check along the L5 root.
Fantastic.
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 Yeah, this is something.
Okay, definitive answer. Sir, your call, sir.
Yes, of course, nerve root block is necessary. Usually, it's L1 to L5 is fused. Even though there is a small stenosis, the fused level seldom causes pain. So most likely it's upper end or lower end. Upper end, it's very stenotic, but this cause not the pain, but some guide disturbance or some
Yes.
balance.
Yes, it causes an
Yes,
epiconia
the cause
syndrome.
is mainly from here. But I'd like to see the coronal one, because it's Bartolotti syndrome. It's coronal one.
Coronal, please.
Yes, if you look at this is fused. So it's not so much instability. However, the cause of the pain is L5 or S1 because the posterior buttock. So the nerve root block is necessary. And maybe L5, S1 decompression is necessary for this patient. Extraforaminal and maybe central.
Sir, I'm going to change your name to Sherlock Holmes. Deduction. Fusion can't cause this. It has to be up or it has to be down. But up is fine, so it's got to be down. It can't be that side, so it has to be this side. Excellent. Appreciate, sir. Fantastic.
I
You're
agree.
The Sherlock Holmes of spine. Salute.
Yeah, I agree.
He
I agree
agrees.
with
Okay,
them.
again, one, see, when a big boss sits behind and says something, next guy says, I agree immediately. Okay. Dr. Pao, the mic is in your hand. You can use that, you can use this.
I think a chronal view of the MRI is very important because if the L5S1, L5 root was impinged in the L5S1 foramen or far lateral area, you can check it. Maybe
Can you show the
can
coronal
note it
view of the MRI? Do you
on
have
the
any
coronal
MRI
of the
coronal
MRI.
view?
Coronal view.
If that area is suspicious, then you can do a nerve block to check, to confirm that
No.
diagnosis.
He doesn't have.
That's
I
very
have, but I
important.
didn't put that MRI.
Okay, but now, despite all our deficiencies, what side will you take?
What side?
Yeah, or you want to be like Mahatma Gandhi, me, myself, and I.
L5,
No
S1
side.
foramen decompression.
Okay,
The far
L5S1 foraminal
far out
decompression.
area.
Okay.
So now the clock is switching, it's changing. Zoom, zoom, zoom. Block, exploration, block, exploration, block, exploration. Block, no block. Exploration, exploration, exploration. Now the block sides are over, okay? Exploration. Sir, your chance, please.
I think the pain origin is the L5S1 left side lateral recess stenosis and the 4-5 bilateral foraminal stenosis. So once I will do L5S1 decompress lateral recess. After that, the pain persists. I L4-5 anterior decompression, discectomy, and only cage insertion.
So as a first stage, you will do an L5S1 decompression. Then you'll make the patient wake up out of GA. Then you'll check he has no pain. But if he has pain, you will take him back in the theater and open up L4-5. I appreciate this guy. I really love him. Dr. Lavangi, your call.
Yes, sir. You appears to be very excited with every answer. So there is no correct answer up till now.
No, you don't know me. You don't know me. No way, Dr. Lavangi. Don't place your bets on me.
So, yes, I agree with Girish that would like to give diagnostic block. Rule out. If it is not L5S1, go for L4, L5. If it is not L4, L5, go for L3, L4. And just ruling out this with blocks, I will go ahead.
Okay, see now comes out the hidden gem. He kept this till the last. Yeah. He kept this till the last. Okay?
This is the cause of
we have calcification of the capsule of the joint. And when this happens, the traversing nerve root at L5S1.
And the things that this patient has big surgery, so he's tired. He said, if you know the correct reason for pain, then and then you go ahead. Otherwise, don't operate. I don't want to go again for same trouble of big surgeries. So we localize the pain at last mobile level. So we get, according to me, that L5S1 facet osteophyte, pinching the left S1 root, responsible for left leg pain. So just to confirm that, we gave root block with plain lignocaine. He has a pain relief, complete pain relief for 1 hour or 45 minutes, 1 hour.
What level was the block given? L5,
S1 root block, S1 root block.
So it was at S1, S2?
Yeah, last mobile level. Yeah, at S1 foramen, we go from.
He's talking of S1 traversing, S2 traversing.
We block the traversing nerve root. Okay.
SNRB has to be given at S1, S2. Selective nerve root block has to be given at
Yes.
S1 foramen.
S1
We gave
foramen.
S1 foramen.
Exiting root को block कर दिया ना sir. Fair enough. S1.
S1.
Exiting, yes. So finally we have, this is the third day and we finally have a consensus amongst us,
S1 route.
at least about the pathology. Okay, it was S5, S1. We had one Sherlock Holmes who was doing a wonderful deduction. And we have had an excellent time. I thank you all, gentlemen. Thank you all.
This is the final.
Thank you.
So,
this is a video, yeah. This is
So
a video
Bhupesh,
of that picture. I can operate. Oh, where is my mouse?
Yeah, he's instant relief. So root. Yes, yes, yes.
I did interlaminar endoscopy at L5S1, remove that osteophyte. So during intraop, the root got flattened with osteophyte. Osteophyte is pinching the root, so not allowing even minor movement of the nerve root. So that's why he's not able to stand because of the severe stretching pain of that nerve root. So we just did decompression, we remove that facet osteophyte and trace the root till down into the foramen. Yeah. 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 So we start with the next session. Dr. Saishav is here. So we asked Dr. Monu Singh and Dr. Same to chair the session. And we start with the talk of Dr. Ghazwan Hassan for his talk on should we wait 3 to 6 months to do endoscopic spine discectomy.
Hello, good afternoon. I know the title, it's not a usual title, and even the lecture will be not the usual lecture because at the end, I will not end up with a conclusion. I will let the topic will be an open discussion, and I hope we have a time to discuss with the mentors about it. Nothing to disclose in my talk because if I disclose something, I will disclose all the hospital, surgeons, companies all over the world. The first, when I started to search about this topic, I surprised that the neurosurgeons follow the guidelines better than the orthopedic. So, special thanks to all the neurosurgeons here. Because I thought that I'm the only orthopedic guy who want to change the guidelines. But in the guidelines, they show that all the neurosurgeons better than me. The learning objective of my talk, why 3 to 6 months? Or why it's more than 3 months? Second, we have to think about the consequences of the chronic pain on the muscle, psychological, and we are living in the era right now that most of the big companies start to fire their employees because of the economic crisis. So imagine these employees develop a back pain. So what the company will do for them? And also the surgical impaction of the chronic disc when we're talking about the fibrosis, calcification of the disc, and I know that most of you facing that when we operate on the fresh disc is different from that on the chronic disc, at least from the surgical perspective. And also, I will dive in some literature review and end up with my proposal, not a conclusion. I will start with this case, and I ask most of you that think about the surgical, the treatment plan at the end of the talk. He's a 35-year-old male, football player, presented with back pain, with severe right radiculopathy for 1 month, for 1 week, severe intractable not response to treatment. And I will keep the discussion at the end. When we come to the disc prolapse, why 3 months? Because most of the literature suppose that about 2/3 of the disc will be resolved with time. And this is not for all disc. We have about 1/3 that's not eligible for resorption. This is one point. And when we take some, let's say, literature review, they saw that 70% they will resolve within 3 months, and this is depend on the nature of the disc when it is sequestrated, while when it is associated with a cartilage and modic changes, it's less chance to be resolved. And this is a meta-analysis that's also conclude that time. When it's come to the chronic disc, we have to think about the paraspinal muscle and its impaction on the chronic pain. And we know it's the long septum duration. It's associated with a muscle changes, and we know that this impaction on the chronic back pain. And also the effect, this is a study that's conclude that's the effect of multifidus muscle on the lumbar disc, and they conclude that we have to take a consideration about early surgery in order to save the muscle from the chronic consequences. What about the psychological impact? And all we know that this impact is associated with the chronic pain, and when it's associated with the chronic pain, and the story will never be end. These are some data supported that. So when we review the guideline, I think that this is the recommendation, a systematic review about the guideline. They conclude that it could be. So there is no definitive guideline supportive waiting for 3 months. Again, the North American Spine Society guidelines about the treatment of the disc prolapse, they conclude that there is absence of reliable evidence related to the natural history and the resorption, and also they conclude that recommendation grade B about the treatment plan. But when we go through these guidelines, these are the reference that the NAS, they took the reference from them, and they put this recommendation. See the number of cases in each paper and the year. So, and even the level of the literature, there is only one RCT study that's the NAS depend on drawing this guideline on it. So I think that this is another systematic review, which is, I think it's in 2019. They recommend that we have to include the patient preference in the treatment guideline. And I think that's all these data, they depend on the technique. When we have guideline on, we have to, let's say, to plan the treatment. From my perspective, we have to manage between the outcome and the complication. So all these data, they depend on the open discectomy or microscopic discectomy. But now here we are talking about endoscopic discectomy. So the first question that's come in my mind, that's, shall we change the guideline or modify it or update it according to the treatment guideline? Because all we know that the endoscopic spine surgery carry less complication compared with the other technique, and even the recovery after surgery is different from the other technique. So this is a question that's come in my mind. And another reference also support that, and you can imagine that in the conclusion in the review that I suppose I couldn't find a clear cut about the duration and even the updated topics and the literature says they suppose that the early surgery cover better early outcome, but when it's come to the after 2 years, they have the same. So can we convince our patient that you will have the same result after 2 years, whether it's conservative or surgery? But what about the early result? What about the other factor that we conclude? So I will discuss that within the coming days, or the effect that if we wait for 3 months, there will be an economic burden, surgical difficulties, and we are talking about failure of conservative. So not all patients will their septum will be resorbed. So some of them will have still have the surgical option, and also about muscle atrophy and psychological burden. While when you do it, let's say within 2 weeks, you will have a fresh disc that you can remove, and the preserved muscle, lower complication in the endoscopic spine compared with the later presentation, return to the activity and away from the worker. So for me, it's time to update the guideline, because I think that we have to include all these factors when we're talking about the treatment plan in the disc. Not all patients have the same age, because the age put it in consideration, the sex, activity level, socio-economic, surgical technique, professional level, economic burden, and direct and indirect cost of each activity. I will return back to the case presentation, and I will ask Diego that, will you treat this patient with a conservative treatment for 3 months? Why? You have to follow the guideline. You are a neurosurgeon. This guy, his salary for 3 months will cost about more than $8 million. So is it feasible for that? So I think that my proposal, we have to have a scoring system that's guide our treatment, not only depending on the factor. And this scoring system, we have to include the age, activity, productivity, neurological septum, herniation type, psychological background, the duration of septum. In the first visit, sometimes we are receiving the patient within 1 week or within 2 weeks with the first visit. So shall we include this time is a 0, or it's after 2 weeks of the initial septum because of the misdiagnosis, and also the trial of the let's say previous treatment and the technique that's available for intervention. Thank you.
Because you are running out of time. Huh?
Yeah, it's finished.
You are on time. So our next topic speaker is Dr. Pao.
Hello, this is Dr. Pao from Taiwan. Today I'm going to show you how to avoid the dural tear in the non-UBE surgery. I will show you the technique that I developed that is called no punch technique. I will show you how to do the decompression surgery without using the punch. The UBE is a very beautiful surgery that we can see the very detailed anatomical structures in the crystal clear surgical field without, we can do very delicate surgery, including using the punch, using the burr, using the disc hump. But we always see the bright side, but we neglected the dark side. The dark side is no matter how hard we work, no matter how cautious we are, there is always a dural tear. The reported incidence in the literature is about 0.7%, even in a very experienced surgeon's hand. So the dural tear is most often occurred in the patients with severe stenosis. In cases of severe stenosis, we will encounter the very hyperemic epidural vein and severe adhesion under the ligamentum flavum. That is what we saw on the endoscope, that is severe adhesion and the fibrosis even in the primary cases. So we never underestimate the epidural adhesion. You can see that when we elevate the epidural vein, elevate the ligamentum flavum, there is always severe adhesion underneath the ligamentum flavum, especially when the patient has severe stenosis or when the symptom is very long, such as 5 years or 10 years. So another special feature in the UB surgery is the central fold. If you neglected that special feature, you will use the punch or use the disc clamp to injure the central fold. That will cause the irreparable or severe damage to the dura and cause unrepairable the dural tear. So there I will show you how the central fold was incidentally injured by the punch. So we have a variety of surgical instruments that we use for decompression: the Carrison punch, the curette, the high-speed burr, the osteotome, the pituitary clamp, and the nerve block, and the Penfield dural dissector. And then the most offending instrument is the Carrison punch. So we tried not to use the Carrison punch, and we use the high-speed burr and the osteotome instead. I will show you how. Why I choose the diamond burr? Because when we use the diamond burr, we can use the burr in forward spinning and backward spinning, the reverse mode. But when we use the cutting burr is more dangerous, and it can be used in one way. That is, if you use it in reverse mode, there will be no use. In the modern equipment of the high-speed burr, you can always find a forward mode and a backward mode. Why the backward mode or reverse mode is so important? When you do, everybody knows that the ligamentum flavum is our best friend when we do the decompression surgery. But when we do the contralateral side, we always do the sublaminar decompression between the lamina and the ligamentum flavum. At that time, if we use the reverse mode, that can prevent the flare up of the ligamentum flavum and let the ligamentum flavum to protect the underlying dura. That is the illustration that I show you. When you use the forward spinning, the ligamentum flavum will be flare up on the right side approach. But on the contrary, if you use the left side approach, then the forward mode is more safer. I will show you the no punch technique, the step by step. The first step is to find the spinal laminar junction and expand the laminotomy. After you find the attachment of the ligamentum flavum, just stop. When you find the ligamentum flavum, you go to the caudal side to find the caudal end of the ligamentum flavum. You use the burr to burr out. Then this step is very critical, that you had used the Penfield to separate the ligamentum flavum, stripping it off from the under surface of the lamina. Then you separate the superficial ligamentum flavum and the deep ligamentum flavum. And then this time you can insert the burr between the ligamentum flavum and the lamina. That is very safe. You can insert the burr into the very deep space of a lateral recess, even into that contralateral side. Then you can use the osteotome to chop off the under surface of the facet joint to do the release of the contralateral facet joint and to free the nerve root, traversing nerve root of the contralateral side. And then you use the Penfield to separate the ligamentum flavum and the underlying, to dissect the underlying adhesion. Then you can remove the ligamentum flavum as a whole piece or piece by piece using the pituitary clamp. You don't need to use the punch. That is much safer. Then to the ipsilateral side, you can use the curved osteotome to chop the lamina of the very thin side sublaminar decompression, to chop off the lamina along with the ligamentum flavum. Then you can take out the ligamentum flavum. That's the final check for the dura. All the ligamentum flavum was removed completely, and all the decompression, offending bony structures, osteophyte was also removed. We don't need to use the punch. Because for the patient with a very severe stenosis, when you use the punch, you will let the punch go into the very severe stenotic lateral recess. Then at that time, you will injure to the nerve root. That I developed a set of osteotome that is very small, very narrow, 4 millimeter in width, and 0 degree, 10 degree, and 20 degree curve. You can see in the left side, the video shows you can do the osteotomy part very clearly and very easily under the endoscope using the uniportal biportal technique. So why another advantage is that when you use the curved osteotome, not instead of the straight punch, that you can save more of the ipsilateral facet joint. Because when you use the curved osteotome, you can do the sublaminar decompression of to undercut the facet joint. That you can preserve the ipsilateral facet joint more. That you don't worry about the postoperative instability. Even for the 3-level stenosis, you can do the decompression effectively in about 40 minutes for one segment. So that is the postoperative MRI evaluation for 3-segment stenosis. You can see the decompression effect is good, and the patient with very minimal facet joint destruction and a soft tissue injury. So we have a study about the facet joint violation. The ipsilateral side violation preservation is about 84%, and the contralateral side is about 92%. That is used the bird technique and the punch. And now we're going to have a study about the no punch technique. I think the facet preservation rate will be even more higher. Until now, we have a consecutive 700 cases of UBE surgery with no dural tear. I think that is a very good record. Even we have a totally about 800 cases of UBE surgery. Now it's a consecutive 700 cases, no dural tear. So the practice not always makes perfect unless you know how to avoid the mistake. So for the dural tear, I think it is avoidable. And the most important is precaution, precaution, precaution. You need to have a very clear surgical field, and you must do the meticulous hemostasis. You must understand the injury mechanism. You know where the risk, where the danger is, then you can avoid or you can prevent it occur. Don't use the instrument blindly. Every instrument, every punch, every osteotome, you need to use it under the clear and under the vision, and you must feel confidently. To handle the instrument in the right way, avoid the offending instrument, such as the Carrison punch. It is the most dangerous. So you must learn from the painful experience from yourself or from the other spine surgeon, and avoid making the same mistake again and again. Thank you.
Thank you, Dr. Pao. Our next speaker is Dr. Diego Oliveira. His topic is UB for lumbar stenosis, step-by-step approach. Dr. Diego.
Thank you, everybody. Let me share my presentation. Okay, thank you for a second time. I'm going to talk about for UBE, for lumbar spine stenosis step by step. appreciate the invitation for being here. So this is the 3 ways I know, MIS ways to decompress lumbar spine stenosis. As you can see, there's so many different things, no? In the third, in all the decisions that you do it, and the best decision that you can do it is that the thing that you know how to do it better. So in those videos, there are similar images like full endo and UV. This is because they are endoscopy based and in water, different like another endoscopies procedures. Well, I said yesterday, in Latin America, it was the first reporter about UV by Dr. D'Antoni. You know, the UV tools is similar like open surgery. This technique has the concept to inflow and outflow of the water and working different, both hands, like working channel and endoscopy portal. Always endoscopy portal follow the hand that is working and use all the tools. Well, you know, UV has a different things that increase the enthusiasm of the knowledge of the young surgeons like me and you, and like good vision, instruments do not obstruct the vision, the freedom of the movements of both hands, no destruction of the paravertebral muscles like tubular or maybe open surgery, the working channel independent for the viewer channel, and use a safe radio frequencies. This is a resume about the UV approaches that we know, like paramedial, paraspinal approaches, and inclinatory approaches. All you can use it for cervical, thoracic, and thoracic and lumbar spine. So when we want to decompress the lumbar spine, we use some targets. For us, the spinal laminar junction is a target like this. Your instruments in AP view look like this. Always mild pedicular line you have to mark. Then you have to mark the spinal laminar junction. You see this, and this is your target point. So in these images, you can see both triangulation of the endoscopic view and working channel. You have to see the spinous process, the lamina, and the interlaminar space. Intraoperative images, I recommend always to see AP view and lateral view all the time. The steps are simple. You have to drill and decompress and detach the ligament flavum. The first step is the spinous process, the base of the spinous process. Then ipsilateral laminotomy, then contralateral decompression, and then the caudal side. I'm going to show you in a video like this. We saw the decompress of the spinous, the base of the spinous process with the drill, detach the ligament. The next step in this place, you decompress the ipsilateral laminotomy and then go to the contralateral laminotomy, contralateral side, remove all the make a space like you see in other videos, and then the caudal side is detached, the ligament, and then in the middle line with all the tools that you have, hooks, radiofrequency like this, you remove the meningovertebral ligaments, and it's not important that in one block remove the ligament flavum. You can do it piece by piece, but secure, without dural tears. And then remove all the small pieces, and you can see the dural is completely decompressed in the central case, in this example. Those are the postoperative images of MRI. We have another example of the compress, the base of the spinous process, ipsilateral, contralateral side, then remove piece by piece the ligament flavum, and we can see the transversus nerve root, dural sac, and exiting nerve root for contralateral side. Those are the images that after decompress this level, L4, L5. We also use it, it's useful for facet joint cyst. For example, this is the cross area, she says CED or D. You can see after decompression, increase the area for the approach. In multiple spinal stenosis is useful, UVE. You can do it with 3 small incisions, 6 millimeters, and increase the dural sac area. This is very important, like the other doctor says, you have to be very careful with those images. Meningovertebral ligaments are very dangerous. If you can see, you can take the ligament flavum and creates a dural tear. So, thank you very much.
Thank you, Dr. Oliveira. We just connect to the OT. Dr. Malcolm Pestonji is ready with his case. He just show us the marking. Dr. Malcolm, hello. Audio do na. Hello. Hello. I think he must be busy. So meanwhile, we finished one more lecture with Dr. Alfonso. He'll present his case, my journey from lumbar transforaminal to posterior cervical endoscopic approach.
Thank you very much. We're all tired now, so I will go very, very fast. So my journey from lumbar transforaminal to posterior cervical endoscopic approaches, I won't be talking about biportal. So actually, the strategy is learn from my patients, go from basic to advanced. And one question that I frequently ask in the workshops, what approach should you learn first? Transforaminal or interlaminar? Can you show me really, really fast hands? Transforaminal should be taught first, and interlaminar should be taught first. Okay. So depending on what you wish to handle, if you want to learn first transforaminal, you have to be aware that it's going to be easy for instrument handling. What happened? It's going to be easy for instrument handling because the transforaminal approach is a very stable approach. You can let both hands go, and the instrument and the scope will stay there on its own. But it's initially difficult for the anatomy. But if you want to learn interlaminar approach,
all of us are very familiar with the anatomy, but the approach is very unstable. So if you're willing to sacrifice unsteadiness, instability, and difficult instrument handling towards an easy anatomy, then it's okay to learn interlaminar first. Personally, I developed a strategy to learn how to go from basic to more advanced cases, which considering first instrument handling. If you know how to handle your tool, if you know how to handle your tool set, you will be able to use your tool set for many different approaches. So my pathway went like this pretty much. I went from transforaminal decompression, simple single level, to more complex two level and a combination of both. And then I jumped into interlaminar decompression from lumbar ipsilateral to contralateral, combination of both. And then when I felt comfortable, I decided to go through a new training plan and access cervical, anterior, posterior, and started with simple one level, one side foraminotomy, and then go to more complex two level, two-sided bilateral decompression with just one incision. So what we all know about endoscopic spine surgery is pretty much said. I won't stay much on that. But the benefit of full endoscopic surgeries has been very, very well established. So this graphic shows the perceived invasiveness and complexity. And what it shows is that as procedures are perceived more invasive and more complex, endoscopic benefit zone grows or tends to grow. So I'd like to share two cases that fall into this benefit zone category, and they're both cervical cases, of course. One first case is cervical stenosis with an OPLL. It's a 63-year-old male with dyslipidemia, progressive loss of upper extremity dexterity and gait unsteadiness during the last 8 to 9 months. At present, was unable to feed himself and unable to walk. Something is happening with the cable connection. Okay. So these are the pre-op images. So the surgical plan was a left single incision cervical endoscopic unilateral laminotomy for bilateral decompression at C3, C4, and C4-5. And the surgery goes as follows. This is the CT scan, the real CT scan of the patient. I use them to plan my surgical approach, to identify the V point, which is a constant in this surgery. And what I did differently than what I usually do is I went off and dissected as much soft tissue as possible. There's me crossing the midline, and you see the flavum crease there. So I went on and did the soft tissue dissection first, and then, of course, bony removal. I do use Kerasins. I find it easy to use and safe, but maybe I will consider to use less Kerasin in the future. I've been paying close attention to the talks. I am very familiar with using the diamond burr. I like it a lot. I think it's a very safe, specifically for cervical approach. But there, I find myself using the Kerasin punch in the more deeper cortical of the lamina. So I went off and did the bony work all over. And in this level, in C3, C4, okay, that shows the shallow insertion of the ligamentum flavum on the upper lamina of the lower level. So in this level, C3, C4, I was very lucky to remove the flavum almost en bloc. So I had a small flavum there left. So it's pretty much done. One level, fully decompressed. So as Dr. Incomtech does, I do a sliding technique. So that's C4 lamina. So you end up very easily in the lower level. So I will start working at the C4-5. and actually the procedure just repeats itself. And unfortunately, in this level, I wasn't that lucky to remove the ligamentum flavum end block, but still, I was able to remove it, as you will see. So same steps, you identify the V-spot. I like to work first on the lower ridge of the upper lamina. Do the bony work first. Identify the proximal insertion of the ligamentum flavum. And as you can see, part of the ligamentum flavum was already removed there. I go to the contralateral side, maybe take a little bite of that bone. There it is, fully decompressed at 2 levels, 1 incision, sliding technique, and bilateral decompression. So patient went home next day with a small Band-Aid. There we go, size of incision. I like making horizontal incisions when I go bilateral, and I make horizontal vertical incisions when I go only single side, single level. So case 2, this is my first case that I operated a long time ago, C667 herniated disc. She was the wife of a colleague of mine, so it was a nerve-wracking case for being my first case. So it's a C667 foraminal disc, right side. For this case, I felt more at ease using the mechanical arm to partially hold my working sleeve. So it made my hands more stable. And I do have to, maybe some of you can tell that back then we didn't have a cervical scope. So I used the regular interlaminar scope for a certain company that has a 30-degree angle, but a very small working channel. So you can tell that the diamond burr was very small, and the RPMs were also low. I had to use 6,000 RPM diamond burr. The kerosene punch was fine for this case. So,
Shoot, please. Thank you. I'm bone. And from here, I'm going to again go on to bone. Shoot, please.
okay, that's the R, right?
Shoot, please.
Okay, so I'm working on the other lamina, and as you can see, most
Shoot,
of the
please.
flavum detaches on its own. Even if I use the kerosene, I'm not pushing down on the kerosene. I use my thumb also, like Dr. Inkantek uses it as a brake, so that makes it more safe.
Shoot. Yeah. Shoot,
And
please.
by that point, I was able to, I don't even
Shoot.
use a nerve retractor. You
Thank you.
cannot use a
Chalo,
nerve retractor
infiltration.
there. So that's the
Let me hand
pedicle. That's the pedicle.
Let that
I'm
talk
close
go
to
on.
the pedicle, and I'm removing the rest
Just
of
tell
the
him who's the moderator,
herniated
tell him
disc.
the talk khatam hoga to give us 5 minutes.
You see the mechanical arm there? So it's a fully decompressed nerve root. So this case, first time, it took me 3 hours. Patient went home, symptom-free, next day, and she's been symptom-free for the past 8 years. So take-home message, learn from every case, actually. Grow with your practice. Some of you know that to run, you actually don't jump over hurdles, you run over hurdles. A runner or an athlete has to train for many years. It's a technique that he or she has to master, even though professional athletes expect that on their first event. Some things like this happen. So instrument handling for me is key. Learn how to handle your instruments. Build academic relationships, network, teamwork, as we're doing right now, and teach others, share your knowledge, and definitely, most of all, enjoy the rewards of your work. So this is how my journey looked when I started back in 2015 with my teachers, Jin Hua. I was so grateful to learn both techniques, biportal and single portal. I seldom do biportal now. And I also have the privilege to teach in many countries and other surgeons. and make contributions. Thank you.
Thank you, Dr. Alfonso. We are just connected to OT. Hello, Dr. Malcolm. Hello. Hello. Dr. Malcolm, can you hear us?
I can hear you.
Yeah. Just explain what you are doing. What is your plan and what will you do?
Can you first somebody show them the MRI, please?
Yeah. Just show us the MRI.
Wait a minute, huh? Patient now I realize he rotated towards me. I want the patient rotated a little that side.
So yeah, we are on the MRI. So what?
In this MRI, patient having C4, C5, C5, C6 PIVD with stenosis and having chord change.
Can you focus more on sagittal view?
Yeah, just.
It's oblique. Can you go on more perpendicular to the MRI images?
Just a minute.
Yeah.
Yeah. Down. This one. Yeah.
Okay. C5, C6, central stenosis with myelopathy.
Yeah.
Probably.
Yeah. C4, C5 and C5, C6 PIVD with central canal stenosis.
C4, C5 just show us. This, we are on 5, 6.
Yeah, this is
up.
5, 6 and this is 4, 5.
4, 5 is up, yeah. Okay.
One patient having right-sided triceps weakness.
Okay.
And hyperreflexia
Mhm.
and pain on C6 nerve distribution, right-sided. So,
please.
Our plan in this case to do.
We are landing on the C5 lamina.
Okay.
We are going to open up the C5, C6. We are going to do a foraminotomy because that root looks a little tight and symptomatic. C4-5 root does not, though it looks tight, but it is not symptomatic at all. So the plan is to do one level foraminotomy and remove the middle lamina, hemilaminectomy, and remove the phlegm from the lower border of C4.
Just show us the Siam view.
Just 1 minute.
PIP.
Yeah, we are showing you 1 minute, please. Siam machine लाओ ना. भैया तुम थोड़ा पीछे रहो ना, तुम zoom करो पीछे से, सियाम बीच में अड़कते हैं. थोड़ा आना निकल रहा है ना. बस, thank you, shoot गए.
Okay.
नहीं, it's out. पीछे ले. Shoot please. थोड़ा और नीचे आओ.
PIP. Siam in a PIP and show us the
please.
live view also. Patient positioning also.
Yes.
Okay. थोड़ा और नीचे की तरफ. Okay. Shoot please. Yeah. So now you can see the T1, C7, C6, and I'm on the C5 lamina.
Okay.
Both my triangulations have been done on the C5 lamina. Can you give me a live shoot for the audience, please? Yeah. Can you see?
Yeah, we can see.
Yeah, I'm creating space from C4 to over the C5 lamina completely. Okay? I'm going towards the C4-5, pushing there a little bit, then coming in and going down. So sorry I'm taking so much radiation, but it's for my friends here. Thank you. Stop please now. Now we'll be introducing the scope. And since patient is myelopathic, blood pressure cannot be dropped. We have to operate in a very high blood pressure situation. So it's going to be a little bloody and it's going to be a little cloudy. No, you couldn't ask me, no, but I was oh, sorry, you couldn't ask me. Yeah. Now it's a right-sided issue and I'm going to operate from the right. I'm going to use my left hand as my surgical hand. I'm going to take the scope in my right hand. The first thing that you're supposed to do is you're supposed to do a position check. Are you facing exactly at 12 o'clock or no? Otherwise, you're going to be lost. The V of the camera helps you to realize, but you should keep your fingers like this and check your verticality. So am I vertical? Yes. Is my V at 12 o'clock? Yes. These are very essential things. Now I'm going to introduce my scope directly onto the vertebral body. Lamina, gently. Siam, please keep the Siam here. Siam, kada, photo kada, please. I will confirm where I am at every time. Cervical spine is not something where you play around. Take a shoot, please.
Shoot.
Yeah. Thoda machine नीचे so our friends can see, can count exactly where we are. Shoot, please. नाही तुम्ही खूप खाली आले. पाठीमागे या डोक्याजवळ या. Okay, चालेल. So you can see the T1, 7, 6, 5. I am on the 5 lamina with my scope, upper border of 5. Okay. And I'm going to
Just show us the endoscopic view.
Sir, अभी तो खून ही दिख रहा है. We'll
खून
show
ही है
you.
क्या?
अब पानी नहीं चालू किया है. I'm removing the tubes. Can I have a 90-degree probe in? Now I'm going to do a triangulation with my probe. I'm going to confirm that both my instruments are exactly on the C5 lamina. It's very important for me in the cervical spine to do that. Shoot, please. Yes, I am on the C5 bone. Yes. I can feel the bone. Now I'll try start the water. We are going to use gravity only. No pump can be used in the cervical spine, especially in a myelopathic patient. Please start the fluid. Can you give puncture वर? पाणी येत नाही मला अजून.
Sir, meanwhile you just create the space. Should we go for talk?
Yeah, you please do your talk.
Yeah.
Moment I do some sensible stripping, I'll get back to you guys.
I'll invite Dr. Hayati because his talk is
चलो,
remain.
please take the CM back now. भैया पीछे खींच ले थोड़ा.
Then we have lunch symposium.
Thank you और पीछे थोड़ा. Thank you.
And then we'll start after lunch the remaining topic. Okay.
आणि स्कोप मधून येत नाही काही.
सब कंप्लीट इसका है. हाँ. कंप्लीट कर दो.
And keep surgery in half view. Okay. हाफ कर दो उसको. साइड में कर देंगे ना आधा कर.
Meanwhile, I have a small comment for Dr. Ghazwan lecture.
Hello, hello.
Dr. Ghazwan, thank you for your lecture and the proposal, but I have a small comment. There is another important.
Just keep.
Hello, hello.
Thank you, Dr. Ghazwan, for your lecture. And I think there is another important point that it should be added to your proposal, which is a biological and biomechanical study for the nature of this disc, because disc prolapse is not almost a primary pathology. Mostly, it's a secondary pathology. One more point must be added to your proposal, which is biology and biomechanical study for the nature of disc prolapse, because it's not almost a primary pathology. Mostly it will be a secondary pathology for failure of dynamics. The other, the other comment about term guideline. Term guidelines is provided to legal issues. That's why it's different from area to area in this world. And I recommended to make it a recommendations, because guidelines differ, because litigations is differ also. It's not about scientific content only. It's also about litigation, which is different from different nations. At last, guidelines and recommendation is not a rule. That's why they have chosen guidelines and recommendation. You are the surgeon, which is who is responsible for best care for your patient. Provided you have the scientific based issue that support your decision. Thank you.
it's not depends on the time of a presentation. It's depend on many other factors. Each patient has his own, let's say scenario to decide whether to choose the appropriate technique. And each technique is different from the other. As what I want to send a message, that's this is one. Second point, that's all the recommendations and the data that's available on the, let's say, recommendation or guideline or whatever we are saying they based on the open techniques. So I think that it's time now to make some update or to whatever you mentioned, because the outcome and the complication and the results of the endoscopic spine is different from the open microscopic or any other technique. This is the concept that I want to deliver from my talk. And if we build a scoring system or whatever you want to say it, by including all the factor and what you mentioned also, I think it will be more practical and more dependable.
Thank you. Yeah, we will proceed with Dr. Hayati.
Yep. Thank you. Dear chairmen, dear audience, my colleagues, good afternoon, everyone. I'm sorry I missed my turn. Now I will show you my presentation. It will be about the cervical endoscopy. In my presentation, I tried to show you the regular or plain our approach, and then in some circumstances, the modified UB approach. You know, there are two main approaches for UB cervical surgery, paramedian and paravertebral approaches. Paramedian approach has modified approach as central or interspinal approach. You see, the preparation is very important, especially in cervical endoscopy. Dr. Malcolm also show us the preparation steps. And the surgical area should be draped after correct patient position. In lateral view, cervical vertebra should be parallel with the surface, is very important. Also, elevating of the head of patient is important for protecting the central nervous system from the high hydrostatic pressure effects. Midline and lateral border of vertebral column should be found and confirmed by using fluoroscopy guidance. After then, target level or segment should be defined and mapped as seen in figure 1 and 2. Endoscopic and working portals should be open under fluoroscopy control. In AP view, portals should be crossed each other in same level with the mid portion of the spinous process. In lateral view, portals should be crossed each other in same level with the inferior end plate of the superior vertebra, as known from the lumbar vertebra. During the portal opening procedure, some important tricks should be kept in mind. Cranial portal should be opened before, then caudal. Because of lamina's funnel shape and the dorsal angulation of the lamina, in cranial side is safer than caudal. If it is tried to open caudal side portal firstly, the needle or dilator can go towards the spinal cord. And also, in cervical vertebra, ligamentum freum is weaker than lumbar, so spinal cord injury can occur easily when needle or initial dilator is introduced toward the spinal canal from interlaminar foramen. In addition, in elderly cases, lamina can be weaker because of osteoporosis, so spinal cord violation is possible with needle or initial dilator, even in open cranial side before. In paramedian approach, you see the sequences. Everybody knows this. Surgery is started with the triangulation of endoscopy and tool. Then working space is created, and we will see it in further slides. You see here. When the camera is inserted the working field, we should see this picture. After then, we should describe our landmarks. Cranial side, and the lateral side, and the inferior border of the lamina should be seen firstly. Then, we start the surgery. We have sequences, but we have not enough time, so want to make faster the presentation. Inferior border of the lamina is an important point for us. In this step, retractor can be helpful to make clear of the working space. I prefer diamond high-speed burr in cervical and thoracic spine endoscopy. First, we can choose the 3 millimeter diamond tip, and then we can change with the 2 millimeter diamond. If you be safe your hands, generally we have to keep intact to the flavum during the high-speed burr working or bony working. But sometimes you need the more corrections or resections by using high-speed burr. If you feel the safe your hand, you can use the high-speed burr, diamond burr, after resection of the flavum. Now, we see preoperative and postoperative MR pictures. This patient was very comorbid patient. So we planned the anterior and the posterior surgery before. He was renal failure and the dialysis bounded case. But after surgery, after posterior, the patient feel pain-free, and the early neurological improvement was seen. Then we postponed the anterior surgery, but the case still waiting for anterior surgery. Let's see the interspinous approach. In this technique, interspinous space is the initial target point. Anteportal points are placed on about 0.5 millimeter lateral of spinous process or ligamentum naha. Portals are passing the skin and trapezius aponeurosis by sharp incision. And the splenius capitis and semispinalis capitis muscle fibrils passing as bluntly. Let's see the muscle anatomy in these depicted pictures. In figure 1, the portal entry points are marked with green spots. You see. Working portal is more centralized in interspinous approach for paramedian approach. The working portal should be placed as shown in figure 2 by blue colored area. In this approach, we can see the attachment points of the multifidus muscles on the flavum. The portals are placed just near the midline, as seen in figure 1. Portals are made interspinous area, as seen in figure A and B. Now, let's see the surgery. After opening the portals, we will see this view on the screen when endoscopy is inserted. After triangulation, we can start to create the working portal. We are using radiofrequency probe for this, as you know, from the other UV techniques also. This procedure is same with paramedian cervical approach, except portal placement. In this approach, we are working between two adjacent spinous processes. When we follow the cranial spinous process, base, we can find the interlaminar space easily. Sorry. How can I make? Sorry. Can you show me my? I couldn't see the cursor. Where is the cursor? Okay. Can you make forward a little bit? No. Okay. Can you make forward a little bit? Okay. I'm sorry we missed our place. Okay. So now we've seen the base of Spino's process. Sometimes to create enough space, we can do resection a little bit the tip of Spino's processes. You know, especially in the lower segments, the Spino's processes has the shape is widening. So you can make a little bit resection of Spino's processes. Now here see the Spino's process, base of Spino's process. Then you can see here is the midline. Seeing the midline also very important point. I'm using the arthroscopic burr in the beginning of the surgery to make further the surgery. And then I'm changing my the burr with the big diamond. This technique gives a chance to control both of sides of foramens and the lateral recesses. More than, actually it's maybe safer than the paramedian approach in the cervical area. In this surgery, we should be careful about the posterior ligamentous complex again. The interspinous ligament should be kept intact. After making thin enough the lamina, I'm using you see, I'm using just curettes or other tools for elevating the lamina, because the spinal cords already under the severe pressure. In the surgery, we need some if you add another pressure on the spinal cord during the surgery, after surgery you can see some problems, neurological problems. And also before then maybe we were called as a reperfusion syndrome, because after surgery sometimes we've seen in many cases the immediate neurological deficit after surgery. We called as the reperfusion syndrome. Maybe it's not true, because in anterior surgery, we doing the surgery in the extension position, of cervical extension position. And the dural fold can make a pressure on the spinal cord. The spinal cord already under the pressure because of the stenosis, so it's very important point. First, we're removing the superficial layer, then the deep layer of the flavum can
Sir,
remove.
Time is
okay, I'm passing. Now, you see the postoperative the results. After 24 hours hospitalization, the patient, the following Cervical collar can help the protective pain and reduce the pain. Early mobilization can be allowed. Drain can be removed after less than 10 millimeter drainage. Postoperative radiologic control should be done. Thank you for your attention.
Thank you, sir. So we just
Thank you, sir.
briefly go to the OT. OT में दिखाओ. And then we have some Mafatlal lunch symposium because we'll take a break for the lunch for 15 minutes because we are running off time. And they are just showing the design of DREP, which is developed by Dr. Malcolm Pestonji.
Okay.
Dr. Malcolm.
Yeah.
So just brief us about what have you done till now.
What I've done is I've tried to adjust for the entire lamina. You can see I've opened up the lamina here.
Which
We
L5,
we
L4?
need to increase the
This
volume
is
for
L4,
Dr.
5.
Malcolm's mic, please.
Your volume is little less.
Yeah, can you hear me now?
We can hear, but not loudly.
Bye team, आवाज बढ़ाओ यार. Okay, sorry. Guys,
Yeah,
can you
this is
see
cervical.
now?
4, 5, 5, 6.
Okay, now this is the full lamina C5. Yellow, please.
Okay.
1 minute, I'll just disappear some of this tissue. Yellow, please. Now, if you see my scope is vertical.
Okay.
So I'm at the C45. Oh, sorry, I'll have to come out. Just 1 second, guys, please. Gauze, please.
Sir, can you just orient us?
Just
An
1
endoscopic
minute,
view?
1 minute, please. I just had a small stain mark on my scope, so I had to get my scope out. 1 second, please. Let me get my scope back in and get back to orientation and then answer you. Okay, now we have the scope back in. This is the entire C5 lamina. Can you see here? Going
Yeah.
up. I'm going up on both sides of the C5 lamina. This is the C4-5 side.
Okay.
Okay, and unfortunately, since we are trying to do laminectomy and phlebectomy from both sides, so it requires a lot of tissue dissection.
Okay.
And the 2 mm plasma is going to take some time. But this is the C4-5.
Just orient us about endoscopic
this
view.
is the C4-5.
Okay.
This is the upper edge of C5.
So, which is cranial caudal?
This side, the red thing is the cranial, yaar. ये lamina C5 है, ये C4-5 है. Okay, this side is cranial. This is cranial.
3 o'clock is cranial?
Yes.
Okay.
And this is the upper edge of C5. This is the lamina of C5. Now I'm coming towards the C5, C6 facet joint.
Okay.
I'm stripping that also. Okay. I have to clear up a little bit. Then I have to get into the C5, C6 foramen.
Okay.
Free up that route. And then I'm going to start with the phlebectomy and the laminectomy.
Okay. Meanwhile, we will finish the lunch symposium.
Please.
Okay?
It will take about 15 minutes for me to be ready.
Yeah.
So go ahead. Touch, please. Come on. Blue.
वो चालू रखो.
Yellow.
Miss Priyanka, where is the lunch symposium? Outside? You only here, no? Try करो.
Hello everyone, good afternoon. This is Mr. Bimal Javeri. I am the business head of healthcare and hygiene representing Mafatlal Industries Limited. As we all know, Mafatlal Industries Limited is a 117-year-old textile company renowned for their famous cotton fabrics, and they have been present in this market for the last 117 years with school uniforms. I have joined Mafatlal 2 years back, and Mafatlal is now entering into the healthcare foray with their offerings of the hospital uniforms, be it scrub suits, be it patient suits, be it aprons, lab coats, or even corporate uniforms. Today, I am here to talk about the infection control platform that we have just entered with Mafatlal. Infection control, I have been in the field of infection control for the last 30 years, and basically, we are very strong in the manufacturing and marketing of surgical gowns, surgical drapes, and surgical packs, which are customized as per the individual needs. Having said so, we teamed up with Dr. Malcolm Pastonji, and we developed a unique endoscopy spine drape, which has never been introduced before, and we are introducing there for the first time. I'm sure most of you all have got a chance to visit our stall outside and have seen the drape. This drape caters to all needs of all forms of spine endoscopy, and the special drape has been done with a special net inbuilt in the drape to collect the flava bone and the clot debris. Extra long side panels have also been given so that the C-arm movement from the below the table should not lead to any asepsis. At the head end, a special surgical screen has been built so that no separate draping is needed, and one drape is enough to cover the patient completely. This drape can also be used in all the open spine surgery. So with this, I also want to introduce you that we are into each and every faculties, be it cardiac, gynec, ortho, urology, ophthalmic, general drapes, surgical gowns, and the likes alike. So I request everybody, we will be passing on this leaflet that Dr. Malcolm has designed, and my request to everybody is to please forward all your inquiries and start using this drape, since it is one of the unique kind to be used in the endoscopy drape. This is the pack. It comes completely sterile, and along with this, we can also customize it in the form of a pack where we could give the Mayo trolley cover, instrument table cover, surgical gowns, and so forth. Thank you very much. Avinash, can you please distribute the literature? Thank you. Thank you all for listening to me.
अभी लंच पे गए
हाँ चल रहे थे ना अपन, अपना आवाज भी तो बकबक होने देना, लंच हॉल में भी तो टीवी है ना.
ओके सर.
Is my voice going there? That you confirm to me, please. Stop, please.
वहाँ पे कॉल करके.
Okay, give me blue.
Yes, we just confirming.
You see, this is the advantage of using a curved probe.
Yes.
I'm using a tonsillar probe, and you can just see just by rotation of my tonsillar probe how much sector area I'm covering. So when you're working at the base of the spinous process, or when you're working in the facet joint, especially cervical facet joint, there's a lot of tissue inside. And you want that joint properly open, you want yourself, properly aligned. Now we have got two facet joints opened in front of us, okay?
Yeah.
Ah! Blue, please. माइक वाला ने कहा अक्कल है क्या करते थे? Because it's myelopathic now. Wherever we touch, it's going to bleed. Okay. We have to be prepared for it. But this is the V spot of the 4-5. This is the V spot of the
5-6.
5-6. See? This is the bone. This is a touch blue. Yeah. So I know, but you have to touch it, no? Yeah, we're having a little bleeding coming from all these muscular tissues. Can't be helped. Okay. Now I'm going to start with the burring of the facet joint, okay? So, and what I've been using is a curved tonsillar Bonds probe. What I'd formerly used was a 90-degree probe, and when we go close to the root, we'll be using a pointed tip probe. So, we need all these things in our armamentarium when we are working in the cervical spine. You can't touch a cervical spine if you don't have these three probes with you. I would not advise you. Touch blue, please. So this is the interlaminar tissue also. Thinning it out a little bit. Okay. Be very careful and gentle that you don't hit the flavum or deeper to the flavum. Sometimes the flavum is even absent in the midline in cervical spine. It's a known phenomena. So you have to be very careful and very gentle. Okay? So good. Now stop please. Now we are marked. You can see the flavum below. You can see the V spot.
Yes.
Okay? So now we're going to start with the process of burring. So we're going to start with the foraminotomy. Okay?
Yes.
Then we'll see what more we need to do and how we need to do, and keep on increasing our footprint. But the first job we want to do is secure the root. So here is the V spot. Here is the V spot. I'm using my scope and burr as a retractor right now. And we're going to start burring the V spot. Now I'm going to burr away the IAP, that is the superior mass first. Come on, burr. Because the inferior mass is going below it.
Yes.
And that is where the root is. You understood?
Yes.
So you don't directly target the V spot completely. And you sort of, take a mental judgment. My one burr is around 2 mm. So if this is 1 mm, 2 mm, then this is another 2 mm. So I've come around 4 mm out. Now if you, in cervical spine, the mechanics is something different. Any zygoapophyseal process or even OLF process, however much it grows, it's not going to grow beyond 5 or 6 millimeters beyond the IAP line. You understand?
Yes.
So zygoapophyseal joint and the AP is your landmark. And keeping that landmark in mind, now see we're burring a little of the IAP, nicely rounding it up. But what is below us? Stop please. What is below us is the bone. Can you see this?
Yes.
So this is the facet joint. Burr a little more. I'm going a little up here towards the canal side. Okay, towards the central canal side.
Yes.
So I'm going around the pillar of the IAP or the superior mass. Okay?
Yes.
So that when I open up, I know where the shoulder of my root is. You understood?
Yes.
हाँ तो मुझे उस shoulder के लिए उतनी जगह बनानी है.
Yes.
So I'm doing that. But I'm not going too much laterally. You understood?
Yeah.
Lateral extent, be careful. Otherwise, you'll have facial instability.
Yeah.
Now see, because see the advantage of what we are doing. Because we have crystal clear vision. Now I'm going down. I'm going to go deeper. And I'm going to work upon the inferior mass. Follow?
Yes.
So below me is bone. I'm pressing down on bone. And as I burr away the inferior mass, you'll start seeing it thin out.
Yes.
Okay?
Yes.
So here is where you have a little patience. You don't hurry up. Okay?
Otherwise, may end up with.
Yeah, you don't want to enter the canal. And if I want to enter the canal, my entry in the canal should be lateral.
Okay.
I always prefer to enter laterally into the canal, never medially. And I never go for a direct laminectomy. I always prefer to do this, and especially if a root is involved.
From lateral to medial side.
Yes, so that I'll tell you why. Because that way, I know how I can enter lateral to the myelin, central myelin. Follow?
Yeah.
Entering to the central myelin has its own advantages.
Hello. Yeah.
Yeah, hello. I hope you all are having a nice lunch.
Yeah,
but I'm starving here.
we are also seeing your surgery.
Okay,
But
thank
we
you.
want to start our next session because we are almost
You
1
see,
hour late with the
Arey
time.
Baba, you do what you want to do. This is the SAP or the inferior mass which I'm burning away now. So I'm opening up the V spot slowly.
So I'm asking the Yuda Shakti, Dr. Yuda Shakti, to share the session.
You go ahead and don't be disturbed by me.
And Dr. Diego Oliveira.
Anything critical, I'll cut in. Okay, guys?
To chair the session.
So, okay,
And
चलो.
Dr.
Now,
Masato Tanaka.
हमारा IAP किधर है? Inferior mass किधर है? Superior mass किधर है? दोनों define हो गए?
Yeah.
Stop. Bingo. Now can I have a dissector?
Yeah.
And now what I'm going to do is I'm going to change my position a bit. I'm changing my angle of my camera to make myself a little from vertical. See, I was like this.
Yes.
Now I'm trying to see things a little like this. Can you see?
Yes.
Now because I'm trying to see things like this.
So our next talk is, we'll finish the talk of Dr. Jalali.
See, now I've entered lateral
Rudolfo,
to the
you
myelin.
are-
Can you see?
Yes.
After
Yes.
that, we'll talk.
Huh?
Okay, after him.
Now entering lateral to the myelin means scan safe.
Sure.
Please, Maxime.
And now I will open up the facet joint. So give me 2 number.
Okay.
Now start with 2 number. We'll open up the root a little, then we'll climb up and we'll do the rest of the laminectomy. And then we'll go for the upper root, or maybe we'll do both roots and then go for the laminectomy. Whatever we feel like, we'll do it right now, but we'll do it.
Thank you very much again for the second time. I hope this time my videos don't wrong, okay? This is a specific and difficult topic because everybody here, although the spinal surgery, endoscopic surgery, have problems like this, like patients have other surgeries, other type of surgeries do it, and other doctors see. Doctor can have the answer, the true answer. That is not my problem. Please go with and return with your first surgery. And when you're talking about to the rescue surgery, maybe you're thinking about this. This is because have a trauma, have a something like this. But the reality, we know, this is patient like this. These patients have 6 screws, have 3 surgeries before, and have many problems around to that spinal. You know the storm is coming. You know this is very difficult. You know maybe you don't take that patient. That is better, no? Because maybe you have an explosion. You have a problem around that. Okay. This is a female, 72 years old. 3 intervention before to see me. He have the last intervention, have screws in L2, L1, L2, 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 L3, and have a laminectomies L5, L4, L3. This is the screws, this is the lateral view, axial view, and this is the surgery. When you start the surgery,
Stop.
please, man, please,
Chota kya rahe,
the video. No. What happened? Sorry, give me 1 second. When you start this surgery, you know that the tissues are very, 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 very hard, and you have cicatrizations, anatomic modifications, and you need to know the surgery are very difficult. For this reason, I do it every time this surgery under neuromonitorization.
Okay.
I don't know what happened with my videos. No. I don't know what happened. I need to check that. Okay. And in this moment, it's difficult because you need to know the anatomy is changed everything. The blending is different, and you know the dura madre is very close to these tissues because you have the cicatrizations. And at the moment you start to the surgery, you don't know when to stop. That surgery maybe it's a couple of minutes, maybe it's a couple of hours. You don't do it planes. Sorry.
So bad.
I don't have the video.
So
Sorry.
bad.
I'm sorry, but I need to show you that video for you to understand that. These patients, after the surgery, start walking again and say, I have pain, but it's less than the first pain. And say thank you, because right now I can sleep, I recover my life, and that's it. The other cases, a man for 64 years, 4 years before, have two interspinosus spacers, and have a radicular pain in the left, because one of these migrate from the left side, L3, L4, again, the same problem. And the problem is that surgery is possible to happen endoscopic surgery. No, it's necessary to open. In this video, I'm sorry again, show the Form 2 kit that's separate, and the people is great after the surgery. I can show the video again. I don't know why, but that's the principle. You don't lose the focus. Jordan say, if you start the thinking about going to win the championship, you lose the focus. You don't lose the focus. The principle is the patience. Don't do it more. Only do it the necessary for help the patients, like the example in the discussions topic. We have 40 patients like this, with these problems. This is the age about the patients. The medium is 65. And it's obviously more time to the surgeries, you have more surgeries. The indication for help this type of the patients is the decision of the best surgery the patients can be. Thank you very much for the invitations. We have a great moments with you. I'm sorry for the videos. Thank you very much, Dr. Malcolm, Dr. Hassem. Mexico is welcome for you.
Yeah.
Thank you.
Thank you, Dr. Adolfo. We just in between take Dr. Jalali's lecture because he need to go to airport for his flight.
That's why I take my computer. So, I'm Dr. Shai from France. Who asked me to speak about the specificity of Caucasian anatomy in ULBD. So the first thing that in Europe, they don't have so much pathology of cervical spine, like calcified posterior ligament. They don't see so much thoracic pathology. One time every 3-4 years. For this, they are very lucky. But we have a lot of patients with height incidence and a lot of old patients in good capacity. Sometimes you need to operate at 98, 92 because the patients are in very good conditions. So about the pathology, we can distinguish, we can have two kinds of stenosis. When you don't have lordosis, the stenosis is due to yellow ligament. The disc are collapsing, or your ligament make compressions. And when you have height incidence, like type 4, you have a big hypertrophy of joint. And the problem during the surgery is to face with very big hypertrophic joint. So when you have a stenosis due to yellow ligament, surgery is very easy. I'm seeing a lot of video today, yesterday, very nice. Stenosis, I remove the ligament on monoblock. This is piece of cake. But in Europe, we have a lot of hyperlordotic spine because it's anatomy of Caucasian anatomy. So for this, we are not lucky. And you have a lot of challenging cases. Sometimes you need to operate 3-4 cases like this. So I will show you a case I operated 2 weeks ago. 75 years old in great condition. He looks 50. You have no back pain, and you have only stenosis like it. So when you look to axial MRI, you see huge facet joint. You see there is not lamina at all. The lamina is very small. It's a huge facet joint. And in this case, you don't have choice. You need to make vasectomy. So the most important thing to know about UBE, when you do UBE, you work in this direction. In micro, you work like this. In UBE, you work like this. So in this kind of case, you need to come back to your lateral side to make arthrectomy and to make right decompression. So the first step when you have this kind of patient is to remove the superficial part of joint, because if you don't do it, you can't go to other side. It's very important. The first time you need to drill this. The second step, you need to do medial arthrectomy. And when you do this kind of surgery, at the beginning, you go to other side. You don't go to your side. You go of time to other side. And sometimes you are surprised that what I'm doing, I'm other side. Because UBE make you to go to other side. And big joint make you to go to other side. So after, when you do your arthrectomy, after you make your contralateral arthrectomy. In this kind of surgery, you have high risk of dural tear. High risk. You must inform your patient that you have high probability to have a dural tear. So the first step is to do arthrectomy. This is the inferior facet, but if you don't do this, you don't have access to contralateral side. You start, you must do this. It's very important. Excuse me. It's working, it's me, because it's a... So you make this, the first step, you make this arthrectomy. It's crucial. If you don't do it, you can't do the surgery. And after, it's like box. You're fighting against the case, or the case will win, or you will win. So you must make it more easy after. After, when you do this, you find a lamb, and you begin your arthrectomy. On this case, all case, there's not lamina, compressive lamina, it's the It's really the joint. You will need to remove a lot of bones because the patient, almost of times, is a man and they have a very huge bone. And this, you see, is a diamond burr. I recommend you to use diamond burr because that guys say aggressive burr is super. You will see this case. So you see the superior facet joint, and this is the inferior facet joint. Here, this is the superior facet joint. Okay? But in this case, when you go medially, it's very tough to go medially, so I'm decide to drill this joint. I'm decide to drill this because to make less bone. And when I'm doing with diamond burr, I found the dura. You don't have yellow ligament. You have nothing. So if I used aggressive burr, I make a catastrophe. So my advice, when you have difficult case, revision, some kind of patient, use diamond burr. And you need to do your arthrectomy. There is not laminectomy, it's only arthrectomy. And there is not instability, but you need to do this big arthrectomy. So for this kind of case, my first advice, when you finish your surgery, you make X-ray. Because don't forget, of bone, in fact, you don't remove enough. So do this X-ray. On this kind of case, sometimes on the facet, it's like a tent like it. It's very small, or you make a tear. When you operate this kind of case, high-speed burr, diamond burr. But when you do tear, nothing happens. Because it's all patients, the dura is like a nerve, so you don't have leakage, you don't have this kind of problem. But you must know that in this case, the strategy is to go medial. Because all time UBE send you to oversize. Thanks for your attention. Thanks all for invitation.
Okay.
And, every year, next year, they did the French spine endoscopic course in Grasse. It was the biggest course in Europe. We were surprised. The guys come from all Europe. I invite you, and I hope to see a lot of guys in Grasse next year. Thanks a lot for your attention.
Thank you, Dr. Jalali. We move on to the next speaker, Dr. Andera Sinagra, for his talk, Combined Transfemoral and Transsacral Approach for Alpha S1 Migrated Disc.
Hello. Hello. Hello again. I've heard very interesting things today. One doctor said in the morning that the best approach is the best approach in your hands. So this is about that. We will show you some cases in which we thought this was the best approach for the patient because it's the best we could do for them. And as Dr. Guerrero said, these are some rescue surgeries too. We will talk about combined transforaminal and transsacral approach in lumbar lesions. There you can see one of a double approach. I won't stop in history. You all know that there are many approaches and the history of our approaches since 1999 in advanced. The indications of transforaminal approach are non-migrated or low-grade migrated disc herniations, but not high-grade disc herniations. The principal obstacles we all know, and we heard a lot about it this morning, are the SAP, the cranial part of the lower pedicle, the osteophytes, the inferior articular process, and the iliac crest, especially in L5S1, high iliac crest, are a real problem. We also know that there are two grades of migration, high and low grade of migration. You can see the picture here. Also here, how a disc can go to the lateral recess, to the foramen, or can be extraforaminal. So there are many approaches, usually the intervertebral route for central, paracentral, and high compromise. Sorry, I'm bothering. Compromised discs. The foraminal route for foraminal, superiorly migrated, and for far lateral lumbar disc herniations. The suprapedicular route. And we are proposing the combined transforaminal and transsacral approach for some particular patients. Which are the indications of combined approach for us? Inferiorly or superiorly migrated discs, which exceed the transforaminal route. Patients unfit for general anesthesia, precluding translaminar or interlaminar approach due to comorbidities, and obese patients. We have talked a lot about transsacral approach, how we insert the trocar in the hiatus, we enter the endoscope. We can go, I want to make the video go. We can go from right to left, and also from ventral to dorsal with the sacral approach. You can see the catheter there. It's a simple procedure for an endoscopist. I will show you the cases now. This is case 1, 40 years old, hip reverse, with a burning radicular pain of 3 months evolution. And I would like to say to the doctor that talked about the timing of surgery, that I don't think that we should change indications in base of the procedure, that we have less complications in endoscopy shouldn't prompt us to go to surgery. I think we should be honest with the patient and present with all the facts, evidence-based facts of pain, and then make a decision with him. We should tell him that, or her, that it's possible that he will go well without surgery if he waits 3 to 6 months. And we shouldn't prompt surgery just because endoscopy has less complications. So this patient particularly wanted surgery because he couldn't work. He had a burning pain that couldn't allow him to work. You can see there he had a inferiorly migrated disc. So we decided, you can see him here, he couldn't even stand the position. He couldn't breathe. He made apneas all the time. So we decided he wasn't a patient for translaminar or interlaminar. He couldn't stand the procedure. So we decided to combine a transforaminal and a transsacral because it would be quicker and with less complications. You can see him here. This is our second surgery in him. He had another extrusion L4-5, and he had been operated with this technique too. He's a difficult patient. You see there how we mark him. And I will try to show you. This was the transforaminal surgery. You see the radiology there too. And some pictures of the procedure. The last one shows that we could liberate the radicular nerve from transforaminal approach, and we then went to the endoscopic approach to get the migrated part. You see there a disc fragment. There you see the disc fragment, the migrated disc fragment. So those are pictures of the procedure where you can see that there's no more migration there after we ended the procedure. This is our second case. This is a young woman, 33 years old, a hockey player. She appeared with a left foot drop. She had a disc extrusion, a big disc extrusion with downward migration, but she was on anticoagulation. She had a lupic factor and was seeking a pregnancy. So she started with foot drop, so there was no choice but surgery. So we decided that interlaminar would be a more bleeding chance surgery. So we decided to do a transforaminal and a transsacral approach. There you can see how we mark her for both procedures and the radiology of the trocar in place. Well, you can see the video out there. The two images show how we had the transforaminal approach and the epidural approach. This is the transforaminal part of the surgery. You can see the big extrusion there, the nerve root behind that. And this is the epidural approach to get the migrated part of the disc. You can see there we are using a laser, the red tip over there, to shrink the disc, and a balloon to bring the disc upwards. There you can see it, so it would be easier to get by the laser. This case is a 63-year-old woman with 120 pounds. She was improvised to. She had a, I will show you these two last cases are L4, L5. The L1, L5S1 is the best approach for transsacral. We can also use it very safely in L4, L5. It is described that you can use transsacral route for every level, but it's easier in the lowest lower levels. So this woman had a big fascicular cyst that had two parts. You can see there on the right, she had a right part, and here a left side part. It could be seen in surgery that it had clearly two parts. She had a very bilateral radicular pain, right and left, and she was claudicating. She was very worried because the pain didn't go away. So we decided, you see there the marcation. We decided to do a double approach. You can see there how we mark the transforaminal trocar in place. I will show you some of the pictures, videos of the transforaminal.
And then we are running out of time. Yeah.
You can see the cyst over there. It's quite big. This was the right part, the left part of the cyst. And this was the epiduroscopic phase. You can see the cyst there too, and how we open it with the laser. And we could solve the problem. I will show you now. Well, there you can see the part of the cyst, a photo of the cyst there. This is the last case, a 78-year-old patient. He was operated on for a spinal stenosis some years before we did that surgery, and we put an interspinous device in that surgery. He did well, almost 5 years, but he had a cardiac ischemia, so his cardiologist wouldn't allow any prolonged surgery. He had an intense L4, L5 radicular pain with claudication would appear suddenly, and he had this extrusion with a little cyst, facet cyst too. You can see the big extrusion over there on the left. He was really very symptomatic, and we decided not to wait. Here, see how we mark him for the two procedures, the trocar in place. This was L4, L5. same radiology. You see the both incisions, the transforaminal and the transsacral. I will show you some of the transforaminal time. You see the huge extrusion there. We had a big part out in the transforaminal time, and we went for the migrated portion in the endoscopic time. I will show you that here. You can see the nerve root there. You will see now a part of the disc. You can see how we are separating the root from the fragment, disc fragment there at the bottom, and how the space was cleared and the root was left free.
Dr. Andera,
at
we
the
are
end
running
of
out
the
of time.
surgery.
Just finish it up fast.
Yes. Conclusions. In selected cases, the combined transforaminal and transsacral technique shares the indications of translaminar and interlaminar approaches with less operative time and avoiding general anesthesia. It is equally safe for extruded fragments, avoiding neural structures, less steep learning curve than translaminar, interlaminar, and other techniques. This is our team. I would like to thank you all, and we hope to see you in Argentina 2025, start saving money, and we wait. You will know Messi's land.
Yeah.
You like Messi, you will see Messi's land. Thank you.
Yeah. So we are ready with our next speaker, Dr. Mahadipta. He will talk about endoscopic and block phlebotomy as a safer method for lumbar decompression. Meanwhile, can we just see the OT picture? Dr. Malcolm? Hello?
Hello.
Yeah.
Yes, yes.
Can you just brief us about your progress?
This is the C45 route.
Okay.
Quite a lot of shingling, quite a lot of low lying, so that we had to cut a lot of the IAP sector. This is the phlegm up here, which we are going to remove.
Okay.
This is the rest of the lamina that is left now.
Okay.
To remove between, so we are going to finish this hemilaminectomy, but I still to clear this route.
Okay.
But it's very badly plastered. Even a 2 mm punch, 1 mm punch is not entering over there.
Okay.
And I don't want to press down on the root and damage it, so I have to, struggle a little. And I've reserved that for a little later. After I do this laminectomy, I will go for that route.
Okay.
But right now, as you can see, the 4-5 route is completely free. This is the phlegm from the 4 lower border, 5 lamina, and we are crossing over to 5-6.
Okay.
5-6 lamina I've already split. I've split the phlegm also over there. But we will slowly now burr away this, and then we'll cut away the final little pieces. Okay?
Okay.
So,
Meanwhile, we'll continue
yeah.
the talk. Okay.
And thank you.
Thank you. Yeah. Yeah, Dr. Mahadipta.
Okay. Afternoon, everyone. Today I would like to deliver a light talk. So it's about me doing the fluffectomy using en bloc technique. I would like to address this for you who start to begin your career as the endoscopic spine surgery. So doing endoscopic spine surgery, you don't want to start your career using like severe stenosis like this one. So you want to try to search for the simple case, because if you see severe stenosis like this, you have to keep in mind there is a severe adhesion between the flavium ligament and the dura. And you, as time experience, will become confident, but sometimes you become overconfident. Like this happens to me. The video is not working. Wait. No, not working. Not this one, not this one. This one. Unfortunately, the video is not working. So the option of doing the fluffectomy is you can do a piecemeal and you can do a en bloc fluffectomy. At the early career of my endoscopic surgery, I do a piecemeal, but I encounter a lot of dural tear, so I switched to the en bloc technique. And you have to try to avoid using sharp tools like keratins, like Dr. Pao said, and also you have to avoid using a Rosenberg like this one. This is fortunately this is not my case, but you can see here the dura and the drill. You don't want to know what happened to this patient, of course. Yeah. So, yeah, this is my friend doing drilling using a sharp Rosenberg. So, flavium ligament is our friend, in my opinion. So you have to know the attachment well. Actually, you have to very well know the caudal part attachment of the flavium ligament, because it attached to the superficial part of the caudal lamina and also on the deep part of the caudal lamina. That part of the attachment on the caudal side usually is difficult to release using endoscopic spine surgery. And why do I choose using en bloc? Because all of my cases, early cases, maybe I do 30 cases using piecemeal, and I encounter a lot of dural tear. Since then, I switched to en bloc technique to limit the use of keratin punch. And en bloc technique is not a new. There's a study describing en bloc technique using tubular retractor. And this is the first time I see en bloc flavium removal technique when I do the short fellowship in Hiroshima with Dr. Yasushi Fujiwara. He do it using the microscope, and he called it semi-circumferential decompression, or SCD. And actually, the work is so simple. After you do all of bony work, like I always say, do all of your bony work first, and then you just need to release the, it's not working. You just need to release all of the attachment of the flavium ligament at each corner using a blunt instrument, like a nerve hook or like a nerve dissector, or sometimes some of you use curettes to release the attachment of the flavium ligament. And then you just need to do a flavium extraction, and you can easily extract that using forceps, but you have to keep in mind whether the flavium ligament is attached or not. So how do you see whether the flavium ligament attached? You can easily flip the flavium and see whether there is attachment or not. If you see attachment, you can release it by a blunt instrument or a sharp instrument. This is the surgical view. This is when I do it years. Now I do it with the semi-tubular tube to ensure the water flow is easy and flow is smooth, and also to easier remove of the flavium ligament. you can see I have a difficulty in removing the flavum ligament as a block because sometimes it's attached to the fascia, and you can see the flavum is nicely removed. And then you can see maybe some like a butterfly flavum, right? And this is pre-op. You can see a fully decompressed neural canal, but this is not working. So actually, this video I wanna show to you that you can see the attachment of the flavum ligament to the dura. When you flip the flavum ligament, you can see clearly the attachment. And usually the attachment is on the suspensory ligament, or some surgeons call the meningovertebral ligament. And then you have to carefully release it before you remove as an end block. Unless when you remove it as an end block, you will drag the dura and you will have your roots coming out. Okay, be careful when removing the flavum ligament as an end block. Make sure you see there's no attachment adhesion on the anterior side of the flavum ligament. So my mean time of surgery when I do a piecemeal, I only do 30 cases of piecemeal, is 39 minutes. When I already did hundreds of cases using the end block technique, and the mean time is very fast, 24 minutes. Although I encountered 2 patients for dural tear complication. So I encourage you to try to use the end block technique in order to make your surgery faster. You don't need to take the flavum piece by piece, and you take out your keratan and go in again, out again. It's waste of time, and it's safer to do the flavum ligament end block technique because you will encounter a less of dural tear. Thank you.
Thank you, Dr. Mahadipta. We will call the next speaker, Dr. Saifuddin Hussain, for evaluation of best relief.
Good afternoon, everybody. My name is Safruddin. I would like to thank the committee and especially Dr. Malcolm for inviting me to speak on our experience in biportal, endoscopic, and T-leaf, our experience. I'm coming from Indonesia. As we know that best T-leaf is now it's growing demand because it's less invasive, and not only for the, we do UBE for the stenosis only, sometimes we need to do the fusion surgery. And then everybody talking about the biportal interbody fusion is safe and effective. And combined a minimally invasive T-leaf and an endoscopic spine approach is favorable. So, and then at the end, they found that the better functional recovery by recovery faster after surgery. And then, as we find in the literature search, that most of the authors said the good and excellent outcome of the surgery of the best T-leaf, and more than, just like Dr. Paul yesterday said, more than 93% of the fusion rate. So we would like to present our experience in our center. In 15 months, we did 71 patients for the best T-leaf, and then mean age is 55, about 58.5. And there are several diagnoses like spinal stenosis with the foraminal stenosis, and then degenerative spondylolisthesis and ischemic spondylolisthesis. We did 1 level, 2 level, and 3 levels. The mean operating time is about 155 minutes. Then average length of the day stay in the hospital is 5 days. And this is the operating technique. We, after the standard technique in the best T-leaf, we do the triangulation and do the interlaminar approach, and then we did cut the fasciectomy, and then after clearance, we put the cage under endoscope. And the most important, you want to put the in the insertion point is more lateral to the pedicle, mid-pedicle line. And then we did the fixation and using the robotic for the putting the pedicle screw. This our clinical outcome. Most of the case are the outcome for the back pain and the leg pain are excellent and good, and ODI as well as very good. But we found a lot of complication, especially the subsidence of the patient is almost 10% of the case were subsidence, and in one infection and end up with a cauda equina, one patient, and luckily there were no dura tear. And this is our experience. So we concluded that we had a high complication rate, high subsidence, but technically it's not so demanding. So this is the example of our good. We did after this case after standard transforaminal endoscopy for the herniation, several months he did underwent for the best T-leaf because of the reherniation, and I did for best T-leaf for this patient, and this is the MRI, and then this is the X-ray after 15 months follow-up. There were no subsidence, and for the flexion extension, dynamic X-ray was excellent. And this is the bed. Some case end up like this. 1 day, 4 days post-op, we found that the case already subside a little, and then we tried to follow up 1 month, 3 months, and then actually some minor complaint of back pain or radicular pain, but at the end, 6 months, the subsidence more than 5 millimeters, and we need to take out the implant. And this is the worst case that 2 level best T-leaf, 7 days after surgery, he end up with the cauda equina, so we need to remove the cage. Then for your information, we putting the expandable cage, the titanium expandable cage. And lastly, I would like to invite you to our next meeting next month. We had a minimal invasive. We chair the ASEAN minimal invasive meeting. We'd like to invite all of you to join us. Thank you very much.
Thank you, Dr. Hussain. Next, we would like to invite Dr. Asrafi Rizki Gatam for his talk, Application of Robotic Navigation and Biportal Endoscopy in Single Surgery, the Technical Note in Experience.
Good afternoon, everyone. So, I'm Rizky Gatam from Indonesia. So today I'd like to share some of the other side of spine surgeries, which is the robotic navigation and biportal endoscopy, which can be done in single position lateral surgery. So I'm going to start with a case. So this is a severe listhesis, grade 2 listhesis. So this is a female, 70 years old with neurogenic claudication. If we see for the treatment option, we could have lots of treatment option. We could probably there are some of the surgeon that will do the compression alone, anterior fusion, posterior fusion, lateral fusion. So which of the option that we want to pick? So which one has a better outcome for the patient? So looking back from the history, usually when I start first doing the endoscopic surgery, I will prefer to do this kind of procedure. I'll do endoscopic decompression and do endoscopic fusion, preparing the disc space using endoscopy and everything. But the problem is that if you see from this lateral view, everything looks all right. But actually, when we see from the AP view, right after we insert the cage, we already break the end plate. So this kind of problem usually happens during the biportal endoscopy. Why it's happened? Because we usually stuck between the muscle. So when we put the instrument in, then the muscle gets in the way. So you could not put the instrument parallel into the end plate. So that's the main problem. So this kind of problem is actually happen directly on surgeries, and also when we follow up the patient, usually the subsidence will happen and the patient gets some back pain. So this is the view. This is another patient with this kind of procedure. The subsidence already happens right on the surgeries. So that's why we have to think another option for this patient. Because if we look from this image, there's a lot of option for fusion, for interbody fusion. There are anterior fusion, oblique fusion, lateral fusion, posterior fusion. If we are going from the posterior part, it's actually not a minimal invasive surgery. So we have to be honest as a spine surgeon, because when we put the cage or we are doing interbody fusion from the posterior part, we have to open the facet, we have to open the soft tissue, everything. When we do using the endoscopy, we actually make a hole inside the posterior part of our spine. So if we're going anterior or we're going from the lateral part, we dissect nothing. So we go retroperitoneally and then we go directly into the disc space. We only see the psoas muscle. Sometimes only the psoas muscle need to be retracted in olive or even in X-leaf. So this procedure, anterior or lateral procedure, is very beneficial for the patient. So if we position the patient on the lateral position, for example, we could have less retraction on the peritoneal content. The peritoneal will directly go down, and then we could see directly this space while after opening up the muscles on the lateral abdomen. And we could put a very, very big cage, end plate to end plate, which have a very, very stable position. It is the hardest part of the bone on the peripheral of the bone itself. And this is a true minimally invasive. And we could do a direct, indirect decompression with this kind of procedure. But usually, most of the surgeons don't want to do this kind of procedures because usually the problem is time for flipping the patient. You need to move from, let's say you're doing anterior or lateral, you need to flip the patient to the to prone position and put the pedicle screw in that position. And only few surgeons adapt this kind of procedure. So if we look from this study, directly after the operation, if we see the pelvic incidence minus the lumbar lordosis, it shows very, very good result in A-leaf or O-leaf, and comparing with the T-leaf. And another paper said that 50% reduction of the listhesis is already happening after interbody placement without the need to put a pedicle screw or everything. So this picture shows how powerful the anterior or lateral surgery is. You see that there is degenerative scoliosis in this image, and right after putting the lateral interbody fusion, and the curve is already gone. So how to insert the pedicle screw in single position lateral? You could do the insertion of pedicle screw using the image intensifier in a lateral position. There's already lots of paper saying that you could do like this. You see, I could put the pedicle screw in the lateral position using the C-arm. It's just a matter of convenience. When you try to do that at the first time, probably it's quite difficult. But by the time you get familiar with it, and you're getting more and more comfortable doing and putting pedicle screws on the lateral position. But there's a problem when doing insertion of pedicle screw in the lateral position. First is you see the convergency of the pedicle screw is less when putting the pedicle screw in lateral, because usually the trocar gets stuck to the table. Usually the location located near the table. So I'm pretty lucky to have a robotic navigation in my centers. So when we have a robotic navigation, we could plan the trajectory of the screws. We could reduce the time for flipping the patient. We could put the screws directly on the lateral position, and the trajectory is not becoming a problem. So like this video, I can first prepare the trajectory of the screws using all the softwares inside the robot. And then you see there's a robotic arm here, which is very rigid. And then we could put instruments directly, and we could see it real time on the screen here. So this is very, very, has a lots of advantages for us as a surgeon. And also for the navigation, we could, it is very, very useful for inserting and preparing the disc space. And so do we need the decompression? So this is always becoming a debate between the spine surgeons, whether we need a decompression or not in doing an anterior or lateral surgeries. So sometimes we see there is a patient with this kind of stenosis, very, very severe stenosis. So whether we need to do a decompression or not. So if we look from this article, there are several things you need to evaluate. First, whether the patient has a dynamic clinical symptoms. Second is whether the disc height is reducible in supine position. You can see from the standing X-ray and compare it with the MRI. And whether the patient has a motoric weakness and also a static stenosis. So, but you don't have to worry. As an endoscopic surgeon, minimally invasive surgeon, you can do a decompression in the lateral position. yesterday, our colleague from Thailand also already done that, doing the decompression on the lateral position as a single surgical procedure. So like this, the problem is that when you want to do as a right-handed surgeon, when you want to do a bilateral decompression, you need to do it from the right side, which is sometimes for some of the surgeon is not really convenient in doing that kind of procedure. But if we look at this graph, we also need to remember that there are some MIS benefit zone that we have to look at, because when we're dealing multi-level surgeries, probably open surgeries is much more beneficial for the patient, because if we combine the time of procedure and then the need for decompression and everything, putting pedicle screws, probably is much more easier in open surgeries when we are going on a multi-level procedure. So back to that case, so for this kind of procedure, first I put the screws on the lateral position using the robots, and then putting the intervertebral cage, and it's already reduced directly without doing nothing, just putting the intervertebral cage. And this is the results after the surgeries. You see, without any decompression, we can see that the spinal canal is already enlarged after putting the intervertebral cage. So complication always happen. So we have screw bridge. Even using the robots, there are also screw bridge, usually due to the skiving of the instruments. We have an anterior thigh pain, yes, because we are dealing with the psoas, O-leaf, X-leaf. You will have some anterior thigh pain. Because we are doing from the anterior, definitely you will have some vascular complication.
You are running out of time, Doctor.
Yes, yeah. And also some autonomic complication. So in conclusion, the lateral interbody fusion is very powerful, because we could have a big cage and wide fusion area, and we were able to do indirect decompression and reduction of the listhesis. So in combining lateral surgeries, robotics, and endoscopy, we can do true minimally invasive surgeries. But we have to remember that sometimes multi-level pathology and deformity, that the benefit of the MIS will be lost. So thank you.
Thank you, Dr. Gautam. Dr. Malcolm.
Hi, Bhupesh.
Just
I'm just
connected
about
to
to
OT.
finish my surgery now.
Hello.
Hi.
So,
Can
you
hear
finished
me?
with your job, or?
Yeah, I've almost finished. I'll just show you 1 minute. I'll take you around and बोलते ना जन्नत की सैर.
Just brief us.
Yeah.
Where have you
Now,
reached?
This is the C4-5 route which we have freed up.
Okay.
Come up. This is the C4 lamina.
Okay.
Flavectomy done. Gone up on the midline.
Okay.
Okay. Removed the entire lamina. This is the
Okay.
spinous process floating tip.
Okay.
Coming down onto the C5, C6 nerve root here. Now only
Okay.
little part of this laminectomy up till this border is left. And after that we can say goodbye. Hasta la vista, baby.
Okay.
Anything else?
Yeah. No, thank you.
Thank you.
Should we continue?
Yeah, you continue. I'm finishing with
Yeah.
this flavectomy. I've kept this last bite.
Okay.
And
So,
yeah,
I would
it is
like to
out.
invite Dr. Abdul Hadar for his talk on best decompression and recurrent pain, post-decompression and interspinous device insertion.
Bhupesh.
Yes, sir.
We are doing this surgery, patient's blood pressure right now. How much is it, guys? 120/90.
Okay.
Is myelopathic, so, and we have not used any pump.
Okay.
So we are obviously struggling with a little bit of bleeding. We have
Great,
to be
great.
slow, and we have to make sure we don't touch the spinal cord at any given time.
Okay.
Even while doing the flavectomy, I have to be very gentle in taking my position under the flavum. Like this, and then gently pull it out.
Okay. Great.
So
great.
this is the lower border of, upper border of C6.
Yeah.
C5 is gone, and this is the lower border of C4.
Okay.
Okay, guys. So
Yo,
this is a complete
great.
hemilaminectomy, and both routes, one route here, and going around one route here. Okay.
Okay.
So
Thank you.
thank you very much.
Thank you, Dr. Malcolm. Yeah. Dr. Abdul.
चलो, I think we'll call it a day. मुझे थोड़ा dispense दो. So we just clean up a little bit our mess. You can cut off the feed to the theater.
Cannot work. Need time. So you don't have type C like this, like this. No. Backup. Oh.
ના મારી પાસે પહેલાંના છે સૌથી 3 કેરીસ અને વુલ્ફના છે 2 કેરીસ 2 3 2 3 4 3 વુલ્ફના છે પછી આના હેબારના બી છે થોડા ઘણા નાના નાના ઇન્સ્ટ્રુમેન્ટ બધા હેબારના છે સારા છે ઇન્દિરાબેન સારા છે
Yes, 100. The video will work properly.
એ છે ને પણ પેલામાંથી જતા પુષ્પેને એનું જાડા છે થિકનેસ થોડી
Best decompression.
કયું છે હેબારો એમાં જ હશે પણ ઇન્સ્ટ્રુમેન્ટ થોડું નાનું હોવું જોઈએ થિકનેસ નહીં થિકનેસ નાની હોવી જોઈએ આ જે થિકનેસ છે એ નાની હોવી જોઈએ એ તો અંદર થોડું ઘણું હલે નહીં તમારે મેનિપ્યુલેશન હતા બધી જગ્યા પર ઇન્ટરનેટ મને સ્કોપ જાડો હોય બધી જગ્યા પર પહોંચી ના શકે તો ઇન્સ્ટ્રુમેન્ટ મૂવમેન્ટ હોવું જોઈએ
No, no. It's different file.
अरे यार उसको बोल Any technical problem?
Yes.
Good afternoon, everybody. And in this second talk, I will talk about biportal endoscopic spinal surgery, decompression in recurrent pain post-decompression and interspinosus device insertions. It is the interesting case. The background is, as spine surgeon, revision of spine surgery is something we must able to do even though it is very difficult. Sometimes faced with two equal difficult choice, leaving a patient in state of great pain or doing revision with considerable risk and complication. So this should be really be discussed with the patient and family. And another thing that will make it more difficult if the revision surgery is another spine surgeon is doing it. So came to us and might be revision with us. Then we have to find where the source of the pain, and spine pain management such selective the fruit block can help us to find out the source of the pains. It is my case reports. Male, 35 years old, he came, a patient who still developed back pain and radicular pain after post-operation, decompression and interspinosus device. The patient first underwent an open decompression procedure in interspinosus device by another surgeon because of herniated nucleus pulposus at level L4, L5. It is the MRI we can see in here that there was narrowing of spinal canal in L4, L5, yeah, this area. And then we can see in here there was any facet arthropathy in both sides. And we can see in here inflammation or fibrotic tissue surround of L4, L5 spinal cord. And the fourth, we can see interspinosus device insert from right side. Sorry. And the last, we can see in here that post-laminotomy, decompression from the right side. So my revision surgery action plan is interspinosus device insert from right side and decompression also perform the right side with big incision. So I decided to perform biportal endoscopic spinal surgery from left side to take interspinosus device firstly and perform decompression. Any three reasons that why I perform in the left side. The left side still natural area, so we can enter the dura very easy rather than right side because any fibrotic tissue in there. The second is from healthy zone, we can find fibrotic tissue, so we can go to the far side first and then to finding foramen very easy. And the third is try to dissection of fibrotic tissue if easy, but if hard, I just make the fibrotic tissue is floating. That's my revision plans. So it's my technique. First, I do a leveling in using undersea arm. It is my technique to leveling. I perform in 4F5 from the AP and lateral. And the second, I perform the removal of interspinosus device first. We can see in here, it is the spinosus device. Yeah, because the spinosus device is very large, so I make more incision to come out the interspinosus device. Yes, this is the interspinosus device that use. And the third, performing laminotomy using burr and keration from the left side. I do the using burr for acromyonizer because I am orthopedic surgeon, so very easy to performing using this. So I do in the inferior of lamina of L4, and then make larger using the kerations. And then the fourth step is release fibrotic tissue, and then from duometer gently perform flavectomy using keration Ronger. We can see in here that the fibrotic tissue, this flavum and fibrotic tissue make the very difficult to detach from the dura. Yeah, we're using the hook to make the release gently, and we can look in here the hyperinflammation, new vascularization surround of the area. And we perform control bleeding using 4 techniques in this case. Hypotension technique performed from the anesthesia we join, and radiofrequency and close and open technique I do because biportal any 2 portal, and when we go to the inside, we stop or we close the walking channel and make easy to control the bleeding, and increasing water pump pressure. So it is the final result. We can see in here the fibrotic tissue we cannot release completely. We make the floating of the fibrotic tissue in the dura, but make sure the right side and left side of the root is already released. So it is first operation. The final one is first operation more larger than second operation. So my conclusion is Biportal endoscopic spinal surgery can be option for efficient surgery with very satisfying result in this case. And endoscopic will always help and monitor our movement so as to help reduce the risk and complication of the revision surgery. Thank you very much.
Thank you, Dr. Halit. So now we move on to the next session. Yeah, thank you, Doctor, as a chairperson. Now I ask Dr. Kangtak Lim, he's here. Dr. Hayati, yeah, just to chair the session. And I'll ask Dr. Hassan, Gazwan Hassan, along with Hayati to chair the session. And we'll start with Dr. Ashok Lavange for his talk. Difficulty in mastering spine endoscopy. Yeah, you want some? Yeah. प्रोग्राम में क्लिक क्या होना प्रोग्राम है क्या अभी का माइक है क्या ऊपर स्टेज पे माइक दिख क्या होना
Good afternoon, friends, respected chairpersons, senior colleagues, and my young friends. If one has chosen spine endoscopy as a career and he wants to become a spine endoscopy surgeon after seeing masters in spine endoscopy performing discectomy fusions very fast, quickly, so he's intended or he's convinced that it's a good technique, minimally invasive, and all the advantages of minimally invasive surgery are there. Patient can go home early, can go to his work early. So one decides to go into a spine endoscopy. When I went through the complete program of 4 days, I noticed that there are many talks which says challenges, hurdles, difficulties, changing of journey from one technique to another, from tubular to UB, from MED to interlaminar. So why this is happening? It means a person who is doing tubular surgery, 100, 200, 300 cases, want to change to another technique like interlaminar or full endoscopy. So certainly there is something which is not uniform. Like in knee arthroscopy, there is only one system. There is only two portals. There are no other ways. But in spine endoscopy, there are different techniques, different modalities. MED, tubular, Destandu, transforaminal, interlaminar, UBE, PSLD. So what to choose? What to choose? Every method had its own equipment, different equipments. It has its own learning curve, and it is really difficult to decide which endoscopy to choose. So my advice would be, like in this meeting, almost there were all techniques were covered, and one should look at these techniques in detail and decide which techniques you want to adapt by talking, by discussing, by attending the particular person who is performing that particular technique. For example, Destandu by Dr. Srinivas Rohidas. So once you decide that you want to take transforaminal, So you must understand the instrumentation of this technique, because it is different to perform open surgery than endoscopic surgery. You need to learn these equipments by heart. And I would like to say, defer you are buying a luxury car for a year or two and buy good equipments, good endoscope. It is a big investment to you. It will help you earning money and buy a luxurious car after a year or two. So when you have decided, you got training from somewhere, and now you are ready for doing first endoscopy spine case. So the most important thing is you have diagnosed the case, low back pain radiating to right lower limb, particularly to the dorsum of the foot. EH is little bit weak. On image, you see there is a L4, L5 disc herniation compressing or abutting the right nerve root. And you are certain, you are sure that the pain is coming from nerve only, compression of the nerve only, and not from anywhere else, because low back pain radiating to lower limb may come from sacroiliitis, it may come from facet arthritis, it may be a piriformis syndrome pain. So you be sure that the pain is coming from compression of the right nerve root L4, L5. If you are not sure, you can take help of diagnostic blocks. Like in that debate we saw just a few hours before, which Dr. Bhupesh Patel presented. He arrived at the diagnosis just because of a one L5, S1 block, and he could do the justice to the patient. So be sure that whatever you are targeting, you are sure that it is the only pathology that is causing the symptoms to the patients. Why the learning curve is stiff or difficult? Because there are no specific books for a particular technique, or there are all the techniques, they are not in one book. So if you want to choose transforaminal, you may have to buy some books which are available now, or take guidance from the masters of this technique. This is not taught in your postgraduate curriculum, so definitely you have to start it from the zero. Patient selection is very important. Whatever you do, for the first patient for the endoscopic spine surgery, it is better to select a lean, thin patient, preferably a L4, L5 disc, and so that you do not have much problems while performing it. I chose transforaminal endoscopy as a beginning of my endoscopy career, and recently I have shifted to interlaminar endoscopic surgery because few stenotic discs or stenotic patients I could not give good relief, and few foraminal stenosis I could not give good relief with interlaminar. So whenever there is a foraminal stenosis, I go for a transforaminal approach. Whenever there is a central or lateral recess stenosis, I go for a interlaminar approach. You need to have experience. If you do say first 5-10 cases, you may be disappointed, because first case up to first 5 cases, you may get a longer time. You may be frustrated. You may be tired. But if you want to achieve success, you have to continue it, and case by case, you will have different experience. Your time will get reduced. Your equipment will work properly well, and you will start mastering the technique. In few patients, good results are not achieved. Some nagging pain remains, which leads to disappointment. But don't worry. Keep a lotus learning going on. Give him neuropathic drugs, pregabalin, gabapentin, ultraset. Tell him to do physiotherapy. And by 4 to 6 weeks, this will resolve automatically. The best experience is to learn from own complication. For that, you do the check MRI of your patient next day or a day after two, and see what you have missed. Whether you have removed the SAP, what structure you have left that is not addressed completely, so that the patient has not relieved completely. So do check MRI of your every patient who is not relieved completely, at least though not of every patient. Sometimes in performing satisfactory procedure, like you have removed a offending fragment, you have seen the pulsating nerve, pulsating dura, but you are a happy man at the end of the procedure. But next day patient says, Doctor Sahab, ye to piche mein dukh hi raha hai. I can't walk. I have this radiating pain. So don't worry. As I told you that wait for some time, it will resolve automatically. The spinal pain, it has a natural blessings of relieving or resolving itself. This is the most important factor of your learning, endoscopic anatomy. Initially, when you enter the disc, you see a white glistening piece of soft tissue. That's a disc. But when you want to remove some part of, say, some horizontal fibers, they come in. Then you think, what is this tissue? Is it a annulus? Is it a posterior ligament? What it is? So you learn this anatomy by heart, so that you don't find any difficulty in achieving your target, reaching your offending fragment. Initially,
sir, we are running out of time.
Yeah, just
do
1
little
minute.
fast, yeah.
So initially, when you like, if you want to make a bigger window in transfemoral surgery, and if you want to remove small part of SAP, so while using the power equipments or the cutting instrument, it's a fear in the mind that even a millimeter or two, if I go ahead, if I cross the medial pedicular line, I will injure the dura. So be careful, and with increasing number of cases, you will be able to handle this instrument very nicely. Many speakers have talked about this. So the take-home message is, study in detail about each modality and which modality you want to adapt. Do sufficient training with good large volume endoscopic surgeon. Learn the endoscopic anatomy by heart. Attend maximum cadaveric workshops and live surgeries. Practice on models. Watch videos of different surgeons frequently. Always good to have a colleague having experience, knowledge of spine endoscopy. So if you are stuck somewhere, so there is someone to guide you, that boss, this is the fiber, cut it. This is the annulus, cut it, don't worry. It is the entrapped magnet, go ahead, remove it out. So it is better to have. Initially when I started, there was no one to help me, but now we are 4 or 5 colleagues who are helping each other and getting the good results. Thank you, friends. Thank you.
Okay, I have a short contribution.
The next speaker is Mr. Naruzuman Khan.
Okay, just want to talk about this topic.
Question.
Just comment.
Sir, we'll take after session.
It's a very important learning curve, especially for the young surgeons, but we should always don't forget that the patients are not coming to us for our education.
Yeah, sure.
Yes, it's very important. It's a big ethical issue. Thank you very much.
Thank you.
Yeah. Meanwhile, we just see the OT picture. Dr. Malcolm, just connect to OT.
Hello, Dr. Malcolm.
Hello?
I think you finished.
Yeah, but the root is badly plastered, so I had to do a partial pediculectomy,
Okay.
osteotomy of this pedicle.
You choose the difficult case again.
Yeah, I can't help it. It doesn't come by choice. Touch, please, yeah, blue. You can see that all this is adherent. But now I'm freeing this adhesion. to make sure that the root is free.
Now you are doing radio frequency for disc?
Yes, by the side of the root, away from the root. I'm just cutting all the fibrous tissue. Can you see this? Now the root is becoming free. Now the root is becoming mobile. This root was stuck. I had to cut this bone.
Sir, just speak little louder.
I had to cut this bone. I had to do a partial pediculectomy, brother, to free this root. This root is so badly adherent. I'm using a Bond's micro probe, which has got a less than a 0.5 surface area, and which is allowing me to free this root. Stop, please. Now I'm using it like a dissector, and you can see how nicely I've mobilized this root, cervical root. Okay, we have gone from here also into the shoulder of the root, and this is also the root is free over here. We have opened up all the ligaments, membranes around the root. This is the cervical cord completely free. And coming to the upper level, this is the upper root is not so badly plastered. Just to clean out these little bone fragments. Thank you so much. Bye-bye and have a nice day.
Thank you very much. Good job.
Thank you, sir.
Cut it.
No.
Good evening, everyone. Good evening, everyone. Actually, Dr. Malcolm showed a huge surgery. This surgery I will show in a mono level. Actually, he showed the two level, and in between the two level, he removed the lamina. But my case is mono level, and because of different indications, that is important issues. So the chairperson, faculty, delegates, welcome everyone. I am Dr. Nuruzzaman Khan from Dhaka. Thanks once again to the organizing committee to invite me in this great fest of endoscopic spine surgery. Degenerative cervical radiculopathy is the dysfunction of the cervical spine at roots and both. Usually it is caused by the intervertebral foramen narrowing with encouragement of the neural structure of various factors like posterolateral cervical disc or foraminal stenosis by different osteophytes or bone formation. Cervical radiculopathy risk increases with aging, thus its incidence is expected to increase in the coming decades due to population aging. ACDF is the standard procedure for the operation of cervical disc herniation with radicular arm pain. This technique has the high fusion rate, with satisfactory patient outcome. But the problem is there some complications like adjacent segment degeneration, motion loss due to the cervical spine fusion, formation of pseudoarthrosis, and height reduction of the intervertebral space causing the intervertebral foramen narrowing, causing the again radiculopathy. This anterior cervical surgery problems are overcome by ADR, artificial disc replacement surgery. Regarding motion limitation and adjacent segment degeneration can be overcome, but these advantages are offset by complications including heterotropic calcifications and mechanical failure, spontaneous fusion, high financial cost, etc. These issues may be overcome with anterior cervical foraminectomy or posterior cervical foraminectomy with or without discectomy, without need of fusion or instrumentation. However, dissection of the muscles and disruption of the cervical structures such as facet joints and ligaments during SCF or PCF may cause some another problems like instability, kyphosis, or muscle dysfunction. The development of full endoscopic procedures enables surgeons to visualize the operative field very clearly and overcome these problems. This article concluded that PECD could significantly relieve pain and disability with no severe complications, and the majority of patients were satisfied with this technique. Thus, it is safe and effective to use this procedure in managing patients with such to managing these patients. There was alternative procedure, that is the ACDF has an alternative procedure as. This meta-analysis published as AO Spine in Global Spine Journal in 2022. They analyzed the outcome of the anterior and posterior endoscopic approach and concluded that there is higher success rate and lower complication rate associated with posterior approach compared to anterior approach, because you know the anterior approach, it passes through the disc. This article published in Clinics of Orthopedic Surgery in 2022 regarding the outcome of uniportal and biportal posterior cervical foraminectomy. And this article says that both the approaches are outcome same, but regarding the immediate postoperative pain relief, full endoscopic is better than biportal. So the indication of this procedure are foraminal disc herniation, foraminal stenosis or bone spur, ligamentum flavum hypertrophy or ossification, facet joint cyst, and ligamentum flavum cyst. And contraindications are segmental instability, kyphotic deformity, myelopathy, or the segmental association if there is infection, tumor, or fractures. In this procedure, usually done under general anesthesia with fluoroscopy, and patient in prone position, the head is fixed with tape. I don't like to use the pin fixator. The surgical table is on reverse Trendelenburger. Identify the entry point at lamina facet junction, which is confirmed by fluoroscopy. Skin incision usually 7 to 10 millimeter according to size of the telescope or endoscope used here. Blunt dissector is introduced, then identify the V point by filling with blunt dissector. Then the point is this point is confirmed by fluoroscopy. Subsequently, the working sleeve and was inserted over the dilator, and then the telescope. And after introducing the telescope, the overlying soft tissue is coagulated by RF probe. Then then identify the V point directly and start drilling. So the keyhole foraminectomy was performed at the center of the V point by drilling, not removing the ligamentum flavum first. First we use the drill, then Carrison punch, and finally the ligamentum flavum. This is the case of 42 years male patient, neck pain and right-sided radicular pain, hypoesthesia. The pain was not improved after 3 months of treatment with conservative treatment. MRI show right-sided paracentral and foraminal disc herniation. After proper all preoperative work, skin incision was made at C45 level over the V point. Dilator was placed and filled by filling the V point with the dilator, then and also with the C-arm. Then I introduce my 30-degree angle stenoscope. Usually I use 10 millimeter scope here. After introducing my endoscope, just remove the soft tissue over the V area, that is lamina facet joint area, and see the V point is clearly visible, that is which is made by upper lamina, lower lamina and the facet joint. Then started drilling at the lower part of upper lamina and upper part of lower lamina and the junctional area of the facet, and drilling is make the bone just like eggshell, then use the Carrison punch. Here I use the thin Carrison punch, that is 1 or 2, not more than that. After removing the bone, little part of the ligamentum flavum is removed. Excessive amount of ligamentum flavum is not required to remove here. Then at the axilla of the root, the disc is removed, and there is a little bit osteophyte which is removed by the osteophyte is removed with the disc. Residual amount of disc is also removed. This is the I retract the nerve by a cannulated retractor actually, and you can see the root is nicely decompressed. So this is the preoperative and postoperative MRI. You can see immediate postoperative MRI actually. So in this procedure there may be some complications. Transient numbness or dysesthesia may occur, which can be treated conservatively. It is self-limiting actually. Nerve root palsy and cord injury may occur. If there is cord injury, it is a very devastating, I think so. Dural tear is rarely occur. If there is any dural tear occur due to diathermy actually, or have some instrumental handling. If there is a small dural tear, it can be easily tackled with some substance. Yesterday you have seen that some Tacosil or absorbable sealant patches can be used here. If there is a larger dural tear, I think it can be converted to open also. Vertebral artery injury is a theoretical actually,
So
but theoretical complication may be due to misplacement of the dilator or working sleeve,
Dr. Khan,
and
we are running
wrong
time.
level
Yeah.
and wrong side surgery, that may be another complications. Just finishing. Main disadvantage of this procedure is a steep learning curve and high risk of nerve injury or spinal cord injury. So in conclusion, full endoscopic posterior laminoforaminectomy with or without discectomy is highly effective for the management of cervical radiculopathy. The decision of the use of this approach partly depends on surgeon's familiarity with the technique. With proper patient selection, with skillful handling of surgical instruments, it achieves excellent surgical results. Thank you all.
Yep. Thank you. Can I have a question to you? Some guys, they compare the posterior endoscopic foraminectomy that's you present with the ACDF. And you mentioned in the earliest, let's say, one of the options that's to do with ACDF, and it's a gold standard with high success rate. Do you think that it's fair to compare the two techniques? From my perspective, I think that the indication of each technique is different from each another. So we are totally dealing with the two different pathology that's dealt with the two different techniques.
I compare, it is not my article, I compare it from a article, okay? This is not...
Yeah, I'm talking about
okay.
your opinion,
Yeah,
let's
okay.
say.
Okay. Actually, ACDF, when there is indication that is purely in the myelopathic, when there is posterior cervical foraminectomy is not relieve the problems, then ACDF is definitely the indication of choice.
And also the posterior,
But
the central, the paracentral, the
yeah.
disc also included in the ACDF.
yeah,
It's not,
right,
not
right.
yeah.
Still, in open surgery, paracentral discs are doing with ACDF.
Yeah.
But you know, ACDF has some complications or some problems is there. There is some adjacent segment degeneration or fuse, reduce
Yeah,
the...
my concern that's in patients with planning for ACDF, you are not able to do a posterior endoscopic discectomy. This is the idea. You have to compare the open posterior decompression or tubular posterior decompression with the endoscopic, not to compare ACDF with the posterior endoscopic, because each one has a different indication.
Actually, no. ACDF open or endoscopy. Open or endoscopy, ACDF. If you do, it has a definitely, it should be done if there is myelopathic problem. But when there is radiculopathy only, you have a better choice than ACDF. That is, you can go posterior.
He is asking, these both are separate procedure. ACDF has their own set of indication and posterior foraminotomy has indication. You cannot compare both together. Foraminal disc is there, then you do posterior foraminotomy, and central disc with myelopathy or paracentral disc, we need to go anteriorly.
Yes, but
Yeah, okay.
but
Thank you.
radiculopathy cases, people are doing ACDF.
Sure.
Yeah, yes. I mean, I am comparing for that only.
Okay, that's good.
Okay, thank you, Dr. Khan. So we move to the next speaker, Dr. Baipak Paudal, and he will talking about disc pain generator percutaneous full endoscopic management.
Good afternoon. Good afternoon. Today I'm going to talk on discs, pain generators in the discs, and percutaneous full endoscopic management. All we know that there are different type of endoscopic technique, but as far as now, what is said that this Destando and biportal are endoscopic assisted and uniportal is true endoscopic, because as of now, what is the definition of true percutaneous endoscopic spine surgery? The surgery that is done with percutaneous stab incision with full endoscopic system that utilizes soft tissue dilation rather than cutting, and it should be done with constant saline irrigation, and it is also supported by EU consensus. So as of now, this is the consensus. And there are pain generators we find in the anterior column, middle column, and the posterior columns. In anterior column, this is mainly by the change in the discal pressure. And in the middle column, there are some of the neural, chemical, and mechanical changes. And from the posterior column, it's due to the some of the somatic, muscular structure, and the facetal structures. And today, I'm going to dash discs, the mid column I will concentrate today. Disc is important structure of the spine, and it is associated low back pain with or without referred or radiating pain. And in our practice, daily practice, which we encounter discogenic back pain and pain due to the prolapsed intervertebral discs and pain due to the stenosis. As we know that disc has two layers, annular fibrosis, and it has also subdivided into this outer layer and inner layer, and nucleus pulposus is jelly-like structure, and there are that disc lies between two end plates, inferior part of this cranial body and the superior part of the caudal body. And disc physiology, it is in the balance, homeostasis by the matrix production and the matrix inhibition and the breakdown of the matrix. So it is in the homogeneous. When there is some disturbances in homeostasis, the problem will arise. And the disc, as we discussed yesterday, that disc is innervated posteriorly by the synovial nerve and laterally by the sympathetic system, and the end plates are innervated by the basivertebral nerve. These are the pain generators in the middle column. And when this disc, painful disc, I studied that there is an ingrowth of the vessels and the nerve that I discussed yesterday, so I will just skip this. And there are extensive pain markers in the pathological painful discs and massive expression of the growth factor in this type of discs. So how to manage these pain generators that is produced by the disc? Discogenic back pain that I discussed about the physiology also. Initially, the normal disc, there is an internal derangement in the disc that leads to the tear in the disc. So because of that tear, though the nucleus pulposus or neural and or vascular, when it is natural form, but when there is disruption, there is a tear, so there will be a growth of the vessel and the nerve that gives the stimulation of the synovertebral nerve and the basivertebral nerve. So that is the pain generators in the discogenic back pain. So the treatment as far available so far is the transforaminal epidural laser ablation that I discussed yesterday. That I am skipping this. And what about the intervertebral disc herniation? So the pathophysiology is the same. There is internal disc derangement, there is a tear, and there is a herniation. So in addition to this stimulation of those nerves, synovertebral and basivertebral, there is a mechanical problem to the nerve, and there is a chemical things that pain substances arises in the disc. These are the pain generators. And we should tackle all these things, and how we can tackle is there are many ways. Open, we have MIS other tubular system, but the modern era can be managed with the endoscopic thing, either by the transforaminal or interlaminar approach. So we can tackle all kind of discs. And so we have a discussion always which discs to be started by the beginners. So as we have developed one grading system, this grading of the scoring of the surgical difficulty of lumbar intervertebral disc herniation with grade 1, 2, 3 like that, mildly difficult, moderate difficult, severely difficult. Like for example, moderate difficult is paracentral, mildly difficult is paracentral, and moderately inferior migrated lumbar disc herniation and migrated and central discs. Whereas severely difficult are foraminal, far lateral, moderately superior migrated discs, high lumbar level above L2, 3 level, high cannot compromise level, and grade 4 is extremely difficult. This we can say revision surgeries, calcified like associated with, and we have also the modifier like in sclerosis Lenke classifications, we have given the modifier also, so we can use this score. So if it may in the grade 1, but because of the modifier, it may have a high risk score. So just saying that it's a paracentral disc is a simple no. You have to see the modifier also before choosing your approach. So and now the RCTs are available for this. So there is an acceptable surgical option for the treatment of disc herniation by the endoscopic thing. And what about the spinal stenosis? In spinal stenosis, there is not only the injury to this disc itself derangement, but there is a problem with the formation of the osteophytes, hypertrophy of the ligamentum flavum. So because of this, there is a narrow canal, so the impingement of the roots, spinal cord, and the growth of this ligamentum flavum and the hypertrophic ligament that leads to the activation of the substances, mechanical pressure and root that leads to the back pain, claudication with without radiation. So according to the pathology, even in the stenosis, we have to manage this with an endoscopic thing that can be managed. And now there is a first in the world that's contralateral, this podcast endoscopic sternolumbar decubitation has been described by our team, and now there are a lot of literature, and that is a RCTs also. This is acceptable surgical option when compared with the MIS other techniques. So can be used, and same for the spinal fusion. This when there is nothing you can do after even with the pain elevating the other methods of pain elevation, or the remaining option is just spinal fusion because the pain generators are there either by the sinovertebral nerve and vaginal, because end plates we scrape, by fusion we scrape the end plates, so we are taking out the basivertebral nerves, and sinovertebral nerve is around the the posterior and posterolateral part of the disc, so we are taking out the disc. So the main aim of the fusion is taking out this all pain generators. So even this can be done with a endoscopic technique, and meta-analysis also support this. And there is a even fusion, there is a up to the 2 years follow-up that with a good results. And in remote, what we can do to elevate the pain from these pain generators, this is the era of technology. So there may be a technology of disc regeneration. We may apply that regenerative material into the disc by the use of the endoscope. So all these pain generators can be managed with this endoscope, and there is a hike of the publication in the journal about endoscopic thing, and also in the books. So the take and last slide, second last. So this is the era, golden era of the endoscopic spine surgery. We are in the go. So the take-home message is endoscopic spine surgery. We can manage disc hernias, has a strong foundation with this literature and the books, and we can manage discogenic back pain, stenosis, pain due to the stenosis, and also by the lumbar disc herniation, and endoscopy will be used as the visualized targeted delivery tools of growth factors as a regenerative medicine in future. So endoscopy is the future of spine surgery, so we have to learn today. Thank you.
Thank you for nice presentation. What's your opinion in what's called blind epiduroscope or nucleoplasty alone or laser that's done by pain management guys?
So
do you have investigates, or do you have any idea about it? Personally, I don't have any, let's say.
Actually,
idea.
you were here yesterday. I have presented in details about this. They're all modalities of discogenic back pain treatment. I can share.
Okay, thank you.
Yeah. Now we would like to invite Dr. Deepak Sreshta for his talk on fluid management and hemostasis in endoscopic spine surgery.
Good afternoon, everyone. Brings the lots of greetings from Nepal. After the very elaborative talk from my colleague, Dr. Bapak, I now bring your attention to very basic of all the endoscopic spine surgery, that is a fluid and the RF. So I have slightly modified the talk after listening to another colleague, Dr. Thapa, who has extensively described about how do you control the bleeding during the endoscopic spine surgery. So being a part of the endoscopic spine surgery team, whatever instruments or whatever materials we use, we need to know the basics behind that. or science behind that. So the fluid is the integral part of the any endoscopic spine surgery. So let's talk about the how does this fluid works and what are the complications if we cannot control the fluids accurately or properly. We know that fluid is required to create the space. We need a clear vision. That is the claimed advantage of the endoscopic spine surgery. And the fluid gives us a very clear vision of both osseous and non-osseous structures. We have seen for last 3 days that how clearly even the epidural vessels are clearly seen or visualized. And of course, the fluid also helps us to control the epidural bleeding. And it also, because there is a continuous irrigation, it helps to remove the debris of the bone or the other soft tissues. And at the same time, because of the continuous irrigation, the risks of the infections are also less. And you know, we all know that in uniportal, there is a biportal, there is an inflow, and at the same time, there is an outflow. And whereas in the uniportal, the fluid goes into the same track to the same seat, and the fluid also come out from the same seat. The continuous irrigations of the fluid is the critical factors, because if the fluid is accumulated, the vision becomes obscured, you cannot see clear the structures and increases the chances of dural injuries or other neural tissue injuries. But the pressure should not exceed more than 50 millimeter of mercury, and it should be remains between 30 to 50 millimeter of mercury. And the pressure depends upon that how high you have kept the bag of the saline, and it usually said that it has to be kept around the level of the head of the surgeon. And it also depends upon the flow, that how outflow is controlled. In biportal also you can manage the outflow with the blocking the outflow track, or in uniportal also you can do by closing or opening the gap. It has been also found that the pressure increases if the distance between the skin and the lamina increases, especially in the obese patients having a high BMI. If the fluid is accumulated, and if you allow to accumulate the fluid in the obese patients, that fluid also can increase the pressure and can injure the dural or neural structures. And similarly, the size of the outflow port also decides the pressure of the fluid inside. I've already said that the 50 to 70 centimeter above the ground is the adequate size or the height for the maintaining the fluid pressure inside. But usually, normally we don't use the pump, but if we require for a brief period of time, you can also use the fluid pump, but otherwise it is not necessary. It should not be used, especially in the cervical, but in the lumbar or other area, you can use the fluid pump briefly, but otherwise it is normally not necessary. But it has been found that increased intracranial pressures is created if the fluid pressure is increased, and it can cause the intraoperative seizures. I have seen or I have listened some of the colleagues having the seizures during the surgery because of the increased, probably because of the increased fluid pressure. It is also reported the blindness because of the increased fluid pressure. Similarly, postoperative headache, postoperative posterior neck pain, and intracranial hematoma has been also described because of the increased fluid pressures. And patients are reported to having a delayed recovery after the surgery if the pressure is high. And in transforaminal approach, there is a hydroperitoneum has been, obviously we have listened a couple of times in last 2 days. But sometimes, as I said, if you require the increased pressure to control the bleeding, in biportal, you can, squeeze the fluid, you can control the outflow, and uniportal also, you can close the port, you can, with the thumb, you can control the outflow of the fluid and control the pressure. It has been found that during the creation of the during the portal creations, the fluid, the pressure is around 17 millimeter of mercury, but when the phlegm is opened and during the decompression and the discectomy time, the fluid pressure is very high, around 35 millimeter of mercury, and once you turn off the irrigation, again the fluid pressure decreases. So during decompressions and the discectomy, the fluid pressure is very high, and you have to be careful during this phase of the time. But you have to also look at the history. The patients with the pseudotumor, hydrocephalus, space-occupying lesions, you have to be very careful before you think about the increasing the pressure, or you have to keep the pressures very low. Now let's talk about little bit about the radiofrequency ablations. So any electrocautery or any things which use the thermoablative techniques generates the heat. So heat can be generated by using the radio frequency, lasers, sometimes ultrasound, and sometimes electric cautery as such. The cautery which has been shown in this figure is the cautery used by this most of the time dermatologists. This is a true electrocautery where the heat and the light both are produced. But the radio frequency is the wavelength which comes into the lower frequency, longer wavelength, and non-ionizing. For example, the most of the, the common modalities we use, like radios or microwaves, they come into the lower frequency and the lower wavelength electromagnetic waves. And radio frequency, it lies between the hertz of 300 kilohertz to 4 megahertz. So these are the non-ionizing radiations. When you apply these radio frequency electrodes, it does not generate itself the heat. It does not produce the heat and the light. What it does is that it brings the water molecule inside the tissues into the higher energy state, and that water evaporates. The water inside the cell evaporates, they burst out, and that creates the vaporization effect, and that creates the coagulation effect. So this is the radio frequency. Radio frequency itself does not produce any heat or the light. So once this cell burst out, that creates the coagulation effect, or that produces the the coating or the ablation effect. Whereas the radio frequency plasma is little bit different. The plasma is not the electrical process. Plasma is a chemical process. What we call is a co-ablation is a short form of cold ablations. So it means the lots of heats are not produced. And this is, as I said, is a chemical process. When you apply the radio frequency in the medium where there's a sodium ions are present or chloride ions are present, it creates three different materials. One is a plasma, as shown in the left side of this slide, and the middle one is the tissue products, and third is the non-ion chemicals, for example, hydrogen ions or the oxygen ions. So these plasma, in fact, produces all the effects what you want at the cost of low temperature, not at the high temperatures. So that is why the beauty of using the plasma without increasing the temperature, without damaging the tissues, and with a very gentle and the precise way of applications, we can have a different effect of the radio frequency plasma, and that causes the hemostasis, that causes the dissection of the tissues, creating the epidural spaces, and it can be also used for annuloplasty. So if possible, instead of using the bipolar cautery, we should go for the radio frequency. Instead of radio frequency, if possible, we have to use the radio frequency plasma so that tissue damage is less. And these are the different electrodes used for the in monoportal or the biportal methods. And it has been found in one of the experiments that when in the dorsal horn of the mice, the radio frequency ablation was used at the temperature of 42 degrees Celsius for 120 seconds. And histologically, they found that there was no, in fact, permanent histological damage. There was only a transient edema, and fibroblasts were activated, and there was a collagens were deposited. But these all are the reversibles, and within 7 days to 21 days, everything came to the normal. So it is very safe to use the radio frequency and radio frequency plasma around the neural tissues, provided duration has to be very kept short. And normally temperature obtained ranges from 35 to 95 degrees, depending upon the fluid irrigation. In the absence of the fluid, of course, the plasma will be not produced, and it should not be used without the irrigations. Again, in another experiment, it has been found that within the 10 millimeter of the applications of your radio frequency or radio frequency plasma, the temperature is within our acceptable range, and you can safely use these methods for your dissection or the hemostasis. So in conclusions, keep your irrigations within the pressures below 50 millimeter of mercury, and you can use judiciously radio frequency plasma for hemostasis and the irrigations. And if you obtain both the hemostasis and the irrigations very clearly, the pictures you obtained is almost like looking through the microscope into the different hole. With a very small window, you can explore the horizon of the neural tissues, cord, facet joints, intervertebral disc space, and you can do whatever you do. And if you can remove the sometimes discs like such a big fragment, it's a relief for the patient and as well as the surgeons. Thank you very much.
So our last talk of
Yes.
this session, Mr. Alvar Masida, Dr. Alvar Masida, is talking about percutaneous stenoscopic cervical foramen anatomy of his technical note.
Okay, thank you very much, Chairman. And I'm happy to be up here again. I purposely, this is a PECD, percutaneous endoscopic cervical decompression. I purposely uh, placed the title as stenoscopy because I want to promote the term stenoscopy. Stenoscopy is a word coined by my mentor, Dr. Lim Kang Tek. It's a Greek word. It came from two words, stenos and scope. Greek word, stenos is a Greek word meaning narrow, and scope is to look or eye look. It's both a philosophy and a principle, focusing primarily on the decompression of neural elements in the whole spine. The word appeared in published literature in 2019. So now with this, I go with the patient, 48-year-old female. The most important, I would like to point out, most important part of this slide is the patient had suicidal ideation. She's in severe pain. Maybe you've seen patients like this, and you want to really help the patient and solve the problem. So she presented with a 4-month non-remitting right shoulder pain. Consult were done. Medications were given with minimal relief. Pain somewhat decreased in the on the 3rd month prior to admission. However, she developed progressive numbness and weakness of the right arm and hand. 2 months prior to admission, MRI was done. 1 month prior to admission, the pain recurred. Dosage of medications were increased. Rehab was done, but there was no relief. And she started having suicidal ideation. This is neurology. This is the MRI. So what do we do? The preoperative planning is key. It's 50% for me. It's 50% of the surgery. This is the OR setup. So for the positioning, I slightly elevate the head of the patient so to decrease the pressure, and put the surgical level flat. For this patient, she had a C6, C7 problem. So I localized the C6, C7. And the incision is at the midline. So I infiltrate local anesthesia, and I duct at the spinal laminar junction, not at the V point. And you can see here that the incision is at the midline. And I will have several slides to discuss this. So the incision is at the midline, then I slide paraspinous, so in the fascia. So when I close, it's always at the midline. And then I move, retract, so there's some inclination or oblique positioning of the sleeve and the scope, so I can cut through more in the inferior facet. So like this one here. Oh, it's not working. Okay. So this is the incision. And then that's going to the fat. That's the fascia. So paraspinous. Then going there to the spinolamellar junction. And finally landing on the V point. I had this experience that a patient for cervical laminoforaminotomy or stenoscopy would have like several days of limit of the range of motion of the neck, some pain there. And when I started doing midline incision and docking with some inclination, it stopped. So I use this entry nowadays. And you can always just check in the MRI how much facet you're going to take out. You have to be conscious about the calcified disc or spur. And you can see this in patient. You expect this in patient with chronic symptoms. And you can check for the X-ray or CT scan. In cases of calcified disc or spur, foraminotomy or unroofing is enough. No need, but you have to cut the foraminal ligaments to free the root. So this is a very important slide for me. You can plan in the MRI how much facet you're going to take out. And it has been emphasized by several lecturers already that you have to be careful when you insert your instruments, especially when the flavum is open because of the water pressure. Some videos up to the V point. And it's the same. You've seen all this and you're familiar, but this is for the benefit of our younger colleagues who are going to do their first cases of cervical decompression endoscopically. And through the excision, before this, removal of the disc material underneath the root. With the forceps. And I usually do a 360 evaluation for any remnant, this material. And very importantly, before closing, I go out with the scope slowly and cauterize any bleeder from the muscles. So that would probably lessen the inflammation and postoperative pain. That's how much incision in the midline with the drain. Postoperative imaging, pre-op and post-op. Sometimes you have to check with you're familiar with this? It's a double root. You have the dorsal and the ventral root. Sometimes if you're not clear with it, you'll think that the ventral root is the disc, and then you come up with a weakness in the patient. So It's lucky that we're doing this using endoscopic view, and it's very clear. But it's a real entity. The dural sleeve of the dorsal and the ventral lute is separate. That's my last slide. Stenoscopic cervical decompression with or without fragmentectomy is a good and rewarding procedure. High definition optics allow for very good visualization of anatomy, making the procedure very safe. Decreased infection rate, day surgery or ERAS, and it eliminates the implant cost and adjacent segment disease. Thank you for your attention.
Thank you, Dr. Elmer Metzeda, for your wonderful lecture. And I thank the chairman of this session, Dr. Hayati and Dr. Gazwan, for chairing the session. Could I now call upon the King of Thailand, Pon Papit, endoscope spine surgery in failed back spinal surgery. Thank you. Thank you. Thank you, brother. Dr. Jung, are you here? Dr. Jung, okay. Dr. Monu Singh is here, all right. Third talk. Dr. Marie Perez is here, okay. Bhupesh is here. Dr. Varun Agarwal, are you here? Varun? No.
Hello, hello, no sound. Hello, hello.
Lavkush Pandey is here. Dr. Lavkush Pandey.
Hello, can you hear me? Hello, hello. It's okay?
Okay,
okay.
we start?
Good afternoon. Thank you for introducing me. And I'm not a king, but I started the endoscope from the year 2008. And today I would like to share my experience. For the failed back surgery, we have the many approaches to deal with the failed back surgery. The first one is the transforaminal inside out. And the second approach is the transforaminal outside in. And in some cases, we have to perform the interlaminar approach, maybe on the caudal or the cephalad as well. And also, I would like to propose the new one is the oblique approach. It is the oblique lateral to the facet. Okay. Okay. I would like to start with this case. He is the male, 39 years ago, performed the microscope discectomy 6 years ago. And one day he sleep in the bathroom in the morning and food drop. So as you see, even this space is quite narrowing, but he have the sequestered 2 pieces of the disc. And then you look at this is the laminectomy from the microscope. And I decided to perform the transforaminal approach inside out under local anesthesia. According to the study of the Sang Ho Lee, he compared between the endoscope and microscope in the case of recurrence this herniation like this. And he found that microscope is slow, endoscope faster, because we approaching to the virgin zone. And also the hospital stay in the endoscope only 0.9, and the complication is less than the open microsurgery in the revision case. So this case, I perform under local anesthesia. I put the needle and put my dilator into the disc space, and then I remove the disc. It's quite very easy, take about less than half an hour, and you can see we can get the disc. Okay, and this is the endoscope wound compare between the microscope and endoscopic. And another technique is outside in. In the case of we cannot put the dilator into the disc space, so I shoot this technique. This technique I would like to review a little bit. I use the needle and target to this area. It's very safe area, right? It's a upper area of the lower pedicle, and you can see. In the case of very narrow this space, we cannot go inside. So we can approaching to the outside in the foraminal first, and then we can create the space, and we can go into the disc like this. In another case, we have the disc space narrowing, and I would like to show the relative, the superior articular process, upward migration and compression, the exiting nerve root. We have to consider exiting nerve root, right? We removed the part of the disc first, the part of the SAP first, and then we can do the discectomy or we shrink the annular ligament. Okay, for example, this case is 52 years old, and at that time, I performed the interspinous device, and the interspinous device worked well only 6 months, and then the patient come back again, and you can see the bony erosion. That means the interspinous space cannot hold the body, and the bone erosion, and this space narrowing, and SAP upward migration and compare the exiting nerve root again. So you can see the foramen on the right side and the left side is different, right? So we perform the transforaminal palsy under local anesthesia again. This is the 11-year follow-up, still good in this patient. And this is very common cases that we found in the failed back surgery. You see that we no choice, we have the pedicle screw, and you look at this X-ray, only 14 months, you can see the adjacent level kyphosis. But please be careful and don't jump to extend the pedicle screw. You have to ask what is the symptom and what is the cause of the pain. This is the MRI you can see. The MRI show the disc herniation at the end of the instrumentation level. I performed the transforaminal discectomy and cut some part of the SAP as well. So the patient is quite happy in this case. Okay. Another case is 37 years old female. She was performed the discectomy L4, L5, and L5S1 from the caudal equina syndrome. And 6 years, very good result. And the last follow-up, you can see, she have difficult to walk, and she feel weakness on the left leg, you can see that. But no pain at all, only weakness. And if you look at the X-ray, no sign of instability. And look at the MRI. Who can see what is the cause of the weakness? No. Very easy, you can see that. Because of they remove, radical remove of this, so they make the instability and the facet hypertrophy, and the facet hypertrophy compression the exiting nerve root. So if you see the CT scan, and you can see on the left side and on the right side is totally different. And I perform, this is more than 10 years ago, I performed the foraminoplasty under local anesthesia. And you can see the MI postoperative. And the patient follow up 3 months after surgery. She can walk well. Only in local injection, we can fix the problem. And another case, this case is quite difficult for me. He have the very complex cases and perform the L2 to L5, and then come back with the back pain 7, left buttock pain 8, and the right buttock only 2. And the first thing we have to consider is what is the cause of the pain, right? And if you see the MRI in this case, very difficult to find because instrumentation, sometimes the MRI not clear. So I recommend to make the CT scan in every cases of the failed back surgery. And you can see that on the left side. On the left side, L5S1, you can see the PAR defect on the left side, but on the right side is good. So the patient have pain on the right, on the left buttock. So I would like to ask you, what is the cause of the pain? PAR defect itself produce the pain or not? I don't know. Maybe from the disc, maybe from the facet joint, and the spinal stenosis also can produce the buttock pain as well. So we have to consider, we have to find what is the cause of the pain. So I decide to perform local anesthesia with the oblique lateral approach. I'm direct into the PAR first. Under local anesthesia, this is the PAR. And then I try to mobilize the PAR fracture. The patient say no pain at all. So then I jump and down, follow the pedicle into the disc, and I open the disc, and I use the RF to cauterize the disc, and the patient said no pain. So that means the disc is not the cause of the pain. And then I go to the tip of the rod, and the patient pain a lot. So I ask the patient to extend the back, and she cannot do that because of the tip of the rod impinge the bone and produce the pain. So I cut the bone, allow the tip of the rod. You can see the rod is too long, and the pain gone. So this is the way that I approach to the failed back patient. And also this patient, 89 years old, she is the surgeon mom. So she performed 2 surgery before and still pain. So if you look at the facet joint, and you will know the facet joint is the cause of the root pain. And then I perform under local anesthesia again and remove the parts of the bone. And this is the last case. 80 years male performed the surgery 20 years ago, and now he cannot walk. Very short claudication, about 10 meters, and severe numbness both legs, you can see. I performed the local bilateral foraminoplasty, and the patient happy for that. And our result with the endoscope in the failed backs, we found that allow the 90% of the case success. And we also have the 10% of the case still have the pain, and then we have to open surgery at the end. So I would like to convince you, all of you, to consider endoscopic first, and if you fail, nobody condemn you, and you can open revision surgery. Thank you for your attention.
Thank you, Dr. Bonpavit, for such information how to find out what is the plate black syndrome, the causes, and how to solve it. Could I request Dr. Pudel and Ashok Labange to take the chair? Dr. Paudel? Dr. Paudel? Huh? Dr. Shrista? Deepak Shrista? Yeah, okay. Deepak, please come. Okay. The second speaker is Dr. Jang from South Korea. He will talk to us on biportal endoscopic fusion in lumbar spine problems, spondylolisthesis and revision. I thought you already.
Thank you. Thank you. Good evening. I am Seokbong Jung, orthopedic surgeon in South Korea. I will talk about biportal endoscopic interbody fusion in lumbar spondylolisthesis and revision. Right one shows the three-level biportal endoscopic three-level interbody fusion. It took 3 hours. Biportal endoscopic surgery has a lot of advantages, but in biportal interbody fusion, especially no transfusion, quick recovery, no infection. Left arm is severe right spondylolisthesis. Middle one is post-operative X-ray. This is a video clip. Remove the facet joint, disc space preparation, and cage insertion. Left one shows the degenerative spondylolisthesis. Right one is post-operative X-ray. You can see the local bone graft, and we gather complete reduction. It took 1 hour 15 minutes. Hemoglobin level was decreased 13.4 to 12.3. Until 2 years ago, when I start the surgery, I do laminotomy using a paw. Since last year, I have used only chisel and osteotomy and punchy from the start without using a paw. Paw is not used to throughout the entire surgical process in interbody fusion. Right one is longitudinal cutting of lamina. Middle one is transverse cutting, and the last one, right one is laminectomy and removal of SAP. Pictures below show real endoscopic view. This is a short video clip. Longitudinal cutting and transverse cutting. Remove the bone fragment. You can see the remove the large fragment. You can see the ligament flavum and the medial facetectomy and removal of the ligament flavum. You can see the annulus and cut the annulus with the Indian knife, change the position profile and the disc space preparation and curate, and complete end plate disc space preparation, and local bone graft and strut bone graft and cage insertion. Additional insert. Before inserting the cage, we have to have end plate preparation, and we graft local bone into the disc space, and right video is show local bone graft through the funnel. Sorry, and I used solid degree scope from the beginning. Solid scope has wider view, especially for beginner. I strongly recommend the solid degree scope because it is very difficult to change once you can use it. First is 0 degree scope. And then first 30 degree scope at the same patient and condition. From 2015, I have performed 3,000 cases. Among them, biportal interbody fusion, 301 patient. 2-level fusion, 84, 3-level fusion, 8 patient. Spondylolisthesis, 203, revision fusion, 51. Entry point is very important factor to make it succeed. Are located above each pedicle because we should do a pedicle screw fixation through this incision. Right one is show post-operative wound. Our right region, we are standing on the right side of the patient, and we must grip digital portal and working portal with the left hand. But in case of lumbar stenosis and interbody fusion, you can change the location of the portal for sufficient decompression of hard to reach places. In other words, you have to use both hands in the working portal. When inserting the cage, we need to use the proximal portal because of step up from the spondylolisthesis. This is a video for your better understanding. This is a diagram step by step, laminectomy and disc space preparation and bone graft and cage insertion. When inserting the cage in spondylolisthesis, you should be careful of upper level exiting route. L3 exiting route, L4 traversing route, this space is working space. This patient is severe stenosis and lytic spondylolisthesis. You can do interbody fusion with biportal technique 2-level fusion. When you carry out the surgery for spondylolisthesis, there are several things to be careful for. Dural adhesion to ligament flavum, so dural tear occur easily. Exiting node because close to the disc space, and the cage insertion always proximal through the proximal portal, and facet hypertrophy because different from normal anatomy. Sometimes we can be confused. This patient is very severe spondylolisthesis, lytic spondylolisthesis. Right one is post-operative X-ray. We got a complete reduction. Next case, we did fusion surgery with the biportal technique. This was very severe lytic spondylolisthesis. We can complete reduction and fusion surgery. This case is change the portal position. First right, change the portal left side. So inserting the cage, we use through the proximal portal. This case is spondylolisthesis and severe stenosis and migrated disc. Two-level fusion. We got a two-level fusion with the pivotal technique. This patient dural adhesion to ligament flavum. When removing the ligamentum flavum, dural tear occurred. So big size. So I stitch one point, and then cage insertion, and stitch the rest. After that, we positive drain. You can see the exiting node in spondylolisthesis. Disc space preparation, you can see the exiting node very close to the disc space. We probe and root retractor protecting traversing node and exiting node. Revision fusion. This patient who underwent the decompression surgery 5 years ago, we did the two-level interbody fusion with the biportal technique. When we perform our revision surgery, bone working should be done first to locate the normal tissue, and then the traversing route should be confirmed before proceeding with the surgery. This video is bone working. First bone working. Remove the laminectomy. You can see after remove the bone fragment, you can see the normal tissue. After you medial facetectomy, and you can see the annulus adhesion. The dura is adhesion to the ligament flavum, and the cage insertion. Next patient is 3 years ago, restenosis. We can do the revision surgery with the biportal technique. This patient is the same. Biportal endoscopic fusion has a lot of advantages. And conclusion, using this method, all removed bone can be used as graft. Maybe I think this surgery will be a good surgical technique for lumbar interbody fusion. Thank you.
Thank you, Dr. Zhang, for showing beautiful series of perfect alignment and fusion. Could I now call upon Dr. Monu Singh? Monu Singh will tell us about Destandu endoscopic principle and philosophy. Is it modified? I request the faculty, if we have given talk during this session, not to go out because we are giving them the mementos. You have to give this. Okay. Call you on the stage. Just.
So good afternoon, everybody, and thank you so much for being here. In spite of going through a huge amount of presentations, most of them high-end, it is time for me to defend the pet horse once again. Thank you, Dr. Malcolm, for giving us this opportunity. So I would just be talking about the workhorse of Distendo technique, which has been there much before UB came in and became the crowd favorite. The philosophy of minimalism in spine surgery started initially with the advent of the tubular retractors. Once the tubular retractors came in and the visualization, the capacity was improved
Dr.
by
Monu Singh,
closed circuit
adjust your
televisions,
mic?
endoscopes.
Can you just adjust your mic? Height.
You want, it's okay now? Thank you. So things became much better, and it was advancement along with those tubular retractors, tubular endo sleeves came in. And of course, with the advent of the endoscope, it was possible to have the mobility to be able to go around into the nook and corners of the wound to be able to see. So as an extension of the tubular retractors, when the endosleeve came in, it was considered to be much less traumatic. Had one would insert it by just dilating the muscles, and it had the mobility. So considering the considering that the basis of minimalism in spine surgery, there are three factors that one has to look for: the mobility, the amount of invasiveness that the instrument has, and the visualization that one gets with this kind of instrumentation. So does Distendo score on all these points? Well, one would say visualization is excellent. There's a lot which is said about a saline irrigation with UBE, which improves the visualization, but if proper bleeding, proper techniques are used to control bleeding, the visualization, the picture cannot be any less in Distendo as well. Are we able to achieve the angulation or the mobility of the system? Are we able to do justice to a complete decompression posteriorly with this endo working sleeve? Yes, it is possible. When in 1993, Dr. Distendo designed this endospine system, it was to apply these three simple principles, or to be the core philosophy of his posterior interlaminar decompression system. So obviously everybody knows about the benefit. We are utilizing these techniques for a lot of benefits, which is reducing the amount of stay, the amount of invasiveness, the comfort of the patient. So there is so much that one can achieve with the simple application of technology to the standard system of procedure. So any posterior discectomy, applying these simple principles of a low invasive approach, getting a good visualization, and being able to move it around, I think it satisfies most of the requirements of a minimal invasive spine surgery. So does the size of incision has something to say about it? Yes. A lot is said about the incisions ranging from 10 millimeters to 1.5 centimeters or so. But something that everybody talks about Distendo being not a true endoscopic technique, just because the incision is on the higher side might not be that generous, because incisions can be as low or as comparable to other techniques. When you look at it in toto, sometimes they are not more than 1.5 centimeters at all. So the visualization definitely is an advantage. Having a video scope, having an endoscope which is able to see there, your eye is right there inside the cavity, and you're able to see everything very clearly. The issues of controlling bleeding are a separate issue, and when we are doing a dry endoscopy, one has to be very particular about it. So the system working as an endo sleeve with a working insert in it was designed so that one could always have the working instrument in front of the endoscope. There was no issues of triangulation required over here. One was able to see the instrument working hand almost all the time. The various sleeves were given various, there were openings which were given for the telescope, for the nerve root retractor, for the suction cannula, and for the working channel. They were all designed to be in 12 degrees angulation so that you would always have them together at a constant angle and there was no struggle involved. So when we talk about visualization, if you're able to control, if you're able to establish good control of the bleeding, you don't really need extensive, expensive, or different instruments. All you need are the routine instrumentation and the routine stuff which is required for your posterior decompressions. The visualization is very good. If you do not have a bleeder, identification of the bleeders, identification of the places where it can lead to a troublesome ooze is very essential. So that goes with knowing your surgical anatomy and being careful about where to place your gauze patties and how to coagulate your vessels beforehand. So the four essential advantages of this endospine system were that it was very mobile, it was very easy for us to move it around, and we were able to get very clear images of the system. The perfect quality of imaging was achieved unless it started bleeding, and that's where it got the bad name initially or later. So having your eye practically inside makes it very easy for you to identify and makes the whole procedure quite safe. And you are not, it is very difficult for you to end up causing any injury if the visualization is so good. So using this endo sleeve, it is very much possible to tackle most of the pathologies from the interlaminar approach. It is having a distinct advantage for patients who are obese because the size of the skin incision still stays the same and you're working at whatever depth, your instruments are still going through that sleeve with a constant angle. Almost all indications, a calcified disc, a foraminal decompression, for lateral root decompression, bilateral decompression, over the top decompression as in lumbar canal stenosis. It is very much possible to do with the same instrumentation. The anatomy, the approach, the surgical technique does not change. It is possible for you to decompress two levels very easily with this single incision approach with this instrumentation. It is possible for you to extend the indication as this case shows by Dr. Rohidas for removal of space-occupying lesions. This case belongs to him, which he shared with us so that it could be taken up. So in short, the advantages of this endospine system gives you a patient which can be mobilized immediately with very short stay. It is adequately safe. It is very difficult to miss out on a dural tear if it happens with this technique. You may sometimes miss it in a saline irrigated endoscopic procedure, but here in a dry condition, it is extremely difficult and it is very simple for you to observe and treat. So it is a procedure where you are able to get a satisfactory result for majority of the pathologies and you are able to see it very clearly. This is the edge stage decompression in a discectomy, let us say, and one can easily go in and inspect even the disc space if you are able to control your bleeding. The key point, the key word here is if you are able to control your bleeding, and that is where most of the training exhausts itself because sometimes we are too eager to move on and discount simple procedures. But yes, if correct methodology is applied, they can work fantastically well. So as in this case, one of the drawbacks for the Distendo for the endospine was that it was not possible to do any kind of fixations with this instrumentations, any kind of fusions with this instrumentation. Now the modifications are coming in. We are able to convert dry endoscopy into a saline endoscopy, and the modification of the sleeve is there so that we can put in a cage through that. Dr. Mukul would be showing it little later. So thank you so much. This is me defending my pet technique. I have taken up UBE, but yes, still a Distendo lover at heart. So the talk had to go in after a long session glorifying today's glorification of UBE. Maybe sometimes later we'll do a comparative thing too. Thank you.
Thank you, Dr. Monu Singh. Could I call the faculty of the last session to come in on the stage to receive the mementos? Dr. Jung, Dr. Jung, Dr. Ponpip. Dr. Jung, you have to do the honor of giving it to them. So, no, you give it to Dr. Deepak Shrestha. Dr. Ashok. Dr. No.
Dr. Monu Singh, please.
Dr. Monu Singh. You give it to
Dr. Ashok Lavange.
Dr. Ashok Lavange.
Dr. Namit, please come on stage. Dr. Amit Thapa also. Dr. Hayati, are you here? Or he's gone out again?
Amit Thapa. Can you give it to
Dr. Namit Nitharwal.
Dr. Namit Mitterwal? The new.
We'll start with the next session.
What about him?
This is Ali.
इसको दिया?
नहीं है, हयाती नहीं है सर.
Would you like to chair the session? Huh? Thank you. Could I call Dr. Monu Singh to chair the session? And Dr. Who's the side of Ashok Lavange? Huh?
Dr. Murat.
Dr. Murat, would you like to chair the session, please? I call upon Dr. Marisa Perez from Argentina. Monu, you're going, no? She will talk to us on surgical endoscopic anatomy of lumbar intervertebral ligaments and dorsal ganglia.
muy alto, me parece. Así, ¿no? Thank you. For this. Good afternoon. Sorry, this is my first lecture. I lost my first day. Yes. This is my pictures. I take these pictures last year in Mumbai. Thank you, Dr. Pestonci. Thank you, Dr. Hassan and Nicolas Santao. My name is Marisa Perez. I'm a neurosurgeon. I will talk about the neuroforamen versus intervertebral corridor endoscopic anatomy implications for extended and fusion surgeries through transforaminal approach. I will talk about this. The intervertebral foramen is the key to a successful and safe posterior access to the intervertebral disc. The intervertebral foramen, its entrance was described a Campbell's triangle, the most referenced figure in spine surgery. A lot of search in PubMed publications. The transforaminal approach has been long time used by different specialists. Nowadays, described in transforaminal lumbar intersomatic fusion and cleave technique and extend approaches, including endoscopic approaches. The old description is no longer enough and demands a new definition with a three-dimensional vision. The original description of this surgical corridor as foramen and the absence of the posterior agreement and use of interchangeable terms has led to confusion. To analyze the different anatomic terminologies used to clearly delimit the anatomic structures which constitute the fundamental surgical corridor. The objectives: to propose the abandonment of the term intervertebral foramen, to replace this term for intervertebral conduct, to describe anatomy and explain the root of the controversy. They present a formal definition of Campbell's triangle, a formal definition of transforaminal corridor. Finally, to recognize the three-dimensional geometry of the corridor, we propose the term intervertebral conduct. The term foramen is a Latin word for a hole or aperture. Instead, conduct means channels or tube. Foramen is a bidimensional 2D concept. And intervertebral conduct is a three-dimensional Cartesian coordinate. Defines an anatomical conduct with a system X, A, and Z. Not aperture, not foramen, it's a conduct. In Campbell's, in drawing his original drawing in 1988 of the triangle, describe an exiting nerve root is the anterior aspect the triangle. The thecal sac and traversing nerve root is the posterior aspect, and this space is the base of the triangle. What is mentioned in the description but not labeled in this diagram is the fourth side of the triangle, this is a SAP or SIP, which is the posterior aspect of the triangle. Therein lies the root of the controversy, that foresight is removed for the transforaminal approach described by Arms. In this illustration from the transforaminal lumbar interbody fusion technique described by Arms and Hesenski in 1998 is total removal the facet joint. The complete facetectomy and angle of perspective are the main difference in surgical lift. The SIP, the lateral border of the SIP, is an important limitation for the surgical access to the disc space. The omission of this structure has important implications for the surgeon. In this picture, this is a triangle, this is a free triangle. This is a video, but not working, yes. This is a transforaminal, and in 35 degree, this is a SAP and YAP. The materials and method, we made a morphological study of the intervertebral conduct in 15 cervical dorsal and lumbar cadaveric dissection with endoscopy. They were compared with 19 radiological studies. This is a no aperture, no foramen, it's a conduct. We can describe from anatomical point of view, we name a conduct: roof, walls, floor, and openings. This is a beautiful picture. This is a roof. This is an inferior aspect of superior vertebra, the pedicle border. This is a posterior, this is an anterior, and intervertebral disc, vertebral body. This is a vessels. The posterior wall, we find the pars anticularis and the zygapophyseal joint. Limited, the posterior, limited YAP and sub-EIP and SIP. This is important. This is a key, the surgery, the start surgery. The anterior wall posterior is a posterior border of vertebral body, as you know. The floor this is a superior border. The floor is a superior border, the vertebral body. The conduct content, the spinal nerve, dorsal root ganglia, sinovertebral nerve of Luschka, segmentary spinal arteries, intervertebral veins, and transforaminal ligaments. In this picture, you can see the sinovertebral nerves, ramo communicantis, L4. This is a lumbar artery. This is originated from sympathetic root, intervertebral disc, pedicle, L4. Content blood vessels and Batstone plexus, as you know. This is our dissection, the transforaminal ligaments. This is other dissections and dorsal root ganglions. This is other pictures. And this is a beautiful histological cross-section. You can see the relationship, the epidural space, flaval ligamento, and exiting nerve root. This is a fat tissue. This is important. And this is a ligamento flavum. A leaf anatomical analysis. The leaf procedure takes advantage of anatomical corridor that allows the compression of the exiting and traversing nerve root, access to interbody space in order to achieve simultaneous decompression and fusion. Leaf, it requires remotion of large amount of facet bone and this material to achieve satisfactory nerve decompression. This is anatomic analysis. This is Kim lines and Gu lines. This is a requires sufficiency end plate preparation and insertion of an interbody implant. The TLIF anatomic analysis, you can see view of the spine rotated 35 degrees is evident from this perspective. The superior articular process, it's a key to the surgery. The resection of SAP and YAP, you can see the thecal sac and free triangle. The geometric corridor that we have described in these three axes represent the integral conduct. The SIP, which was not defined in Cambis triangle, is now established as limited. In conclusion, we consider intervertebral foramen should be defined as intervertebral conduct. This describes better its complex anatomy, whose knowledge is fundamental for safe endoscopic approaches and for TLIF techniques. This is our team, Dr. Andrea Sinagra and me. See you in Argentina.
Thank you, Dr. Maris, for a lovely lecture. I now call upon Dr. Bhupesh Patel. Dr. Bhupesh Patel will talk to us on TF versus IL for migrated disc herniations. Which one is better?
So we will just quickly conclude the session. High migrated disc herniation, which one would you like? Transforaminal or interlaminar? Just we go to the basic. What are the migrated herniation? When herniation we call migrated where it extend above or below superior or inferior end plate respectively. You know, it can be extruded or sequestrated. Classification, this is old classification, zone 1, 2, 3, 4. We all know this classification, up migrated, near up, near down and far down. What are the surgical consideration when you deal with migrated herniation? We have a transforaminal technique in transforaminal inside out, outside in, modified transforaminal approach and interlaminar approach. First we just take step by step. First we take inside out technique. Here the angle of insertion. If the disc is migrated superiorly, we go below upwards. If it inferiorly, we go above downwards. You see the direction according to location of herniation. So if it above, then we go gradually increase our angle of insertion. If it down, we go more and more above downward. Second is position of cannula into the foramen. First is half and half technique. If it is a near migrated herniation, superior or inferior, we go half into the foramen and half into the disc, and then maneuver our cannula towards the location of herniation. Here hook is very useful. You see half and half technique. PLA it's seen half through the endoscopic view, and here you see the half and half view. Second is epiduroscopic. Here you just anchor your cannula inside the disc and then directly go to the targeted fragment. Third is outside in approach. You entirely stay into the epidural without anchoring the cannula and target your herniation. And modified transpedicular approach. Third is interlaminar approach. Now, for what are the options for inferior migrated herniation? We superior oblique pediculotomy. Here we drill the pedicle, medial aspect of the pedicle. Then we enlarge the foraminal window. Third, we do transpedicular. So we now go case by case. He is 45-year-old male with severe right leg pain since 3 months. We tried all conservative approach, including blocks, but nothing works. No neurology. You see there is a L2-3 highly down migrated herniation. CT, there is no calcification. So we tried transforaminally and we targeted the herniation with superior oblique pediculotomy. So initially we just identify superior facet and pedicular junction, then we go with high speed drill. We burr that junction and target the herniation and remove that part. You see there is a capsule. With RF we just remove that membrane and we remove the herniation. And with final inspection with the hook we just see whether we are not leaving any fragment. So postoperatively you can see the complete removal of herniation. Again, one 48-year-old male with severe right leg pain and recently developed a foot drop since 5 days, no ball bladder involvement. You can see here the herniation is entirely behind the L5 vertebral body and with root is medial to the herniation. So here we just here, what are our list? We are highly down migrated herniation, shoulder position, right foot drop. So here we tried modified transforaminal endoscopy. We call it transpedicular approach. What we did again, we go in discography and we target the pedicle. We start drilling with pedicle with trephine, and we reach the pedicle on medial wall, and you see when you reach the medial pedicle line, you just stay on the just enter into the posterior vertebra. You can see nicely decompressed now root, and this is a pedicular window. This is the pedicular bone we removed, and at the end of surgery we again reinserted, and this is a herniation. So patient with foot drop, I think recently developed, so he recovered immediately in the recovery room. Again, 54-year-old male with severe left leg pain, not able to stand more than 2 minutes, not able to sit more than, not able to walk more than 2 minutes, partial foot drop since 3 days. You see, and he underwent 5 years back, he underwent L4-5, L5-S1, laminectomy and discectomy. And this is a reherniation at L3-4 level. You see the herniation in the lower section at L3-4 level with no instability. But where patient is very obese, you have large previous scar, this is a recurrent PIVD, and left L3-4 down migrate disc with large foraminal window. So here again best approach is transforaminal. So we went transforaminally. So one more patient with 45-year-old male with right complete foot drop since 2 months. Again bowel bladder involvement since 1 month. Severe right leg pain and progressively increasing symptom. You see very huge disc is behind L4-5 body, and patients along with have a severe lumbar canal stenosis. If you observe this herniation, it starts from right side of the L4-5 and progressing behind the L5 vertebral body and go on to the left side at the L5-S1 level. The same herniation. So here, what are our problem? L4-5 highly down migrate disc, reaching almost at the level of L5S1. Severe stenosis, complete canal occlusion at L4-5 and also behind L5. And L4-5 right is more than left symptom, and L5S1 disc is more on left side than right side. So we need an approach which can address both stenosis and herniation. So I tried here interlaminar approach, monoportal. So we did both side flavectomy. We removed herniation as much as possible from L4-5 disc L4-5 disc level and from down behind the L5 vertebral body. Sorry. And this is a scope in scope technique. So we use interlaminar scope and then add the transforaminal scope just to retract the nerve root easily. So with transforaminal scope, a cannula, you have a mobility. Interlaminar cannula is little larger. So you cannot go beyond certain extent and cannot retract the nerve root. Chances of injury to nerve root is high. So usually entirely behind the L5 vertebral body. So this is L5S1 window. You see the direction here. We haven't go inside the L5S1 disc. We just go directly, just do flavectomy, 4-5 bites for the flavum, and directly go to the L5 vertebral body behind an axilla of L5S1 nerve root. And you can see entire vertebral body from behind only. Because it's a 30-degree scope. This is a transforaminal scope. So it's a 30-degree scope. You see the amount of reach. We can almost entirely you can cover. This is a post-op MRI. There is complete removal of herniation. So, and also stenosis is taken care of. So this last patient with again 48-year-old female with right foot drop since 15 days, severe right leg pain, walking distance is less than 3 minutes, standing is less than 3 minutes, no bowel bed involvement. Here again unique problem, the disc herniation is both up migrated and foraminal, you can see here, and again down migrated at the same level. This foraminal disc up and down migrated, both herniation. So again here, what are the problems we need to solve? L4-5 up migrated and foraminal disc on right side, L5S1 down migrated disc herniation on right side. Need the approach which can handle both up migrated foraminal herniation and down migrated herniation with a single incision. So we choose the contralateral interlaminar approach. We start drilling at the base of spine L4 spinous process and went directly to the opposite side without disturbing ipsilateral flavum or ipsilateral lamina. So we can reach on opposite side easily. You can see the axilla of this exiting nerve root and this is traversing nerve root is L4 vertebral body. We completely decompress and expose the axilla. And this is a exiting of this is a traversing exit of traversing nerve root. This is a pedicle, and we remove the fragment from behind below the L5 nerve root here. So with a single incision, single approach, we take care of both all three herniation, foraminal, up migrated and down migrated herniation. So again, this is a post-op MRI of same patient. You can see complete removal of herniation. Again, down migrated fragment, foraminal fragment is taken care of. You see, we didn't remove in the ipsilateral flavum, even we don't go to the same lamina also. We just go directly on the opposite side and remove herniation. So again, for me, the endoscopic discectomy is gold standard, even for highly migrated herniation. Pathology and level of herniation define your approach. You should not fix your mind. You should learn all kind of approach, technique of endoscopic, transforaminal, interlaminar, biportal, and do use appropriate technique for appropriate pathology. Due to high leg crest, I prefer L5S1 interlaminar approach. Adequate pre-op planning must be for the successful completion of surgery, and surgeon expertise is also important in migrated disc herniation. Thank you.
Thank you, Dr. Bhupesh, for a lovely lecture, great presentation. I now call upon we have from virtual presentation now of Dr. Salman Sharif.
Dear friends from the World Federation of Spine Endoscopy annual
Virtual
event from the
presentation
World
from
Congress
Dr.
on
Salman
MIS and
Sharif,
Endoscopic
President
Spine
of the
Surgery,
World Federation of
and my dearest friends Malcolm Pastanji and Sami Al-Mursi, and all the other friends who have been participating on behalf of the Spine Committee of the World Federation of Neurosurgical Societies. I really am grateful for inviting us, and also really thrilled to see such an event happening routinely. Today, I'll be talking about learning curve for MIS surgery. This is a part of Pakistan, and this is Nanga Parbat Base Camp, and this is Ferry Meadows. Same areas that we're seeing here as well. Well, spine surgery, we perform spine surgery. We need to access a target area in the body. We approach, create, and get there. Surgery is done, and the surgical path is closed. Despite normal anatomical paths, surgeons destroy normal and functional tissues and leave scar behind, which is functionally inactive, so footprints are left behind. A basic principle of surgery is to effectively treat pathology with minimal disturbance of normal anatomy, leaving the smallest footprint. Why MIS? Minimal neural retraction, contralateral anatomy preservation, shorter hospital stay, minimal postoperative pain, early return to normal activity and economic benefits. Concept was originally introduced about learning curve in aircraft manufacturing back in 1930s. He described a basic theory for costing the repetitive production of airplane assemblies. Term was introduced in medicine in 1980, mainly after the advent of MIS surgery. It is the time taken or the number of procedures an average surgeon needs to be able to perform a procedure independently with a reasonable outcome. Ability to identify an average surgeon is the question. The learning curve may depend on manual dexterity of the individual surgeon, background knowledge of anatomy, experience of the supporting surgical team, and the frequency of procedures performed in a specific period. New technology does not apply to all cases. Good judgment comes from experience, and experience, well, that comes from poor judgment. Training on inanimate trainers and animal tissue has been shown to facilitate the process of learning. The presence of structured training schemes and mentoring are also important factors. The slope of a learning curve depends on the nature of the procedure. Learning curve from MIS is longer than that of open procedure. However, studies have shown when inexperienced subjects are given equal training in laparoscopy and open surgery, the overall skills acquired were similar by both methods. Learning curve, its lack of clear anatomical landmarks, jaw and mystery attributed complications during microendoscopic learning curve period to unfamiliarity with the endoscopic image orientation and suboptimal approach to surgical target. This may lead to injury to neural structures, multiple durotomies, and at the same time, wrong level and unintended removal of facet. The key step in overcoming the MIS learning curve is an ideal entry point and trajectory during the surgical approach. So a correct initial placement of tubular retractor, for example, it prevents intraoperative readjustment, and because of that, can high rate of neurological injury and inadequate decompression. The two types of variables used to assess learning is patient's outcome and clinical process or task efficiency. Common patient outcome measures are the incidence of complications and survival. Statistical analysis is more complicated, hence operating time and period of hospitalization is used. There is no ideal measurement of learning. Various proxies are available. While we may agree on how to measure the learning curve, we cannot say how we should compare individual progress, particularly in dealing with real patients. So with the experience, the performance increases, and then it comes to an asymptote, and then from here on, there should not be a problem. It should be hunky-dory. Damaged nerves, smaller incision don't necessarily mean better outcome if the surgeon is not familiar with anatomy and exposure. increased radiation exposure. Recent studies suggest that MIS could lead to excessive radiation exposure and serious problems. So Silva looked at this carefully and they correlated with a steep learning curve. Approximately 40 cases are required before you're able to do something proficiently in the MIS surgery. So here with 150 TLIF cases, single surgeon, the overall complication rate up to 12%, and most frequent was the dural tear, and complications were initially very high and then coming down. And it took about 40 cases to get to a proficient level. So microendoscopic discectomy for lumbar disc herniation, surgical technique and outcome, 870 cases. So early cases, you've got the operative time of 75 going down to 49 and blood loss reducing, telling us that obviously your learning curve is up to that number. And if you look at this particular slide, comparing lemnectomy and microdiscectomy, and you can see again the time period keeps going down as patient gets efficient and experience. Failure is inevitable for humans. We are built to make mistakes, encoded for error. So we look at this study with 14 studies involving MIS versus SPLIF summarized. And they said extensive training experience is necessary, otherwise MIS TLIF may yield unsatisfactory results upon patients. Well, Nancy Epstein looked at this, and some studies have documented comparable long-term outcome for open versus MIS. Is the learning curve really worth it? And when we look at this, her in 2008, there was this kind of small number of cases, but with infections, it's a fistula, cauda equina, as the numbers go higher and higher, those deficits keep reducing. So telling us that obviously the experience, because of the experience, we are having less and less complications. We looked at this way back in 2018 for MIS surgery. MIS preserves natural anatomy and decrease perioperative blood loss, tissue trauma, pain, and stability. It has a shallow learning curve with multiple contributing factors. Learning curve is usually achieved after 35 MIS cases with significant decrease in complications and operative time. And this is the chart that we found that proficiency of surgeon, knowledge of anatomy, 3D understanding, surgical aptitude, manual dexterity, and frequency of surgeries. The progressive training is structured concept by a 3D computer cadaver under supervision independent. And then you go on to increase from injection to interlaminar to transfemoral to TLIF and ALF and OLIF. And obviously you need a trained team, a scrub nurse, a radiographer, and a technical support as well. So your plan could be that you could cycle from point A and B, but reality could be completely different and you could have all these harms in your way. And so you need to be prepared and you need to be aware of the problems. That's why I need to practice, practice, and practice. Complications associated with initial learning curve of MIS, a study that's discussed the learning curve in 14 studies. The most common complication is attributed to learning curve for decompression alone for durotomy. Total complication was up to 11%. So average of 20 to 30 cases were warranted to satisfy learning curve for TLIF, MIS pedicle screws, MIS ALF, and MIS surgery. Learning curve for MIS TLIF was up between 10 to 44 cases for different surgeons. So it depends on surgeon's aptitude, manual dexterity, and structured training programs are the main factors. Facilities for training and practice of surgical techniques have enormous impact on the learning curve, and training on inanimate trainers and animal tissue is vital to improve the results. So it was really my pleasure to give this talk, and I wish the organizers all the very best and hope to see you in person in near future. Thank you. Bye-bye.
Next talk is Sandeep Vaishya. Can you play that? It is MIS for intradural tumors. Role of MIS in intradural tumors.
So I'll be talking on the minimally invasive surgery for cervical intradural tumors. Basically, I'm talking about cervical, taking as an example, but the same thing can be done in dorsal or lumbar also. Generally speaking, people tend to do multi-level lemnectomies for these tumors, which can lead to potential instability of the spine in future. And most of these tumors can anyway be removed by minimally invasive surgeries. And the commonest tumors in cervical spine are neurofibroma, followed by meningiomas. Some of them are dumbbell-shaped, which may require multiple strategies or anterior and posterior approach combined. But most of these tumors are located on one side. They may be posterolateral or anterolateral to the spinal cord. Rarely they are in midline anterior or posterior to the cord. Traditionally, the technique has been a midline exposure and a laminectomy to remove the tumor, and this leads to potential instability for future. Tumors located completely anteriorly are a challenge, and previously I used to do corpectomy to remove these tumors, but now I do by posterior minimally invasive techniques, which I'll show you by a video. Now, this is disheartening to see that such a small neurofibroma done by a multi-level laminectomy here. So, and actually there is no need to do that. I use 18 millimeter fixed dilator for all my tumors. And after exposing the lamina, identify the spinal laminar junction and the facet joint, and then dock it there. So this is done generally a setup in the OR. This is a dorsal lumbar tumor, which I'm doing here. And this is after the docking, the X-ray after the docking. In the cervical spine, the spinous processes are long, so it is not an issue. But in dorsal spine, the spinous processes are very flat. And if you are too oblique, you can go to the opposite side. So one has to be careful about that. And one should always do an AP X-ray to confirm. This is showing the level of the laminotomy depending upon the location of the tumor. And so this is an example of a cervical C7D1 tumor. This is ideally located in posterolateral quadrant. And so these tumors are relatively easy to operate. You open the dura, you dog the tube, drill out the bone, then open the dura. And this tumor it can be decompressed by both by blunt dissection, and I usually use CUSA here. So, but this tumor was fairly straightforward, and it just took 10 minutes to take out. And here I'm decompressing it with CUSA. And as you see, the tumor is out completely, and you can see the cord pulsating. And after that, the dura is closed completely. I use 6-0 nylon to close the dura. I'll just forward it to show. And this is at the end of it. And at the end of the procedure, you just have to take the tube out and just put subcuticular stitches and skin. And this is the post-op MRI, the next day of surgery. You can see this was the trajectory that was taken. There is no residual tumor. The spinous process and facet joints are intact. Now, this was another lady who had a cervicodorsal tumor. She came with mild paraparesis and sensory loss. It was the longest tumor that I had done by tube. It was 5.5 centimeters long. And so we had to do a 2-level hemilaminectomy. We just swiveled the tube up and down and could do it with a small 1.8 centimeter incision. And this tumor was completely anteriorly. It took quite some time to remove it, but we were able to remove it completely. Now, this is another 10-year-old kid I had operated recently. You see there's an irregular tumor and there's significant cord edema there. He presented with quadriparesis. And again, this tumor is also anterior to the cord nearly completely, but slightly more on the right side. So we put the tube on the right side, and this dissection of the muscle, the lamina is exposed. And then you drill out the lamina. Now the dura is exposed, and once you cut the dura, a couple of tacking stitches are applied. And normally, if the tumor is in posterolateral quadrant, the nerve roots don't come into the picture because the tumor has splayed them away from the field. But here, because the tumor was anterior, the nerve roots were all coming in the way, and we had to create a corridor in between the rootlets. So there were 3 different corridors that we created. So this is the lowermost part of the tumor that we are removing. And the CUSA was pretty helpful here in this case. And as you keep on removing the tumor, more and more tumor keeps on coming into the field. And now we are going to the middle corridor, and by blunt and sharp dissection, you will keep on removing the tumor. So I've just played the video at 3 times the speed so as to not waste any time. And so now this is the last bit of the tumor which is being removed. I'll just forward it. And now the tumor removal is complete. You can see the cord is pulsating nicely. The dura is closed completely. And now this is MRI done next day. This is the cut on the patient's back. And the edema is still there, which will take time to subside, but there is no residual tumor. So this was another 10-year-old young girl who had bilateral upper limb pain and right upper limb weakness. And the MRI showed this bilateral disease, which was going through the foramen. And it is again anterior to the cord on both sides. And you can see the disease going into the bilateral neural foramen. And if you see the sagittal view, this bone is involved and there is anterior disease. The radiologist's opinion was that it might be a lymphoma. In a 10-year-old kid, I did not want to do a corpectomy and tumor removal through that approach. So I did a posterior MIS approach. And you can see here. So the tumor was all extradural. So we just kept on removing tumor piecemeal. It was relatively firm as compared to neurofibroma. It turned out to be Ewing sarcoma on histopathology later. And you can see that, so gradually as you keep on removing the tumor, you can remove more and more tumor from the opposite side. And this is at the end of the procedure, you just do the hemostasis. And this is the post-op MRI. You can see that the disease, and this is the trajectory that we had taken. And there was some disease in the foramen, though, which of course, we could not remove from the opposite foramen, but most of the disease was gone. And now she has gone to the oncologist for further treatment. Again, this is an example of a lumbar tumor, which is again a 5-centimeter tumor. And this other one. And these are the post-op MRIs. There's no residual tumor. This was the trajectory of the approach. Again, another large tumor. So what I'm trying to tell you is that the literature suggests that not more than 1.5 or 2 centimeter tumors should be attempted. But I have easily done more than 5 centimeter tumors in many instances. Now our series is pretty big now. And it is the largest series in the world by tubular surgeries. And if there is a doubt, one can always convert into an open procedure. We have done more than 270 cases now. And I had to change my plan once in a very hard calcified meningioma, which was completely stuck. And then I had to do it, convert it into an open procedure. Total number of IDNs operated at the time was more than 250. Cervical were 30 tumors. And there were no complications in any of these cervical cases, while 4 patients in dorsal lumbar tumor developed transient complications. And no patient had a permanent complication. So to conclude, MIS techniques are quite safe and can be used to operate small intradural tumors safely. As the incision is very small, it is more cosmetic and pain is minimal. It preserves the posterior tension band and thus minimizes the integrity of the spine and prevents long-term instability. The hospital stays short, 1 to 2 days, and patients can go back to work within few days. Thank you.
So when we talk about navigation, this is usually what is asked. Who needs navigation? It is too expensive. It will slow me down. I'm doing fine without it, and don't fix what is broken. I don't want to learn a new thing. It is just marketing. There is no benefit, and it is good for new surgeons. So this is how man has evolved. But we should ask ourselves, are we as spine surgeons ready to evolve? This was the earlier days, and now even my 4-year-old son doesn't know how to manually dial a phone. So this is now what technology is all about. 80% of the population suffers from low back pain, and it is a very high demanding for medical expenditure. About $85 billion was spent in US alone. The complication rates are high, including death. Spine surgery with time has been increasing. So this is what traditional spine surgery used to look like. Large and slightly scars, big open wounds during surgery, and this is what everybody wants. that they can just go home with just a band-aid. Then why MIS? So the new definition of MIS by the AOSPINE task force is, it is a suite of technology-dependent techniques and procedures that reduces local operative tissue damage and systemic surgical stress, enabling earlier return to function and striving for better outcomes than the traditional techniques. So this is the MIS benefit zone. So as the complexity of the surgery increases, the benefit of these minimally invasive surgery increases. So where does it work? So with great technology comes great possibility. So this is a case of Kerry Spine, 55-year-old female, 1-year follow-up case, heel tuberculosis, neuro intact but with severe back pain, and we can see there is severe osteoporosis, and you can see that the vertebra is almost gone there. L2, L3 bodies are completely destroyed. This is the CT, you can see the hollowed out vertebra, and the L2, L3 bodies are completely destroyed. Even L1 vertebra has been hollowed out. So this is how the O-arm looks like. This is an intraoperative CT scan. The gantry opens up, goes around the patient, who in this case is under GA. And then the gantry closes around the patient, and a 360-degree X-ray spin is taken, just like a regular CT scan. And this is what we did. Navigated, minimally invasive anterior psoas corpectomy and cage was done. So this is a mini open technique. This is how we are doing the OLIF approach. And first we put the navigation dilator, then navigated trials are there. All the instruments, this is how it looks like under navigation. You can precisely put your hardware where it is required with great accuracy. The navigated screws. And this is the post-op picture. An anterior psoas approach for corpectomy with an expandable cage, and posterior percutaneous cement augmented screws were used. So this is the intraoperative confirmation of the screw placement with the cement, the cage placement, and these are the post-operative scars. So another case, 21-year-old female with a spinopelvic dissociation, type C3U fracture of the sacrum with fracture transfer process of the L5. You can see here, this is the fracture line with bladder and bowel involvement and the left foot drop, and with fat embolism syndrome. So once the fat embolism was settled, we took up this patient again with MIS navigated surgery, and this is the way it looks, the minimally invasive placement of screws and the sacral screws. This is the navigated image, intraoperative, and this is the final picture. You can see that the fracture is reduced beautifully with no need to open. So anybody who has done these kind of surgeries knows that there is a very high risk of wound dehiscence, infection, etc. And these are just the small scars that the patient goes home with. She is walking by second post-op day, and even the foot drop is improving after the reduction of the fracture and indirect decompression of the neural elements there. So when we combine this endoscopy, we can boldly go and do things which are not hitherto imagined. So this is a case of another occipitocervical anomaly, 8-year-old male, neglected, 8 months old at presentation with complete quadriplegia. And you can see on the imaging that the occiput and the C1 are assimilated, and the C2 and C3 are assimilated, and there is subluxation with basilar invagination. This is the cuts, and you can see here. And then the CT angio shows that the vertebral artery is going over the screw insertion points. So if we do this surgery posteriorly, we need to mobilize, and there is high risk of vascular injury. So these are the traditional options: oral odontectomy, Goel-Harms fixation, or the DCR technique. Endoscopic options have been described by transoral excision, transnasal, and transclival transodontoid approach. All these are a little difficult to perform. Tube MIS has been again described, where a specially designed tube is used. So this is how we did this case. The patient was put on the Mayfield, and using the navigated endoscope, we did this. This is the navigation tracker on the endoscope. We did an odontoid resection. So this is a normal approach, anterior cervical, using the endoscope, and we just did the odontoid removal. And then later, this is the post-operative. You can see good decompression there. And then the patient was fixed with this OC fixation because of the anomalous vertebral arteries. So this is the recovery by 20th post-op day. The patient was recovering well. So this is a 2-year follow-up, and now he's back to school doing all his jobs normally. So this has been described again by Dr. Royton and his team, and they have also done a couple of cases. So another case in Carey spine, where we do only conservative for neuro-intact patients or radical surgeries. Are there other options, and can we have a surgical middle path? So this is another case, 15-year-old female with caries of D78, and she presented with paraplegia and a big paravertebral collection and cord compression. This patient was initially planned for decompression and fixation. Then the COVID second wave struck, and we all know how it was in India. There was severe oxygen crisis, and we were not getting clearance for surgery. So, again under OARM guided 3D navigation under local anesthesia, we did a percutaneous endoscopic decompression. You can see the navigated Jamshedi being used to cannulate to the transforaminal approach in the thoracic spine. The pus was aspirated, the guide wire was passed, then the dilator was passed. So this is the dilator being passed, and then this is how it looks like. Again, the navigated endoscope, and this is the decompression. The patient was discharged on AKT, and then she presented after 4 months with complete neurological recovery, and then we did an MIS fixation again. So a big surgery which was planned for a VCR, and we all know how morbid the VCR is. We could get away with just small percutaneous approaches, and the patient was mobilized after fixation. So this is the follow-up at 1 year. So another Carey spine, cervical spine, 36-year-old male, severe right arm radiculopathy. Sorry. So again under local anesthesia, we just give a stab incision. There's a local anesthetic being given. The patient is awake. We palpate the interval between the trachea and the carotid, and then a stab incision. Then dissection again under local anesthesia with a hemostatic artery forceps. Then a blunt dilator is placed, and then under CM guidance again. Then we place the guide wire. The cannula is hammered, and then we use the disc FX system to do this, to grab that fragment and do the discectomy there. So this is done all under local anesthesia, and this is the scar. This is the amount of disc material which was removed. And the patient on table tells immediately about the recovery. So in the technology adoption life cycle, where do we want to be? So when we talk about spine surgery, the first spine surgery ever recorded was in 19th century. The operation was successful, but the patient was dead. The mortality was 100%. In the 20th century, we are talking about morbidity, but in this 21st century now, we are talking about outcomes. So image guidance can assist even the most experienced surgeon. So ask yourself, when your cab driver is now using GPS, why aren't you? Thanks for a patient hearing.
Thank you, Dr. Varun, for such a inspirational talk. Now, can I call upon Dr. Girish Datar? You are giving both things together? Yeah. So you are studying this or this one? Okay. So you are going to make it 20 minutes or? Okay, come. Dr. Girish Datar will talk to us full endoscopic interlaminar decompression of lumbar spine for stenosis, ipsilateral and contralateral. And at the same time, he will continue and teach us how to do full endoscopic interbody fusion.
Good evening, everyone. It's already quite late, so I've tried to wrap it up fast because most of the things have already been spoken. So here I'm not going to show. So here I'm not going to show you the surgery, but talk about a little bit of technical stuff that is used in the posterior endoscopic decompression of stenosis. Now we are all into the aging spine, where we know that there is involvement of bone, there's involvement of ligaments, joints, musculature, and neurological structures. We know that we cannot prevent it, we cannot stop it, nor we can reverse it. But what we can do is to do a decompression wherein we can take off the offending things so that the patient can live a pain-free, active life. So the concept of stenosis has evolved because we need to understand that it is not a single column which is involved, but a three column, which comes from our understanding of the three column concept of Roy Camilli, whereas in the anterior, middle, and the posterior columns all get involved. It is not just the Kirkcaldy-Willis concept of the two column theory, which is the middle column and the anterior column. Even the posterior column gets involved, where things like the Bastrup's condition and overlapping of the spinous processes can cause a lot of problems, and it can also lead to the rotation of the vertebra, which leads to degenerative scoliosis. So it's a combination of two factors. One is the stabilizer and one is the mobilizer. This is the concept of Professor Darwano, where he says that the deformators are the one which are causing the whole problem. And you take off the deformators and the stabilizers can be reactivated with rehabilitation. This makes a lot of sense in degenerative spine rather than fixing them and making them a show dog like 5-level fixation and 8-level fixation. Doesn't really make sense in this old. So decompression and take off the offending thing makes a lot of sense in these kind of patients. So we understand that the pathology, which is dorsal pathology, which is bone lamina, the SAP, IAP, which is rare until and unless the central part of the spinal canal is involved. Ventral pathologies, which include bone, which is end plate osteophytes, calcified or ossified herniations or annulus. Soft tissues like annulus and nucleus. Lateral pathologies like pedicle in scoliosis, which can cause teethering effect on the root itself. Soft tissues like lateral ligamentum flavum and facet skin. There are multiple more. These are few which are commonly seen. So most important thing, we all talk about stenosis. We know what to do in stenosis. But you'll agree with me that docking is as important as the entire decompression, because that tells you how easily you can decompress. So primarily two kinds of dockings. One is a supralaminar docking and an infralaminar docking. You need to understand that the interlaminar window and the window of the discs are not in the same line. At L5S1, sometimes you may have this overlapping with each other, but by and large, the interlaminar windows are much caudal than the actual discal window. So an angle, the major hurdle in endoscopic decompression of stenosis in the early part of your learning curve comes from axis angle, that how do you access a particular kind of a pathology, and the reach. So what is the extent of decompression that you expect or you would want to do in a case of a single segmental stenosis? It is primarily a little up above the tip of the superior articular process to half of the caudal pedicle, after which the nerve starts curving laterally. This can be on the ipsilateral side, and then you can also do it on the contralateral side. So the important is to understand where is the pathology and where do you need to go. The other minor hurdles when you are doing your endoscopic decompression of stenosis lies is tools for bone and soft tissue removal. The exact angle access for bone is important because you need to remove bone. Bleeding is of concern, so you need to also learn all the techniques. As Dr. Lim said, when you have the bone bleeding, how do you do it? There are multiple ways of doing it. So you can also crush it, you can use bone wax. There are so many things that you can do, but control of bleeding is of paramount importance. And identifying intraoperative anatomy. So rehearsing again and again and again that way, what is going to be the structure. So if you know your anatomy pit-pat, you will know the pathology in degenerative spine. If you are unaware of the anatomy and just try to remove bone just because it is seen ahead, you're going to land up into a lot of problems. So doing it again and again is going to be of great importance. So you need to understand now a little bit about angle, reach, access. So I'm not going to show you this surgery. I'm just going to enumerate because it's already been spoken by a lot of speakers. So the most important, two important muscles, what is minimal invasion in spine? Is it the skin incision? Are we really concerned about the skin incision? No. We are concerned about the musculature. We are concerned about the bone. We are concerned about the joint, and we are concerned about the stabilizing structures like ligaments. So using a larger system by putting a small skin incision doesn't mean anything. It is not skin incision which is important at all. So these two important muscles, the longissimus and the multifidus, are the two important muscles which act as a pretension bands in your back. If you destroy it, you may not have an immediate problem, but over a period of time, there is going to be a problem which is related to the surgery. Any problem related to the pathology is understandable, but not related to the surgery. So your surgery should not have any kind of problems later on. So there are basically two docking sites, as I told you. One is a sublaminar docking and a supralaminar docking. When you do a sublaminar docking, the cranial access of your instruments, especially your Kerrison rounger, is limited. Now this is limited because you cannot move your endoscope too much cranially because of the direction and the orientation of the multifidus. Multifidus starts cranially superior, lateral inferior. So going cranially is extremely difficult, but coming caudally is much easier. So if you force it, yes, you will be able to reach it, but then you will destroy a lot of muscle. So access to this area will be extremely difficult, that you will be destroying too much of tissue here. So this is not really minimal invasion. For you to be minimal invasive, the supralaminar docking is easy, where you have a great access. You can go as close as caudal level of the half of the caudal pedicle, and you can reach beyond the tip of SAP, which is actually the area or the segment that you need to decompress. Now, important thing again is how does it make a difference? Why? So if you see here, the first picture here, with the sublaminar docking, your Kerrison rounger, this is the orientation of the lamina. You are getting underneath the cranial lamina tangential. Understand, this cannot remove bone. You will be able to access the bone, but I'll tell you, it is sheer frustration that you cannot remove this. You have to slide or translate cranially to get this bone off, which is again destruction of soft tissues. Whereas, when you have a supralaminar docking, your access to the cranial lamina is perpendicular to the lamina itself. Getting it off is absolutely easy. So you start from the supralaminar docking to get the bone off, and then you can move caudally, which is again perpendicular to the caudal lamina. This is because of the orientation of the lamina itself. So supralaminar docking is superior, and you can practically do a lot of things. Now depends is what kind of a scope do we need? Well, you need to understand all the surgeries are triangulation. UBE is triangulation, which you do it outside. The scope is different, the working channel is different. With uniportal endoscopy, all the triangulation happens in the scope itself. So that depends whether you cannot use a 0-degree scope because you cannot triangulate, because the working channel and the scope portal is both straight. So either 11, 10 degrees, 15 degrees, or 20 degrees. Now, the larger the angle, the more closer inside the canal you can go. The smaller the angle, you have to remain outside, because the triangulation occurs further away from the scope itself. So if you're doing a stenosis surgery, a 10 millimeter scope, you don't want to jam it into the spinal canal because it's already a stenotic canal. So you would use a scope with a smaller angle, 15 degrees and 10 degrees angle, for you to get adequate amount of decompression without compromising too much of resection of joint. So scope has to be tailored for what kind of a surgery you are doing. So there is no such golden rule as I will just use 15 degrees or just 20 degrees. No, you need to have different tools for different kind of problems. Now, technique itself can be divided into 10 different steps. I'm just enumerating the steps because of short of time. I cannot show you the video. Docking, introduction of the dilator in the sleeve, finding the right spinolaminar junction, preparation of the endoscopic window, removal of bone, which is cranial lamina, follow it up with the lateral part, which is the inferior radicular process, going down and identifying the tip of the inferior radicular process, then dipping inside to identify the caudal lamina, and then resection of the caudal lamina and the superior articular process. So you go step by step every time so that you keep memorizing these steps. Don't look at the experienced surgeons. They can start from anywhere and they can finish it up. But as a learner, it is important that we go step by step, take some more time. Don't try to finish in 25, 30 minutes of surgery. Nobody's going to give you a gold medal if you finish in 30 minutes. Take your time and see that you do it properly, because in pathology, especially in degenerative spine, can be sometimes extremely difficult to identify the structures. So doing it safely, doing it step by step is going to be of paramount importance. Once the entire bony decompression is complete, you can proceed ahead with the flavectomy and then ventral decompression if required, or if there is a disc herniation or an osteophyte, end plate osteophyte can be taken off to decompress ventral, dorsal, all the segments of the spinal canal. So additional techniques can be used is inside out technique, wherein you remove the ligamentum flavum in the very early part of the surgery to identify the lateral margin of the dura, so that you can identify the root and the axilla. So this is inside out technique. Outside in is you do all the bony work before you actually remove the ligamentum flavum. Much safer to do it initially because your times are longer, so you don't want to inadvertently push a lot of fluid in the epidural space. As well, gives you a safety margin where you're using a drill or your sharp instruments like an osteotome, that you don't injure the dura. And contralateral foramen is by removing the base of the spinous process and taking it off. So I'm not going to get into the details because this has already been spoken again and again. So let me start with the second topic, which is going to be interbody fusion, which will again cover all these things. So we have only surgical videos here. So I'm going to cut the long story short, where all the techniques have already been spoken. I'm just going to give you a step-by-step review of how an uniportal endoscopic fusion is performed. So posterior lumbar interbody fusion. Now my philosophy of fusion is whatever route I do the decompression. Say for example, it's a pure foraminal compression and I want to do the foraminal decompression. Transforaminally, I would do a transforaminal decompression and a transforaminal fusion. But if it is a bilateral decompression over the top I need to do a central decompression. Then my concept is go interlaminar, do a complete decompression and do a interbody fusion through the same axis route. So for me, decompression route is the fusion route. There is no specific indication or such. So this is a representative case, a 60-year-old male doctor with bilateral thigh lower limb pain, right more than left, claudication of about 50 feet, right more than left again, VAS of 7, right thigh pain VAS 7. Neurology was normal, history of diabetes, hypertension, and a case of CABG. So let's go state by state. Here you can see all the MRI pictures. So let's go step by step. Patient positioning is standard as we do it for any other spine surgery. I do not prefer any lordosis or kyphosis in these patients. So they are in neutral position. Over the bolster, try to see that the chin and the shoulders are comfortable because they are old patients, so they don't end up having a lot of pain post-operatively. So you can bend the knee, flex the knee a little bit and the hip so that it's a comfortable, the hamstrings will relax, because in most of these cases, hamstrings are pretty tight. Most of these cases, I do it under general anesthesia, which is quite comfortable for us. And regional anesthesia can also be used. A combination of epidural and spinal can be used. Image intensifier is absolutely necessary. So we use the true views, no oblique views, AP and lateral. Endoscopic tower. Now I did not tell you what things are there with this. The first important thing is targeting. Now, as rightly said, ECHAP from Indonesia presented his series where he had a lot of subsidence and cases. The problem is that we start off doing endoscopy and then we don't have our docking which is parallel to the disc space. So you have to make an effort to see that your starting point is always parallel to the disc space. This is a small change that you need to make when you are doing a decompression and fusion and when you're doing just a decompression. So just decompression doesn't demand all these things. But if you're doing a fusion, then you need to do your decompression in the same axis so that your cage can go in parallel. This will reduce the amount of end plate injury that it will cause. So it has to be parallel. So always after the AP, check the lateral that you are parallel. So this is how I go. So I'm targeting the space, trying to be absolute parallel to the disc. That is important for me here. So once you do the parallel part of the disc and you access, the first thing that you do is extra spinal clearance. Extra spinal soft tissue clearance is important because that will give you a lot of mobility and that will give you an absolute access into the interlaminar space. This is the plasma generator that we are using, and you start doing it the way you do your decompression, starting from the spinolaminar junction, going all the way, tracing the inferior articular process till you find the tip of the inferior articular process. At the tip of the inferior articular process is going to be the caudal lamina. Second is going to be the cranial laminotomy. So once you identify this, because you need to also harvest bone. So you remove the superficial part of the bone with the help of a burr, but ultimately you need a lot of bone. So you need to use a lot of kerrison punch and osteotome to remove bone. So a little bit of cranial laminotomy going cranially and trace it along. So this burring of the bone helps in two ways. One is it's faster, and second thing, it strips away all the soft tissue from the bone. So your assistant doesn't have to do anything, is just have to make it into small pieces so that you can pack it inside completely. So identify the entire anatomy, define your anatomy, and then starts your cranial laminotomy the way you would do it for a decompression. So step by step, cranial laminotomy using kerrison rongeurs. Try and take small bits. Again, you are reducing the amount of work that your assistant is going to do to trying to piecemeal it. So you get it out piecemeal, it's much easier. It will take 15 minutes more, but then it will save you a lot of other problems. So keep on doing it till you trace off the entire thing. Confirm at every point of time that you are reaching at least the inferior end plate of the cranial vertebra. I prefer personally to retain the part of the inferior articular process over the exiting root. I do not remove that until and unless I put my cage, because then I have to deal with only one root, which is the traversing root. I don't have to think about the exiting root because it is naturally protected by the ligamentum flavum and the part of the inferior articular process in the pars, so that it is covering it completely. So you do your laminotomy till you detach the ligamentum flavum cranially and caudally, and then starts is going to be the osteotomy of the inferior articular process. So identify the inferior articular process and start taking it off piecemeal. It's like bit by bit. So use an osteotome and take off small bits and pieces, remove these bits and pieces. You can remove a larger chunk, then you have to struggle getting that piece out from the endoscopic working channel. So it is better to use the osteotome and remove small bits and pieces again a couple of times till you reach the upper border of the at the level of the inferior end plate of the cranial vertebra, and still have a lot of pars covering the exiting root so that it is naturally protecting the exiting root. So you can see this is the upper part. You can see the curvature of the superior articular process, which is curving out completely. That is the part of the pars which is still there, which is covering the exiting root. So I keep it the way it is till I put my cage inside. Okay. Next is going to be decompression of, or a contralateral decompression. So you go contralaterally. So I'll run this video a little faster. Everybody is eager to go home faster today, early. So this is contralateral. So you reach the base of the spinous process, take off the base of the spinous process, split the ligamentum flavum, and go underneath the lamina to do your sublaminoplasty. What is going to be the differentiation between the superficial and the deep layer of the ligamentum flavum is not the cranial lamina, it is the caudal lamina. Anything that lies above the caudal lamina is superficial layer of ligamentum flavum. Anything lies at the edge and the deeper to the caudal lamina is inferior. So follow the caudal lamina, which goes and continues as a superior articular process. So you can decompress the entire lateral recess and the part of the lamina so that you can decompress the traversing route on the contralateral side. I'll just run this fast. Decompression of ipsilateral, after that you have done that, now you start decompressing the ipsilateral. Now why after the contralateral? Because you don't want the dura to get, the epidural space to get opened. The moment you take off the medial border of the ipsilateral lateral recess, superior articular process, you'll start detaching the deeper layer of ligamentum flavum. So you'll start opening up the ligamentums, the epidural space. So you'll find the part of the SAP. Here you can see the part of the SAP with the curette, trying to just dissect it out to gain access. So once you gain access with your curette, then you can use your Kerrison ronger, start with the smaller Kerrison ronger and go with the Kerrison ronger till you completely remove the part of that. That is the horizontal component of the superior articular process. What is going to be your lateral extent? Your lateral extent is going to be the pedicle, the caudal pedicle. At the level of the foramen, you may go more inside and retain the entire vertical component of SAP. This vertical component of SAP will ensure that all the ligaments which are extrafacetal will all remain intact. That's one. Second, it will avoid a lot of bleeding. So you can finish your surgery really fast, and it is going to be the part of the foramen through where your cage is going to enter through the annulus. So prepare so that you are able to enter inside in such a way with the dimension of the cage, which is usually about 10 millimeters, because when you go inside with your cage, you always go rotated 90 degrees. So you go with the 90-degree rotation, reach the target, and then turn your cage. This will also help in reducing the backout rates so that you are kind of creating a pinch, because the height can vary. But the 10 millimeters is the standard size of the cage that you get. So you are going cranially here, caudal lamina, to decompress. So decompression is the most important thing that we need to do when you are doing a fusion. So you are able to properly decompress it, you are able to probably do a very good fusion. So decompression is going to be the important thing here. I'm not trying to say that fusion is not important, but decompression is more important than what you do for the fusion. So once you're finished with that, this is the part of this is cranial pedicle, caudal pedicle, and this is going to be the area through which you're going to get inside. Now is going to be the removal of the ligamentum flavum. Since caudal lamina, cranial lamina, contralateral, everything is free, you can most of the times remove the ligamentum flavum in one single chunk. But there's nothing that you should remove it in one chunk, but you can also remove it piecemeal. Just always be careful that when you are holding the contralateral ligamentum flavum, turn your endoscope, use the 10 degrees or the 15-degree optics of your endoscope to visualize the undersurface of the ligamentum flavum, that there are no adhesions with the dura. In cases of stenosis, you often find these kind of dural tags, or you'll find kind of adhesions which are there, exactly like this. So you need to go underneath, turn, see, confirm, see this. Confirm that you are not holding anything which is important, and you will safely be able to remove the whole ligamentum flavum to decompress the lateral recess on the opposite side. Now, if you think that there is a grade of listhesis 2 and beyond, you may opt to do a contralateral facetectomy, which you can do it from this side itself. So you don't have to remove the bone, but you just take off the part of the inferior articular process, completely osteotomize it, which can be just a radiologically guided procedure, so that you break it off, so that when you reduce the entire segment, you will have no problems with that. Yeah, nearly finished, sir. So preparation of the cage is as standard as you do it for the MIs. So this is going to be the cage entry side. This is the lateral border. You can see the pedicle at the 3 o'clock, 4 o'clock position. At the 9 o'clock position is the cranial pedicle, still the exiting route intact, which is covered by the part of the pars intraarticularis. So you use the technique beyond this is going to be all standard. So standard discectomy. So I use the curette to remove an angled curette to remove all the end plate cartilage. If you find an osteophyte and if you feel that the surface of the cage will not sit properly on the end plate, I do burr it sometimes so that they have a proper flat fitment of the foot plate of the cage. So next comes is all the morcellated bone graft, and if you think that the bone graft is not sufficient, You may use Cron OS or some substitute along with the bone. You can use marrow. A lot of things can be done. Pack it up completely, and then the cage implantation starts. So you size it, whatever size, a larger size, a little larger size is preferable. And then I prefer to put most of the times a lordotic cage. So here is the cage, here is the dura. So there are 2-3 ways of putting the cage. One is you can use a small retractor to just retract it and then put in the cage. Or you can use a sleeve, which is a little larger size sleeve, which is slit on one side. So the moment you put the cage, it opens up, and then the cage can go inside completely. So after you have done your implantation of the cage, then we'll start the decompression of the exiting route. I'll just run this a little bit ahead. So here you go and you start decompressing the upper part of the foramen. You can see the decompression of the exiting root. So exiting root is very beautifully protected by the ligamentum flavum and the part of the pars here, so that you don't have to really worry about exiting root here. Okay. So the final construct after posterior screw placements is, this is the final construct. You can see nice bone graft in anteriorly and a lordotic cage sitting in, augmented posteriorly by pedicle screws. And these are the final x-rays of the patient before discharge. Thanks a lot for your patient listening.
Thank you, Dr. Girish, for a lovely lecture, very informative. Now, can I call upon Dr. Lav Kush Pandey to give his talk on interlaminar and transforaminal in high iliac crest disc decompressions. After this, I tell them to come and ask these ladies to.
Dr. Rehit Delat, Dr. Mukul Kaushal, and Dr. Murad, please be ready because you're the last speakers of the conference. Dr. Adam, you also please be ready.
Hello. Hello. Good evening, everyone. My talk is on transforaminal versus interlaminar approach in cases with high iliac crest. I'm Dr. Lavkush. I'm practicing in Dehradun, and I run my own center, Samvedna Pain and Spine Center. The percutaneous endoscopic lumbar discectomy for lumbar disc herniation has been established and well-known procedure. Spine surgery and junctional areas has always been challenging in terms of surgical approach. L5S1 level has its challenges for the endoscopic procedures. At L5S1, the available surgical option at L5S1 level, the available surgical options for the disc herniations include generally lumbar discectomy, microendoscopic procedures, suprailiac transforaminal approaches, transiliac transforaminal approaches, and interlaminar endoscopy. While assessing the herniation at L5S1 level, the commonly faced challenges are a high iliac crest, large transverse process of L5, sacral ala, narrow and AP dimension of foramina, considering interpedicular distance and disc inclination due to the lumbar lordosis. Dr. Osman reported a cadaver study on the feasibility of the transiliac approach for L5S1 in 1997, and then concluded that the transiliac approach is a lumbosacral junction is safe. Dr. Osman in his study reported the result of transiliac approach in 15 patients for L5S1 disc pathology, and he concluded that the endoscopic transiliac approach for the L5S1 disc and foramen is feasible and safe. The transiliac approach allows entering into the disc in the line of inclination.
The only disadvantage in the drill is the drilling of the iliac bone, which may lead to increased blood loss, pain, and discomfort in patient post-operatively. Dr. Mahesha chosen 10 patients with variety of L5S1 disc pathology who were treated with endoscopic transiliac surgery under local anesthesia from June 15 to December 2016. And he concluded the endoscopic transiliac approach is safe and effective in lumbosacral pathologies. The transiliac approach removes the limitation of transforaminal approach for L5S1 disc space. There was no radiological classification of the approach and guidelines for the pre-operative assessment and decision making in L5S1 cases. Dr. Prashad, Dr. Girish, and their team presented a paper in 2019, aims to validate a new radiological classification and approach guidelines for the selection of suprailiac or iliac transforaminal approaches for L5S1 space. In his study, he taken the radiographs in AP and lateral dimensions and chosen the few points when the highest point over the iliac crest, 1 point at the lower caudal margin of the spinous process, pedicle, and in lateral approach, there is a line at the level of the L5S1 superior end plate and another line at the base of the pedicle. According to his classification, he divided into type 1, type 2, and type 3 based on the AP and lateral images of lumbosacral area. And according to the studies, they concluded that in which cases we can go transiliac and in which cases that suprailiac approach will be feasible. Dr. Choi in their study described the relation of the iliac crest with L5S1 disc space. In his cases, where the iliac crest is above the mid of the L5 pedicle in lateral radiography, foraminoplasty was considered for the suprailiac transforaminal access for L5S1 disc herniations. Transiliac approach provides a technically easier inline access to L5S1 disc, but the only disadvantages are drilling the iliac bone and bleeding, restriction, maneuverability of rigid endoscope through the transiliac bone window, pain and discomfort of the patient intra and post-operatively. These access problem may limit the ability to carry out an adequate decompression. Interlaminar approach can be useful in L5S1 disc herniation because of larger interlaminar window at L5S1 and the liver little overhang. Upper lamina makes interlaminar approach possible and relatively easy. It has a higher risk of neural injury because of neural structures are encountered before the removal of the disc decompression. Post-operative dysesthesia is quite common if not carried out properly because of it requires a manipulation of traversing nerve root. Interlaminar approach can escape the blockade of iliac crest and offer several advantages like faster puncture and orientation, shorter operative time, and less intraoperative radiation exposures. The interlaminar approach is preferred in cases with axillary type herniations, high migrated disc, central herniations, subarticular herniations, sequestrated dorsally migrated herniations, and concomitant multi-level bilateral lumbal canal stenosis, fixed pelvic obliquity, and previous any iliac deformity. Suprailiac versus transiliac approach. Suprailiac approach, transforaminal approach is indicated for foraminal and extraforaminal disc herniation at the L5S1 level and for the foraminal stenosis cases. Transforamin transiliac approach can be considered in patients with unilateral symptoms having foraminal herniations, stenosis, or paracentral herniations. This case, this patient was a 36-year-old male with no back pain, only the S1 radiculopathy for 2 to 3 months, and you can see in the radiograph, the iliac crest is lying high over the mid of the particular point. So this patient cannot be feasible with a suprailiac approach, so I prefer to do this case. This is a herniation in the right subarticular herniation. So I prefer to do this case transiliac approach. Transiliac approach we generally earlier we were doing at local anesthesia, and now we do in a sensory blocker by putting an epidural catheter and give a sensory block prior to drilling the iliac bone. We go with the K wire, enter into the disc space and ream the progressive reaming of the iliac bone, and then we enter into the disc space and do the decompression. And this patient was a 27-year-old female with back pain, right radiculopathy more than left. Patient was having bilateral symptoms. The right side symptoms were more. Or you can see in the X-ray, the iliac crest is again high at the level of L4-5, and the herniation was little bit of paracentral to medial. So I performed this case interlaminar approach I used. I go from the right side and decompress the disc and relieve the traversing nerve root. All approaches has its pros and cons. Always do pre-operative assessment prior to selection of the technique. Choice of techniques depend on your experience, feasibility, and post-operative management. I prefer interlaminar in L5 cases because of the easy access and advanced optics. Transiliac transforaminal approach is kept reserved for foraminal and extraforaminal pathologies. That I generally do under the sensory blockade. Suprailiac transforamen for foraminal stenosis in type 1 or type 2 high iliac cases. Thank you.
Thank you, Dr. Lavkush. We now have the last session, the session 11 of the Congress. And the first speaker for this will be Dr. Adam.
I will invite everyone to my next cadaveric working course in Dehradun in November under mentorship of Dr. Malcolm in November 14, November 16.
Dr. Adam will talk to us on percutaneous stenoscopic lumbar decompression in two-level lumbar canal stenosis. We missed Dr. Adam as today the rock star of Indonesia.
Take the platform, Adam. Adam, take the platform.
Platform, stand on the platform.
Okay. Assalamualaikum, namaste. I'm going to talk about multi-level PSLD without radiation to surgeon. How do I do it? Thank you for Malcolm sir and Dr. Sameh Mursi Hassan and all the team and participant and all the talk that I cannot explain here. The philosophy and is I take from my Holy Quran, and the life of this world is nothing but play and amusement. And Japanese concept meaning a reason for a being, it is you have to balance love, passion, mission, good at what you're good at, your profession, what you can be paid for, your vocation, our vocation and our need. We have to keep it in balance. So the grand essential to happiness in this life are something to do, something to love, and something to hope for. Concentrating on one thing at a time may be the single most important factor in achieving the flow. We are what we repeatedly do. Excellence then is not an act, but a habit. He who has a why to live for can bear with almost anyhow. This is where am I in PSLD. If my teacher, my mentor, Dr. Malcolm is in the top of the skills, I am still in this level. So it's too far. If you play game online, Mobile Legend or Dota, the rank is too high. But I try to push my rank. What is the problem for a beginner for me? There are 9 ranks. There's target versus time. I can do multiple, but it takes maybe more than 5 hours, 6 hours. There will be trouble. And radiation exposed to surgeon, incomplete decompression, tennis elbow to excessive surgery, low back pain due to lead apron weight, leg cramp due to long time standing, trigger finger or arthritis due to overuse of Garrison, cheap instrument or fancy instrument, and how to push rank. This is the journal that inspired me to do. This is the therapeutic feasibility of multiple decompression. It's like kill 2 birds with 1 stone. And this is the target of the MRI post view. So this I try to aim to do per level for 30 minutes. Now I'm doing 38 minutes per level. So for 3 level, I still go for 100 minutes, not 90 minutes like my senior, my teacher. So the strategic planning, if you want to do multiple, you have to plan where you in, not a standard. PSLD is a translaminar surgery, not interlaminar. So you have to prepare for the next jump. And the strategic planning, you have to draw the landmark and think the incision. You can use a bleed 10 is enough for 7 mm length. And the strategic planning, you have to follow the 1, 2, 3, 4, up and rotating clockwise. And try not to do piecemeal first, but try to keep the ligamentum flavum for dural protection. And this is the multiple level PSLD is multi-radiation. The fact is per year safety up to 50 millisievert. The US Nuclear Regulation Commission has established the standard allow exposure up to 5,000 mrem per year. It is about per spine surgery, maximum 100 spine surgery per year. To reduce cancer risk, a maximum 200 spine surgery per year. Why I say this? Because I have two my senior having lung cancer and also lymphoma, non-Hodgkin lymphoma to excessive C-arm because they're done smoking and they eat very well, but they still have a cancer. So please reduce. Why? And also the evaluation of back pain lead apron, it is 83% versus 37% within who use lead apron and not using. So we treat the patient and at later life we get the back pain also. So we become the patient. No, we have to prevent this. And as I want to tell you all that the lead apron, according to the study, only block 37.1%, not 100%. So your cell is maybe change the DNA, but our cells still repair it. So we're not having cancer, but we have to be careful in our later life. So this is C-arm. It can help me like terrorist. This is a patient, and this is the wall. Lead apron is a Kevlar, and this is surgeon. After having my teacher have a cancer, I never exposed by C-arm anymore. So how do I do it? This is how I use a needle, and you can see this is Son Goku when fighting Ten Shin Han. This is a famous film. He throw the apron back so he can beat the Ten Shin Han because with dropping everything, he can move faster. So his manipulation, his work is better when without leads. This is me. I never operate the endoscopy using lead apron. I always behind this wall, and see, I don't use even collar because I have no apron at all. I avoid the C-arm. And when we will have a track navigation, I have a thinking, how if we don't have Revo track navigation? So I use multiple needle and push it and keep it there and not take it out. So it will reduce me using more C-arm. So I planned it. When I put this, I ask a radiologist to fix. This is the upper end of the compression, lateral end of decompression, so I do not break the pars, and this is the inferior decompression. And for lateral, I try to put the uppermost and lowermost is pedicle to pedicle decompression, so I can avoid incomplete decompression. So this is the endpoint endoscopic. I have to achieve this, and if dural tear, I will mobilize. I presented earlier, and this is epidural using probe. But how if we cannot cauterize? I learned from Dr. Klim, this is KKUK. I don't know what is the meaning, but crushing the bone to stop the bleeding is really work. Okay, without proper self-evaluation, failure is inevitable. So, how about my pre-op and post-op MRI? From these three stenosis, finally I can do it this and this, but still make I fail to decompress contralateral lateral recess. So I have to repaired my skills or refine my skills. For pneumatic carrison can save hand wrist in later life. Such I'm doing now 80 case of PSLD. I don't think if I've done 3,000, I will lead my hand with a trigger finger. Now I have a trigger finger and I afraid of getting surgery. I ask my pain doctor to inject my finger to avoid trigger finger. So they are pneumatic carrison, but they built only for open surgery. I wish that in the future we have a pneumatic carrison for endoscopic surgery. So we need like pressures. So every we push like this, it helps. It's only like a button, and we push like this, it grasps. It grabs, and we can control the power, so it won't bite the dura anymore. And with AI, maybe if it touch the dura, it won't work. So it is a pneumatic carrison with AI. I have a dream. So the problems, the time strategic planning for 3-level, 90 minute, radiation exposed to surgeon, avoid X-ray, go out from OT, evaluate post-op MRI and do better next, rest arm in the seal arm lateral pose to stand, take off lead apron to reduce disc degeneration problem in surgeon, leg cramp, sitting when the officer doing the C-arm, and trigger finger to carrison or arthritic or tennis elbow maybe. You can use a good quality carrison or pneumatic carrison, start cheap and upgrade and improve this with like this course, fellow and join the meeting. Thank you so much. I invite you to Jakarta, 27 to 29 July. Thank you so much.
Then I call upon Dr. Rohit Delat.
Adam, you changed my photograph here. I'm very fat in that. Now put a thinner one.
Good evening. I am Dr. Rohit Delat from Surat, and I'll be basically summarizing what we have learned from today morning. And my topic is tips and tricks of UBE TRIF. I'll be talking same as that of Dr. Girish sir, but in biportal manner. So as we all know that there are various methods by which we can do spine fixation, from PLIF, TLIF, MIS, TLIF, OLIF, open surgeries to endoscopic fixation like transforaminal, stenotic scope, and UBE fusion. As we know that open fixation has obvious disadvantages like back pain, muscle damage, scarring, bleeding, whereas UBE has advantages like it gives similar result as that of open surgeries, but the vision is very good because of illumination, magnification what we get through scope, and we can also do direct decompression of neural structures unlike OLIF. Also, there is advantage of we can put big cage, like unlike transforaminal surgeries, and we can supervise the meticulous end plate preparation. The indication of surgery is disc instability, facet fusion, vertical facets, grade 1, grade 2, listhesis, and recurrent disc herniations. Contraindication being high-grade spondylolisthesis, deformities, and some of the cases in fractures and infection. We can do these surgeries in general anesthesia as well as in epidural anesthesia. Prefer left-sided approach being a right-handed surgeon, but in some cases like right-sided pathologies and in high-grade listhesis, we can also do these surgeries from right side. For planning surgery, we have to square the end plate. lower end plate of upper vertebra and disc to be parallel. We use two portal from left side, cranial being scopic portal and caudal being working portal. Those are 3 centimeter apart. Docking is at spinolamellar junction and at lower part of cranial lamina. For making initial working space, we use semitubular retractor, RF plasma, water pressure, and our primary aim is to see lamina, IAP, and base of spinous process. We have to do laminotomy by starting at the base of spinal laminar junction to reach the cleft of ligamentum flavum using burr. After that, we have to decompress ipsilateral side and remove IAP. We have to use maximum of osteotome and punch so that we can collect more and more of bone grafts, and we can use burr also. After completing the decompression on same side, we will be able to see SAP. After seeing SAP, before removing ligamentum flavum, we have to complete our contralateral work using burr and chisel osteotomes. We can do contralateral facetectomy to release the opposite side so that we can get equal distraction in the disc space. After that, we have to remove the superficial layer of ligamentum flavum. After removing superficial layer of ligamentum flavum, we will decompress the lateral recess by removing medial edge of the SAP and tip of the SAP, keeping ligamentum flavum intact. Cranially and laterally, we have to remove the SAP to see disc and make a space for cage insertion. We have to protect exiting route by not seeing it, just like Datta sir said. Protect traversing route by adequate decompression of SAP and keeping ligamentum flavum intact. For inserting cage, we have to do annulotomy. We use root retractor, we use Indian knife. We can also use radiofrequency ablation using shaver, scoop, and end plates. We have to remove the disc space. We have to remove disc, and we can do it under supervision until the end plate bleeding can be seen. This reduces the chances of end plate fracture and chances of non-union. For inserting bone cage, we have to use the nerve root retractor. We use bone graft using funnel. We may stop fluid so that bone graft does not come back, and we insert the cage. As we insert the cage, we see the ligamentum flavum gets automatically separated from the cranial lamina, and we have to finally do our decompression by removing ligamentum flavum from same side and opposite side. These are the final percutaneous screws. There is a complication which we should know during as a beginner. Those are dural tear, bleeding tendencies, cage subsidence, neural injuries, and there are some fluid-related complications like headache, neck stiffness, seizure, retroperitoneal fluid collections. As a take-home message for beginners, we should remove sufficient SAP, we should sufficiently remove basospinous process and careful end plate preparation. Thank you.
Thank you, Dr. Rohit, for being precise and telling us, giving us tips and tricks. Could I call upon Dr. Mukul Kaushal? He will tell us how arthrospine can help in lumbar fusion using UB procedure.
Thank you, Nicholas sir. Thank you, Malcolm sir, for giving me a platform to present my technique and our technique on arthrospine assisted UB lumbar fusion. So, done, sir, done. I hope better, sir. Okay. So just like any cricket match, when it comes to the end of the innings, the tail enders also have to have a very important role to play. That they have to hit big so that the game and the scorecard ends on a high note. So probably I'll try to do some justice with my talk, sir.
High note on winning side.
Yes, sir. Full screen, thank you. So I'll be talking on this technique of arthrospine assisted UB lumbar fusion. So arthrospine is basically a modification of the distendu system. So to reduce or offset the drawbacks of distendu, we try to reduce the footprint size of the distendu tube. This arthrospine system is can be performed in either a dry or air medium surgery, or you can even use it in a saline medium surgery. And it can be compatible with both a 0-degree or a 30-degree rigid endoscope, which usually is commonly used by both neurosurgeons and orthopedic surgeons. So this is how this is the minimal assembly of this arthrospine system. You need a sheath, a telescope camera. There is a set of serial dilators. The tube is slid over that, and there are two inserts. One is used in a dry medium, one is used in a saline medium. There is a small nerve root retractor if you are planning for a disc or a decompression surgery. So the standard arthroscopy equipments which you use in a joint arthroscopy, like in a knee or a shoulder, like a arthroscopic shaver or a burr or a radio frequency bond, that is compatible with the system. This is the portfolio of the instrumentation systems. Standard Kerrison punches, disc forceps, which is compatible with the system. And for fusion, the standard instrumentation and that instrumentation which is provided by the vendors, that can be used with this system. But right now, this is the flavor, UBE. So this, what I feel is that it provides a very unparalleled instrument mobility, because you basically break the tube. Both your hands are now working independent of each other. And with this arthrospine tube, which we are using frequently, we just use the tube to create another portal, so that we can simplify our UB portal creation, orientation, and triangulation. And once we have created another portal, we remove our tube and convert it into a freehand biportal system. So with this UB, I feel that it is very good to create our end plate preparation, put in our graft, prepare our graft bed, and also helps in a very good cage insertion. So these are small videos, which I hope they play. So this is a bone model demonstration where the tube is docked over the interlaminar window. It is covering the interlaminar window. I give a 11 number stab, use a 11 number knife to give a stab through the skin and the fascia, and through which I introduce a switching stick. It hits the tube, and the tube is used like a sound to railroad and slide this onto the cranial lamina. And once that switching sticks goes over the cranial lamina, over that I introduce my this telescope sheath, introduce my camera, connect everything, and remove the tube. So the tube portal becomes my working portal, and the stab portal becomes my camera portal. So this was a bone model demo, and this is a small video. No, sir, I am trying to play it in such a way so that I can fast forward it also. So serial dilators.
No picture on the screen.
Oh. Huh? Full screen से ही आएगा? ऐसे नहीं आएगा,
Yeah.
Okay.
Go ahead.
Fair enough. So there is serial dilators, skin incision, paramedian 10 to 15 millimeters, serial dilators. Over that the tube is slid. So right now everything is done under a tactile field, and once I connect all my endoscopic camera, under vision I am putting in a couple of cottonoids to expose my cranial lamina. And this is how the picture looks like in a air medium surgery or a dry medium. You put in your cottonoid to expose the cranial lamina. And I'll keep the tube covering my interlaminar window, give a small stab incision through the skin and the fascia. Over this, I'll introduce something which is known for us arthroscopic as a arthroscopic surgeon as a Wissinger rod, or commonly a switching stick. It goes through that skin facial incision, hits the tube, and slides over down onto the cranial lamina. Once it's on the cranial lamina, I just put my arthroscope sheath over that. Still, I'm on the bone. So just like in a UV biportal system, we tend to dance with the dilators to strip off the soft tissues. I put in my scope camera, connect the fluid, turn on the fluid and everything, and remove the tube. And this is how I find it. The patty I also can see that reassures me that I'm on the same level. So I remove this patty and convert it to a biportal system. So this is a small case, a 60-year-old female, low backache with buttock discomfort. She also had a significant component of back pain. The claudication was restricting her to almost a homebound ambulatory state. She had an on-off perianal complaints, but she was continent. There was numbness, paresthesia at rest. Her nerve root tension signs were negative, but she was unable to tiptoe, heel walk, almost going to a kind of a paraparetic state with reduced peripheral jerks. So this is her X-ray. So there is a mobile slip on flexion extension views, and quite tight stenosis, central recess, and bilateral foraminal on the sagittal cuts. So our plan was to do a fusion, and I tend to mark my portals out in a lateral view. I don't usually use an AP view. So if you can see the image on the right hand side, you can see that I'm putting it a spinal needle, and it is going almost along with the upper end plate of the lower vertebra. So that almost I create a portal which is parallel with the disc space. And this I usually tend to create transverse skin incisions. So this incision is given in line with the upper end plate of the caudal vertebra. Through that I dock in my tube, do all my decompression either in dry or saline mode, but when I'm about to start my end plate prep, that is the time when I convert it into a UB system. So once my decompression is done, I use my technique of arthrospine to convert it into a UB system. And for UB fusions, usually I mark the upper cranial incision at the lower edge of the upper pedicle on the ipsilateral side. And that acts as a scopic portal also, and later on when I have to put in my MI screws, it doubles that as a screw insertion portal also. So initially, once I start my disc prep, I open up the annulus, put in a 8 mm smallest shaver trial under CM control, so that I'm not damaging my end plates. And after that, I don't use any shaver. I just do endoscopic visual assisted end plate clearance and serial trialing under CM control. And once the end plates are prepared, usually this is the kind of a vision it affords, that you just remove the cartilaginous end plates, but you preserve the bony end plates, which helps you reduce your cage subsidence rates also. So once that is done, you turn off the saline, put in a funnel, just like in an MIS TLIF or an open TLIF open fusion procedure, and pack it with your autologous bone graft, which is augmented with the bone graft substitutes. And this is usually done under CM guidance after turning off your fluid. But what I found is, in my initial cases, I used to just put in my cage, and I didn't used to make it transfer. So I saw in my follow-up X-ray that some amount of cage backout I was noticing, but the patients were luckily asymptomatic. So I also started making my cages transfers to reduce the chances of backout. So usually the instrumentation which the vendors provide to push in your graft through the funnel, that same thing can be used to just pry your cage into a more transverse position, and under endoscopic control and simultaneously CM assisted control, you can gradually make your cage transverse, so reducing the chances of a cage backout also, and hopefully create a better lordosis, as the cage also goes into the anterior half of the vertebral body. So this is a small video of an endoscopic assisted MIS fusion using this technique of arthrospine and UB. So I'm doing it in a dry medium. Right now I've done a laminotomy on my side. Then I'll do a flavum removal in the center, expose the thecal sac in the midline, do a contralateral decompression. All of this I'm doing in the dry mode because I want to reduce my saline usage. So once I'm done with the lateral decompression on my side and on the ipsilateral side, I do an extended facet resection on my side, almost to the tune of 8 to 10 millimeters, lateral to the lateral border of the root, or the traversing root. And I put in a couple of cottonoids. They also act as a soft tissue and a protector for my thecal sac. And I probe the disc space, go inside, do an annulotomy to open up this disc space window, because the interbody prep has to be more aggressive as compared to a standard discectomy in such cases. And now I switch to the UB technique, because now I can put my camera even further down, and it helps me create a better end plate preparation under a good visual endoscopic control. So you can use n number of instruments. You can use a Kerrison, you can use a curette, you can use those trial shavers which come with the vendor. So usually I put in an 8 millimeter distractor. This is done under both endoscopic and radiological control, so that I'm not injuring my end plates. Radiofrequency probe is a very great help. It can help you coagulate also and clear out the tissues. And once you put your endoscope in, you can see a pretty good vision. You can use angled curettes or angled pen fields to prepare your end plates while preserving your bony end plate. And serial trialing is done afterwards, and whatever cage it fits and looks appropriate on a lateral view, I switch off the saline, put back in my graft, and this is how the graft looks once I turn back my salon on. This is a cage guide root retractor, which helps to guide my cage inside. And this cage is hammered under endoscopic control, and also while looking at in a CM, so that I'm not injuring my end plate. And once the cage is done like this, I tend to make it transverse nowadays. Remove those cottonoids which are helping me protect my neural elements. And then assess the adequacy of my decompression. So that is on the opposite side, that is the opposite side traversing route going from the recess into the opposite side foramen. That is a stable disc on the opposite side. There is no bulge after putting in my cage. And this is the route on my side. After that, I put in percutaneous MIS screws through the same incisions, one above, one below. I usually, in these low-grade slips, I confer to the philosophy of monolateral fixation. This is the kind of footprint you place on the patient's back, and usually they can be mobilized the very next day quite comfortably. Their symptoms are dramatically taken care of. So to conclude, decompression is a very important part of this procedure because the leg pain and the neurological element is taken care of if we do a good neural decompression. If we are able to alongside simultaneously fuse in a good alignment, that takes care of the instability little back pain also. But there's a word of caution, we don't need to fuse everybody, so careful case selection is quite paramount. Thank you for your patient listening.
Thank you, Dr. Mukul, for a wonderful demonstration. Now we have the last speaker of the session, and thank you for your tolerance. Wait, let them sit there only. Dr. Murad, can you come in, please?
Murad, you get your talk ready, sir. Dr. Paudel, Dr. Bipok Paudel, can you please come on the stage, sir? Just let him connect. Just wait 2 minutes. Call all these people on stage. Dr. Rohit Delat, Dr. Laukush Pandey, Dr. Girish Datar, please. Dr. Varun Agarwal, Dr. Bhupesh Patel, Dr. Bhupesh Patel. Fremad. Shodun Fremad. Dr. Mukul Kaushal, please. Are you there with us? Yeah. Where is Dr. Paudel? Sir, please come here. You are the guest handing over. Dr. Varun Agarwal, please. चलता है. Dr. Girish Datar. Dr. Bhupesh Patel.
Dr. Rohit. Dr. Lavkush Pandey. And Dr. Mukul Kaushal.
Thank you very much, all of you. We have our last speaker of the day. So just 5 minutes of more patience. I request you, Dr. Murad Sain, let's hear his story.
Yes. I want to thank you everyone to be here at this time. It was a real honor to be here. It was a great organization, really. I made my talk and I wanted to present a case that was interesting for me. And the next. It was a 71 years old male. He was suggested to have a decompression and instrumentation for leg pain and neurogenic claudication, and he was told that his operation. Huh? That's better. Okay. And he was told that he was operated at another center approximately 6 weeks ago, and he was told that his operation that he couldn't be instrumented because of so much bleeding, and after his surgery he had still neurogenic claudications, but his doctor said that it was the goal that he could reach. Nothing could be done more, and he was looking for a second opinion, and he came to me. I did an MRI, and his neurological examination was okay, but laboratory infection markers were positive, and this was his MRI. And any guess what it could be? He had an L2 to LS1 total laminectomy done, but after the surgery there was a mass that was compromising the thing, and this is the T1 images, and this is the myelography, and this is the myelography video. It was totally blocked. So I plan to make an endoscopic decompression for it. Actually, I told it that it was an infection, and so at that time I just drilled. I wanted to go from the bone. Just to the lateral margin. I checked it with the X-ray, C-arm, and then I found a good way to come in. I just defined the neural structures, and I thought that there was a pseudocapsule of the infection there. I wanted to get rid of that upper part. I just coagulated it and I wanted to get in that. I was waiting some pussy. It was there, and look what is coming out. See that? There was a ghost there. There was a ghost forgotten.
This is a gauze?
Yes. For 6 weeks he was living with this, and the previous surgeon said that he was too old and that could be the final thing that you could have. Luckily he came to me. And it was a total gozectomy. And and this was his post-op MRI. It was totally cleaned, and the follow-up is 18 months. He's okay now, no problem. Okay, thank you very much.
Okay, thank you.
Thank you.
They always say, friends, very few minutes more. All things starts well, ends well, and we are here because of one man vision, and that is Dr. Malcolm. Please give him a big hand. He not only arranged to get all the international faculty that we thank for and grateful for, and the Indian faculty and the delegates, but although he also managed to get the pigs for the cadavers. Thank you. We thank Sister Lizzie and the admin for being with us, supporting us, and helping us all through the planning of the Congress. We thank the dancers for the beautiful dances that we had yesterday. I mean, not yesterday, for the inaugural, yes, dance. We thank the caterers for giving us good food and having good time. And the industry for all the support that is given to us all along the Congress. We also thank the hotel people who have helped us to lodge and board our international and national delegates and faculty. And I hope you all had a good time there. And time is not over. I'm told early morning tomorrow, some of the faculty is going to visit Aurangabad and see Indian culture. We must also thank the theatre people, the theatre staff, the anesthetists who help us to anesthetize the patient, and the caretakers in the wards looking after the patients who were willing to come for these live surgeries.
Can I request all of you all to come here for a small group photograph? One photograph before we leave. Please. Up, down, everywhere. Priyanka, ma'am la patao. And you all also join in, please. Chalo.
I forgot the better half of the Malcolm, who's the lady behind. There she comes. Malcolm, who does all the work, and his team. And I must not forget my department people, all those consultants and the residents who helped us to make the Congress a big success.
Come up here. Come up, buddy. We'll make more space. We'll make more space. Come. Come, sir. Please come. Come right in front. Come. Yeah. All day. We all there, sir. Come. Chalo. Thank you. Something else? One more photograph? Oh, okay, he's still taking video. Guys, please hold your place. Yeah. One. Come on, sir. This is in honor of Dr. Lim. And now we'll do one this way. In honor of Dr. John.